Namaskar and a very good morning to all of you. We welcome you all to day 5 of Appec 2025. Hopefully, the first 4 days, though exhaustive, were academically fruitful for our postgraduate students. So without wasting any further time, let's kickstart today's proceedings. So we are delighted to welcome the chairpersons, the esteemed chairpersons of our first session, Dr. Arvind Khare, sir. Good morning, sir. And Dr. Ganga Prasad, sir.
Good morning.
Very good morning, sir.
Good morning.
So Dr. Arvind Khare, sir, is the medical superintendent and senior professor anesthesia at GLN Medical College, Ajmer. He is a lifetime member of ISA and Pain Society of India. Sir's area of interest is critical care medicine. And our other chairperson for today is Dr. Ganga Prasad, sir. Sir is a professor at All India Institute of Medical Sciences, Delhi. Sir is the head of the department at AIIMS. He is the member of Bureau of Indian Standards for Anesthesia and Allied Equipment. Sir is an MD, DM, and fellowship examiner. He is an examiner for various universities, PGI, and AIIMS. Sir's area of interest is pediatric anesthesia. We welcome you, sir. So the first speaker of the day is Dr. Ashok Kumar Nishad. Sir would be speaking on management of foreign body bronchus. Sir, I would request you to introduce Dr. Ashok, please.
Good morning. I'm Dr. Ashok Nishad. I'm working as Director Professor at ABVIMS and Dr. RML Hospital, Delhi. Am I audible, Neha?
Yes, sir, you are. Sir, yes, please.
So you can stream my lecture, please.
Sure, sir.
Good morning. I'm Dr. Ashok Nishad. This lecture is about management of foreign body bronchus. So foreign body bronchus is one of the emergencies, and at times such foreign body aspiration may prove fatal. These are the emergencies with high morbidity, and these are very common in children up to 15 years, especially the children below 3 years of age. There are preponderance among male children 2:1 as compared to the female. There are other risk groups where these aspiration can happen, like abnormal airways or patients with neuromuscular disease, or poorly protected airways like patients who are alcoholic or sedated, overtly sedated. There are various items that can be aspirated. They can be organic, inorganic, metallic in nature. So these are the commonest foreign bodies that are aspirated. They are groundnuts, green peas, kaju, metallic sharp pins, pin caps, rubber toys, and various wood particles also have been reported. After aspiration, these foreign bodies may settle into the larynx. In around 1 to 5% patients, they can also settle in trachea, around 15%, or they can go into right or left bronchus, mainly the right bronchus, as you know the reasons. It is 60% in the right side of the bronchus and 40% in the left side. The aspiration may be initially asymptomatic, or even, as I said, it can result into sudden death. With symptoms, it may present with cough, and the various phases of aspirations are: in initial phase, there can be choking, coughing because of the airway obstruction. Then there can be a phase of asymptomatic time. It may last from days to weeks. And in chronic cases, when it goes for a longer period, there can be obstruction, atelectasis in the lung, erosion, infection, and abscess. Again, this is the picture of the various foreign bodies that have been aspirated and retrieved from the bronchus. This is again the same picture showing the settlement of the aspirated foreign body, mainly towards the right side of the bronchus, and around 40% cases it may be in the left side of the bronchus. It can be impacted also. Towards left side main bronchus, around 35% times it may get impacted. In right bronchus, it is up to 40%, and it go further down into the left lobar bronchus or right lobar bronchus. It is very important to know when this aspiration happened, because the recent aspiration, they are easy to retrieve with high rate of success without much of complications. Whether if it is delayed, it may result into edema, various other reactions, inflammation. Also important is what has been ingested, as organic materials can swell, can result into further edema and obstruction, partial to complete obstruction. Its size, also the shape, it can be a pronged one that can impact into the mucosa. Where this foreign body which is aspirated gets lost, it may lodge in the upper airways or may go into deeper areas where retrieval becomes difficult. Generally, a single foreign body is aspirated, but at times it has been reported there can be several such foreign bodies of different types even that can be aspirated, or they may get fragmented and lodge into different areas of the thorax. So what are the various signs and symptoms? As I earlier said, it can be even asymptomatic, or it may present with the symptoms of cough, dyspnea, wheezing, decreased air entry, even cyanosis and hoarseness. When there is a suggestive history of aspiration of a foreign body, one must go for the examination, as up to 40% of the cases, the examination may reveal nothing and remains normal. And the signs and symptoms, they depend on the site of the foreign body lodgement. The classic triad of presentation and findings are wheeze, cough, decreased air entry, which is regional, especially towards one side, that is unilateral, along with dyspnea, and there may or may not be sputum that is blood tinged. When it is unilateral, the wheeze and decreased percussion on that side is possible and it shall be looked for. Diagnosis may happen in 50% of the cases in initial 24 hours, in up to 80% in the next 1 week, and it may take years in some of the patients. So how to diagnose it? So depending on the history, the examination, one must try to find the exact diagnosis, location, type of the foreign body that is aspirated. The plain radiograph, that is chest X-ray, is very important. The PA view as well as lateral view, as only 10% of the aspirated foreign bodies are radio opaque, so they are easily picked up on the chest X-ray. But 60% are radiolucent, so they are not easily seen on the plain radiograph. Hence, we rely on the indirect evidences of the obstruction because of the foreign body, that can be seen as hyperinflation of the unilateral lung along with atelectasis or mediastinal shift. Fluoroscopy is another important investigation for radiolucent foreign bodies. If these are not helpful, then one may resort to CT scan or MRI of the thorax, or at times for the ventilation VQ scans, that is helpful in diagnosing the foreign body lodgement. So what is the management of foreign body in the bronchus? I'll be mainly talking of the bronchus, as the topic is given foreign body inside the main bronchus. The gold standard is rigid bronchoscopy, as it has a success rate of around 95%. It helps in allowing the visualization of the impacted foreign body, the easy ventilation, removal of the foreign body, and management in cases when there is mucosal hemorrhage. The complication rate with this technique is low, but at times there can be laryngeal and subglottic edema, atelectasis, or dislodgement of the foreign body that may go further deeper to the dangerous positions. Even at times there are perforations have been noted, and hypoxic insult can also result. Another technique is flexible bronchoscopy, that is mainly for the diagnostic purposes. It has excellent role for the diagnosis with minimal trauma. It can be performed under sedation with local anesthetics, and even it has a role in removal of the foreign bodies which are smaller in size. Coming to the preoperative assessment of these patients, as I already said, it is very important to know when the foreign body aspirated, what was aspirated, where it is lost, and how many they are in number. When it is aspirated is important because it may result into edema, infection, granulation, and if they are recently ingested, they can be easily removed. What is ingested? Again, it is important to know the size, shape, and the material. As organic seeds, they can result into local inflammation and edema, while the other organic material which can swell because of the edema and absorption of the secretions. Where it is lost is again important to decide the method of retrieval. If the foreign body is in the bronchus, say on the right or left side, it is not an immediate emergency, unlike the foreign bodies which are impacting the trachea. Because it is one side, so second side lung is working and patient can tolerate these foreign bodies with discomfort of dyspnea and cough and wheezing. It can be impacted very firmly or maybe loosely lodged inside the main bronchus. Knowing how many are they and confirming it is very important, because at times the children, they can ingest one or more of the coins or other nails, pins, and at times they get fragmented also and need to be removed. It is very important to know the last meal time, as there is high risk of aspiration during such procedures. One must ensure adequate NPO time in these patients. Since foreign body bronchus is not an emergency, we must ensure 6 hours of fasting for the solids and around 2 hours for the liquids. One must weigh the danger of delayed removal against the aspiration risk. Another very important point is the airway patency. Since it is in the one of the bronchus, the patient are generally stable and the retrieval can be done in the elective routine hours of the operation theater. Very rarely they are in distress, requiring urgent bronchoscopy. What are the anesthetic considerations in foreign body retrieval? Since they are causing airway obstruction and we are sharing the airway with the surgeons, there are again further potential for the obstructed airway. It is very important to have very clear communication with the surgeons along with good cooperation. It is imperative to have a detailed anesthetic plan in advance along with surgeon's operative plan that must be communicated between two and arrange the things accordingly. Our concerns are to prevent aspiration of the gastric contents or secretions or blood, ensure the airway patency throughout to ensure proper oxygenation and ventilation. Depth of anesthesia is very important because the surgeons, they position the patient in hyperextension during rigid bronchoscopy. So intense analgesia along with relaxation is very important, and their scopies are done multiple times for retrieval of such foreign bodies to inspect the type, the number, and final removal. So they they go for multiple attempts. What will be the pre-op instruction to the patients? As I already said, NPO must be ensured. A written and explained consent along with the preparation is very important. These patients are at high risk, so high risk consent along with arrangement for the ICU stay as well along with ventilatory arrangement is important, as they require at times brief ventilation inside the ICU. And if things go in another way, patient may require urgent tracheostomy and thoracotomy. For that, it is important to have consent and explain the procedure to the patient in advance. As far as anxiety is concerned, one can use anxiolytic agents, but in minimal doses, as they may impair the respiratory drive of the patient. So half the doses of anxiolytics like midazolam can be used inside operating room. For various pre-medications to address our concerns, it is important to give injection ranitidine along with metoclopramide or ondansetron as anti-aspiration prophylaxis. As anti-sialagogue and bronchodilator, diclofenac in doses of 0.2 mg for adult patient can be given. To settle the existing edema and prevent further edema because of the repeated attempts of bronchoscopy, steroid in the form of dexamethasone or hydrocot shall be used. Bronchodilator nebulization with salbutamol is advised, as there are more chances of bronchospasm intraoperatively because of the instrumentation. For anxiolysis, as I said, half the doses of midazolam along with antihistaminic phenyramine or promethazine can be used. If foreign bodies was ingested a long time back, it is important to continue with the antibiotics. Meticulous monitoring is very important. That's why continuous ECG along with heart rate is monitored, non-invasive blood pressure, oxygen saturation along with end-tidal carbon dioxide is monitored. Temperature, as procedure may last more than 30 minutes, at times 2 hours. So it is better to monitor the temperature also. Other monitoring will be decided as per the specific or patient disease or as per the requirement of the pre-existing condition of the patient. We must be very watchful for the operative site to see what and when it is being retrieved, what type of foreign body it is it causing any hemorrhage, was it impacted, or there is any injury because of the instrumentation. So monitoring along with vigilance is very important. It is important to have our OT table a little head down so that the secretions, blood that are resulting because of the instrumentation, they don't go into the patient and towards the left side or other side of the bronchus. And even if the foreign body gets dropped, because at the time of retrieval, it may slip inside the other side of the bronchus. So keeping head down helps preventing these dropping back of these foreign bodies. Working suction, at least 2 suction ports shall always be ready with suction catheters. What are the anesthetic issues? There are 3 important anesthetic issues. One is what will be the method of induction of anesthesia, whether it will be intravenous or inhalational. What will be mode of ventilation, whether spontaneous or controlled, and how will this anesthesia will be maintained, whether with the inhalational or balanced or total intravenous anesthesia. As far as induction of anesthesia is concerned, both are equally good or have been used, and the superiority of one over the other is debatable. It is said inhalational induction is better for the foreign bodies which are proximally present or lodged as because of the controlled mechanical ventilation or bag mask ventilation during induction of anesthesia, they can shift down towards the main bronchus and may result even the complete obstruction of the airway. But both can be used. My personal experience is I am better with the IV induction of anesthesia. Whatever agent we can use, we must use potent short-acting agents. So propofol, ketamine, thiopentone, sodium, these all can be used. While for the inhalational agent, sevoflurane is best in 100% oxygen. As far as the ventilation goes, we may go for short-acting succinylcholine for airway relaxation and introduction of the rigid bronchoscope. As if the surgeon is very confident the procedure is going to take not more than few minutes, succinylcholine can be used. Otherwise, I think at least till the time of extubation or recovery, it is around 20 to 30 minutes minimum as per my experience and otherwise also. So we must be ready for around 30 minutes of relaxation. So we can go for injection vecuronium or atracurium or other short-acting agent like cisatracurium also. Maintenance again can be with the inhalational agents with sevoflurane in oxygen or intermittent doses of opioids along with atracurium, vecuronium or cisatracurium can be used. Rapid recovery is very important in these patients. If it is a recently ingested foreign body that can be retrieved within few minutes, and patient in that cases can be extubated and shifted to post-anesthesia care unit for further recovery. And if there is long period of instrumentation, at times patient require post-retrieval intubation and a brief period of ICU stay with ventilation. Adequate oxygenation is very important. So whenever possible, use 100% oxygen for pre-oxygenation and with inhalational induction and maintenance. As I already said, intense analgesia and relaxation is important because the surgeons, they use hyperextension position for their repeated bronchoscopy. Deep plane of anesthesia is one of the requirement as it prevents the awareness. There can be otherwise adverse cardiac events. Patient can cough or bark that may result in the injury or dislodgement of the foreign body or delayed removal while the bronchoscope is inside the main bronchus and surgeon is about to perform the picking up of foreign body and its retrieval. If in such points of time, patient coughs or bucks, that can result into injury or perforation of the tracheobronchial tree. So it is important. Inhalational agents when used for such maintenance of anesthesia because of leak of gases, there can be OT pollution and awareness is one of the possibility. So while retrieving the foreign body, there are 3-4 possibilities. The retrieval depends on the type of the foreign body, the expertise of the retrieving surgeon and the available instruments. There can be complete removal in single go, or it may be removed in piecemeal, though entire foreign body can be removed. It can be partial removal with fragmented parts removed and some of the parts may remain inside. In that case, surgeons generally plan for the conservative management and may again replan for retrieval, that is reattempt at a later date. There are incidences when there has been failed attempts at removal of the foreign body. In such cases, it can be dropped even further down at dangerous locations where it can cause lung abscess, and initial conservative management may be followed by thoracotomy in those cases because initial attempt has failed. Rarely, while retrieving the foreign body from one of the bronchuses, there is a chance that during removal, it may cause complete airway obstruction near the carina, especially when the foreign body is large. In those cases, it is important to either pull it out or push it back into the one of the bronchuses so that we can ventilate the another unobstructed lung. So overall, at least we must be ready for a 30 minutes of anesthesia that is controlled and safe as per our plan. We must again emphasize the use of potent and short-acting drugs as well as inhalational agents. Subsequent to our pre-medication, we must adequately pre-oxygenate the patient with 100% oxygen throughout. We may give a little dose of injection midazolam around 0.03 milligram per kg along with any of the opioids, fentanyl or remifentanil. The fentanyl can be given in the dose of 1.5 to 2 microgram per kg. For induction of anesthesia, it can be, as I already told, either can be intravenous or inhalational using sevoflurane in oxygen. Once anesthesia is induced, we must check the bag mask ventilation with low tidal volume breaths. Ventilation, as I said, can remain spontaneous with sevoflurane in oxygen or even the muscle relaxant like vecuronium, etraquirone can be given and it can be controlled. We generally prefer control mode of ventilation for the foreign body bronchus with low tidal volume and little higher rate. When there is no ventilating bronchoscope available with the surgeon, in those cases, intermittent ventilation using the bag mask or intermittently orotracheal intubation is performed while the surgeon in between inserts the rigid bronchoscope for inspection as well as retrieval of the foreign body. When these are not available, especially in children for larger foreign body, manual jet ventilation can be used for the unobstructed lung to ventilate. For maintenance of anesthesia, surgeons do have ventilating bronchoscope, so we can connect our anesthesia circuit to the ventilating port and sevoflurane with oxygen can be given from that along with assisted ventilation, or if we have given relaxant, then we can continue with the mechanical ventilation. Even TIVA, total intravenous anesthesia, in such cases can be given with assisted ventilation. If there is no ventilating bronchoscope, then intermittent bag mask ventilation with 100% oxygen can be given with TIVA. In between the surgeons, they insert their ventilating bronchoscope, and if they are taking long and patient is about to desaturate, they take out the bronchoscope and bag mask ventilation can be continued to increase the oxygenation. With the inhalational, there is a chance of, since we use high gas flow rates for the inhalational anesthesia, there can be inadequate depth of anesthesia along with the OT pollution because of leak around the ventilating bronchoscope. So once the foreign body bronchus is retrieved, we may plan our recovery. When the ventilating bronchoscope is taken out, we must do the gentle laryngoscopy and intubate the trachea with appropriate size endotracheal tube. We must put in a pharyngeal pack initially and continue with the controlled mechanical ventilation. Once we are ensured that there is not much of laryngeal edema or injury, the repeat check laryngoscopy is done, followed by giving the reversal agent in the form of glycopyrrolate along with neostigmine in appropriate doses. When the airway patency is ensured along with the protective airway reflexes, the trachea can be easily extubated with head down position of the OT table, and after recovery can be shifted to post anesthesia care unit. And if we are anticipating or surgeon has taken long time with prolonged handling of the airways with instrumentation, or there is airway edema or injury with any of the cardiac or respiratory adverse events, we must plan for continuous sedation and paralysis without extubation on table. We shall shift the patient to ICU for recovery later. Brief elective ventilation shall be planned with mechanical ventilation, and thereafter, at appropriate time, the trachea shall be extubated. Once trachea is extubated, patient is recovered, he shall be nursed in the post-op area with instruction to keep the patient propped up around 30 to 40 degrees with oxygen inhalation by mask around 4 to 6 liters per minute and NPO for next 6 hours. Normal saline steam inhalation along with ethylene nebulization may be given as there are more chances of bronchospasm. So bronchodilator is one of the requirements in the post-op period. Adequate hydration must be maintained as patient is NPO, so we must give intravenous fluid in appropriate doses. 8 to 12 hourly analgesia in the form of paracetamol or diclofenac sodium or tramadol with antiemetic like ondansetron shall be given to the patient. So what are the complications that are associated with foreign body retrieval? Because of the instrumentation, there are chances of trauma to the lip, dental, tongue, and perioral areas. It may also can result in the airway edema that may cause postoperative stridor, and at times it may require emergency tracheostomy if the airway edema continues to increase. There are chances of laryngospasm also, and definitely bronchospasm chances are very much high in such patients, especially those who have who has ingested a foreign body a long time back. During instrumentation, there are chances of injury to the tracheobronchial tree. Maybe there can be perforation and even rupture to the structure. There are chances of atelectasis with emphysema. Pneumothorax and pneumomediastinum has been reported. Because of the hypoxia, there can be hypoxic brain injury. Hypoxia and other instrumentation may result in dysrhythmia, and at times there has been reports of cardiac arrest. There are more chances of infection in such patients who have ingested the foreign body a long time back. Chances of bleeding is also there because of the injury. And if the rigid bronchoscopy for retrieval failed, patient may be planned for thoracotomy at a later date. And if during retrieval of a large foreign body it drops down, it may cause the complete obstruction above the carina. In that case, it is very important to either take it out as fast as possible or to push it back into any one of the bronchus. So these are the two types of the bronchoscope. That is, one is flexible fiber optic bronchoscope that is only for the diagnostic purposes, with rigid bronchoscope, which is the gold standard practice for the visualization and removal of the foreign body in the bronchus. I have given a link below. We can go through it. It shows how the current rigid ventilating bronchoscopes are assembled, what are their parts, what is the ventilating port, and there are optical forceps available with these ventilating bronchoscope that has made our ventilation and management of anesthesia easy, as well as retrieval of the foreign body. Thank you very much.
Thank you, Dr. Ashok. It was very enlightening talk, though it's overshooted the time. I don't think there are much of postgraduate online. Just for information to the postgraduates, it's a most commonly used, commonly asked question as a long question in the theory, and often in the viva. So in the viva, most of the time you will be asked about the management of hypoxia. It many times occurs when the foreign body is being retrieved or on the process of retrieval. So how to manage the oxygenation. Second thing, the name of the bronchoscope and comparison with the size of tube, endotracheal tube, and compare with the bronchoscope size. So it doesn't match. If the minimum bronchoscope size available is at 2.5, but corresponding tube is around 3.5. Another thing which I missed in this talk about the topical anesthesia. So if patient is in distress, then during spontaneous induction, it should be sprayed with the Xylopard. And introp analgesia I could not see in this Sergio talk, but introp analgesia is also very important during this procedure of the bronchoscope. If any question from the audience online, please, you can ask.
Thank you so much, Ganga sir. Sir, actually the link for the delegates is different. So
Okay,
almost all of them are logged in and they can get the benefits from all the discussion that we had.
I was not
Thank you. Thank you,
So we
Dr.
don't
Ganga
have any
Prasad.
question
Thank you
in
very
the
much.
chat box.
Thank you, Dr. Ashok. You have nicely delivered the lecture of the management of the foreign body of bronchus. As the real problem and issues faced to time the remove the foreign body is very described by the Dr. Ganga. I invite the next lecture for the Dr. Rupesh Yadav for the IRAS.
Hello.
Morning, Dr. Rupesh.
Hello,
Sir, I would
good
like you
morning.
to introduce him. Yes, sir.
Hello, I am Dr. Rupesh, Professor Anesthesiology, ABVIMS, and Dr. RML Hospital, New Delhi. Hello, Ganga sir, Arvind sir. Recently, we meet both of you few days before, and nice to see you again in our own
Nice to
excellent
see you,
academic
Rupesh,
event.
also, and I'm very happy to see you. You are my alumni of the JLN Ajmer. Now the projecting lecture as a professor is a most welcome. Please continue.
Dr. Neha, please speak.
Yes, sir, sure. Can we have the presentation, please?
Hello everyone. I am Dr. Rupesh Yadav, Professor ABVIMS and Dr. RML Hospital, New Delhi. My topic is ERAS, Enhanced Recovery After Surgery. Objectives: ERAS ensure clarity on the fundamentals of protocols, review evidence-based component across the perioperative timeline, and explore what to implement and when. Discuss implementation strategy and performance merits. These able continue quality improvement. Highlight barriers, solution, and future direction to ensure sustained success. Why ERAS matter? Reduce complication and hospital length of stay, improve patient satisfaction and faster return to baseline function, lower cost without compromising safety. ERAS historical perspective originated in colorectal surgery work by Killet et al. These efforts set down the foundation for modern ERAS protocol. Rapid expansion into multiple specialties include orthopedics, gynecology, and urology. Also increased adoption in emergency setting. ERAS Society finalized guidelines. ERAS versus traditional care. ERAS protocolized multimodal and multidisciplinary approach. Traditional care fragmented and reactive. ERAS focus on modifiable risk factor and early mobilization. Traditional model often delay rehabilitation. ERAS emphasis on data-driven continuous improvement. traditional care pathway with limited feedback. ERA's timeline framework: preoperative, intraoperative, and postoperative. Preoperative includes patient education, risk stratification, nutritional optimization, and rehabilitation strategy. Intraoperative focus on anesthesia choice, fluid management, opioid sparing analgesia, and thermal regulation to reduce complication. Postoperative encourage early oral feeding, mobilization, and minimum use of drain and catheter, emphasize real-time audit and feedback loops. Core principle of ERA's centered care built on evidence-based practice. This ensures that intervention on align with patient value and clinical outcome. Multimodal analgesia that minimize opioid reliance, improve recovery, and reduce complications like ALS and delirium. Goal-directed therapy for fluid and hemodynamic management, aid in maintaining organ transfusion without overload. Early nutrition and mobilization, speed of functional recovery, and reduce hospital length of stay. ERA's team. Core members include surgeon, anesthesiologist, nurses, physiotherapists, dietitian, and pharmacist. Collaboration is a key factor. Quality leads, data manager support, audit, tracking, and compliance are also other key factors. Patient and family engagement is essential for adherence and satisfaction. Pre-op patient education. Educate on ERA's goal like pain control, early mobilization, discharge plan. Empower patient through knowledge. Use of brochure, video, and in-person counseling for consistent messaging. Support sharing decision make to enhance compliance and reduce anxiety. Preoperative risk stratification. Use ASA classification, comorbidity index, and frailty scale to assess surgical risk. Screen of obstetric sleep apnea, malnutrition, and other comorbidities. High-risk patient can be identified early and managed promptly. Preoperative rehabilitation focus on physical fitness through aerobic and resistance training, nutritional enhance with adequate protein and caloric intake, psychological support, stop smoking, and alcohol reduction improve surgical readiness. Preoperative anemia and iron management. Early screening of anemia allow timely correction. Start at least 4 to 6 weeks before surgery. Use IV iron, folate, vitamin B12 supplement, or erythropoietin when indicated. Effective management reduce transfusion need and improve oxygen delivery during surgery. Pre-op carbohydrate loading and fasting. Liberalize fasting, clear fluid up to 2 hours and solid up to 6 hours before surgery. Carbohydrate drinks 2 to 3 hours before surgery help reduce insulin resistance and improve metabolic stability. Avoid in patients with gastroparesis and poor controlled diabetes. Intraoperative strategy, use minimal invasive approach when feasible. Prefer short-acting agent to allow faster recovery from anesthesia. Prefer regional anesthesia technique like spinal, epidural, tap block, reduce opioid need, and improve pain control. Implement multimodal approach, combine pharmacology and non-pharmacological strategies for post-operative nausea vomiting. This approach bundles to improve patient comfort. Intraoperative opioid sparing analgesia use combination of acetaminophen, NSAIDs, ketamine, lignocaine, and regional block. Reduce post-operative ileus, nausea, respiratory depression, and delirium. Enhance patient comfort and speed up mobilization. Intraoperative fluid and hemodynamic management. Goal is euvolemia avoid both hypovolemia and fluid overload. Use dynamic index for stroke volume optimization. Prefer balanced crystalloid solutions. Intraoperative temperature and glycemic control. Maintain normothermia with active warming device to reduce surgical site infection. Tight but safe glucose control, reduce risk of infection and poor wound healing. Monitor closely to avoid hypoglycemia and hyperglycemia. Intraoperative, minimizing drain and tube. Avoid routine use of nasogastric tube as they delay return of gut function. Use bladder screening protocol for mainly urine catheter removal. Place surgical drain only when evidence supports benefit. Post-operative, early nutrition. Start oral intake within hour after surgery if tolerate. Use antiemetic strategy and minimal opioid use to support early feeding. Post-operative early mobilization. Encourage patient to sit up and mobilize on day of surgery. Set daily target for time spent out of bed and walking distance. Physiotherapists play a key role in achieving mobilization milestones. Post-operative analgesia. Use non-opioid medication on a scheduled basis. Use regional anesthesia technique post-operatively when possible. Avoid IV PCA unless absolutely necessary to reduce sedation and improve participation in recovery. Post-operative nausea, vomiting, ileus prevention. Risk stratification done by using Alpine score and similar score. Use multimodal prophylaxis including 5-HT3 antagonist, dexamethasone. Encourage early oral intake and chewing gum to stimulate gut mobility. Avoid routine reinsertion of nasogastric tubes. Post-operative thromboprophylaxis and infection prevention. Use risk-based approach for pharmacological prophylaxis along with mechanical methods. Early mobilization and catheter removal reduce infection and thrombotic risk. Continue glucose and temperature monitoring post-operatively. Specialty pathway. Colorectal surgeries. Avoid routine mechanical bowel preparation unless evidence-based indication. Use albumin to reduce ileus duration where available. Favor minimal invasive approach to reduce pain and recovery time. Orthopedic surgery. Prefer spinal with adjuvant local injections. Use Trenexa for bleeding reduction. Discharge plan aim for same day or next day discharge with adequate support. Gynae and oncosurgery. Avoid unnecessary bowel preparation. Start oral intake early. Remove drain catheter promptly. Use tab block or liposomal bupropion for effective analgesia. Merits for clinical outcome. Measure length of stay, complication and readmission. Track time to flatus, stool and ambulation. Monitor transfusion. Merits for patient-centered outcome. Collect patient report outcome measures like quality of recovery, pain score and satisfaction rating. Monitor opioid use post-discharge. Assess time to return to normal activity and work. Implementation roadmap. Formation of multidisciplinary committee. Conduct baseline audit and gap analysis. Choose guideline and tailor it to institutional context. Develop protocols with stakeholder input. Train staff and embed checklist and orders. Audit and feedback. Use real-time dashboard and monthly review meeting. Track compliance by pathway element and department. share transparent data across the care team, change management and culture, identify and empower ERA's champions and early adopters, address myths and barriers with data and stories, celebrate small wins to maintain momentum. Barrier and solution. Variation is practice, manage standardize with order set, too much documentation, manage use electric medical record integrated tools, high staff turnover, manage build continuous education module. Special population frail or elder patients need comprehensive geriatric assessment. Obese and OSA patient benefit from tailored respiratory plan. CKD or liver disease required customized fluid and drug protocols. Future direction and research gap. Personalized ERAs using risk prediction and biomarkers, opioid-free anesthesia pathway, tele-ERAs, and post-discharge remote monitoring. Key takeaways and references. ERAS is a multidisciplinary evidence-based approach, adherence to protocol, improve outcome and efficacy, ongoing audit, and strong leadership are crucial for sustained success. References, ERAS Society Guideline, recent meta-analysis. Thank you.
Excuse me, sir. Ganga, sir, you're muted. Could you please unmute yourself?
Thank you, Dr. Rupesh. It was a very nice, short and sweet lecture on this ERAS protocol. And this is again a very long questions usually comes in this DNB and other MD program. And also it's been asked in this Viva also. So just I want to ask one thing just for benefit of this postgraduate. What are the limitation you have all highlighted, but can you just repeat what this limitation of this ERAS protocol is? Cannot be applied in each and every case, and this mainly designed for this colorectal surgery. So applying this protocol like kind of this cannot fit for all cases. So what are the limitations like fluid restriction and carbohydrate overloading? It's maybe not be beneficial in cases like diabetic or patient of high aspiration risk and obese. Yes, is there any some controversies for this ERAS protocol?
Dr. Could you put some light on that?
Dr. Neha.
Dr. Rupesh, could you listen to Dr. Ganga's comments?
Yes. Sir, specify limitations are one is difficult to control the multiple disciplinary involved in implementation of ERAS protocol, like role of anesthetist specified, like role of surgeon, multiple departments and paramedic departments are involved in this. One is difficult to control all these, and other one is regularly change over staff to train and manage. These are the, I think, most challenging part of with us.
Right, and another thing is it's not a cost effective because this protocol has been developed to reduce the hospital stay.
Yes, sir.
But in our cultural setup, it's
Yes.
very difficult to send someone the next day of the hospital after the surgery. So their apprehension that some problem will occur, what we'll do, and these are the few limitations. And cost
Right, sir.
and the cultural setup of our country is a limitation.
Right, sir.
This is
And
because
And one thing I want to add for the IRAS protocols, that is the one thing, the second is the resistance. Very important.
Right.
Whenever the people are used to have the practice, have to change of the practice, and implementation of practice is very, that is it. So there is with the people of the used to do the IRAS protocol, where if you only want to do change, and some second is the issues are regarding the resources and facilities are available of your institute. It depends on institute to institute also, please also. There is inadequate communication, lack of staff facilities of this, and even the training. And one thing is more important is institutional support. Thank you, Dr. Rupesh. You nicely delivered. Very shortly, it's a very broad topic is IRAS. It's the latest topic, and it's very important for the postgraduate resident. This will come as a question in the fourth paper. Is what is the IRAS protocol? What are the use? What are the limitations? And what is side effect? Okay. Thank you, Dr. Rupesh.
Thank you, sir. Thank you.
thank you, Doctor.
Thank you, Dr. Rupesh. Next, we have Dr. Indu Bala Maurya. She'll be speaking on malignant hyperthermia. So could you please introduce Dr. Indu Bala?
Welcome, Dr. Indu Bala. You are from the Kalyan Singh Super Specialty Cancer Institute from Lucknow. You're the associate professor there. You have taken the lot of the awards. Your field of interest on anesthesia. And one thing I will add for the postgraduate, this is a malignant hyperthermia. It is very repeatedly asked the questions. It's come as a long question. What is the malignant hyperthermia and the causes of malignant hyperthermia and the management and intraoperative management of the malignant hyperthermia and the implication and post-operative issues regarding malignant hyperthermia. Welcome, Dr. Indu Bala. Please continue your topic.
Could we have the lecture, please?
Hello everyone. My topic for my presentation is malignant hyperthermia. In this is the outline of my presentation. After a brief introduction, I will cover pathophysiology, triggers for malignant hyperthermia, its clinical presentation, management, and preventive strategies. Malignant hyperthermia is rare, life-threatening pharmacogenetic hypermetabolic crisis which affects skeletal muscle. It is primarily triggered by volatile anesthetic agents and succinylcholine. Though its incidence varies as per ethnicity, but in general population, as per anesthesia provided, it is 1 in 1 lakh. It has autosomal dominant pattern with variable penetrance. It's with this patient having malignant hyperthermia related genetic defect may not present with malignant hyperthermia. It is more common in males in ratio of 2:1, and 50% of the patient are younger population, less than 19 years. These are the triggers for malignant hyperthermia: volatile anesthetic agent, halothane, sevoflurane, isoflurane, desflurane, and depolarizing muscle relaxant, succinylcholine. Besides this, non-anesthesia condition like stress, heat, and standard exercise, though it's very rare, can present with malignant hyperthermia. Common genetic mutation which causes malignant hyperthermia is mutation is RYR1 gene, which is for ryanodine receptor type 1 on the sarcoplasmic reticulum in the skeletal muscle. And another which is less common is dihydropyridine calcium channel. Though a specific mechanism how trigger factor interact with these abnormal receptor is not known, but in malignant hyperthermia susceptible individual, there is abnormal and excessive opening of ryanodine receptor, which causes uncontrolled release of calcium. This shows normal physiology of muscle contraction. When action potential reaches to muscle membrane, it activated through the T-tubule system, it activates dihydropyridine receptor, which in turn activates ryanodine receptor. There is opening of this receptor causes movement of calcium from sarcoplasmic reticulum to cytoplasm. This calcium binds to troponin, which in activate cross-link between actin and myosin, causing the muscle contraction. Then this calcium is taken up by calcium ATPase back to the sarcoplasmic reticulum, causes a relaxation. But in malignant hypothermia, due to abnormal dihydropyridine receptor and ryanodine receptor, there is a prolonged and abnormal opening leading to release of calcium from sarcoplasmic reticulum to cytoplasm, and this calcium binds to troponin, causes sustained contraction of the muscle and leading to both aerobic and anaerobic metabolism. Just to summarize, calcium overload in skeletal muscle is increased due to mutation, causing to sustain muscular contraction and cellular hypermetabolism, anaerobic metabolism, acidosis, and its clinical sequelae. Clinical feature of malignant hypothermia, though clinical feature varies as in different patients, and even timing for presentation also varies. Some patient may present immediately after trigger factor, or some patient may have presentation up to 24 to 48 hours. Early clinical presentation is the patient will have increase in end-tidal CO2 hypercarbia, which is resistant to increase in minute ventilation. Patient will have fever, hypothermia, or sinus tachycardia. Patient may present with tachypnea. Patient will have rheumatic spasms and line muscle rigidity, sweating. Patient may show features of acute hyperkalemia due to hypermetabolism in skeletal muscle, leading to peaked T wave or arrhythmia. Patients who are not treated or having delayed presentation may have clinical sequelae of rhabdomyolysis, leading to myoglobinuria and DIC. Laboratory finding. These patients may show mixed metabolic or respiratory acidosis, hyperkalemia due to muscle breakdown, elevated creatine kinase or myoglobinuria, and patient may present with DIC due to uncorrected acidosis, rhabdomyolysis, and prolonged hyperthermia. Its diagnosis is always presumptive. Any patient who has clinical features of malignant hyperthermia and who has received triggering agent, regardless of family history or prior uneventful anesthesia, should be considered as a malignant hyperthermia if patient present with unexplained, unexpected increase in end-tidal CO2, unexplained, unexpected increase in heart rate, unexplained, unexpected increase in temperature. We should not wait for any lab test or any confirmatory test during acute event. During acute event of suspected malignant hyperthermia, always call for help. If malignant hyperthermia cart is available, ask for that and inform surgeons to hold the surgical procedure. Discontinue triggering agent. Optimize oxygen and ventilation by increasing FiO2 up to 100%. Increase fresh gas flow more than equal to 10 liters per minute. Increase minute ventilation rate or tidal volume to maximize ventilation and reduce the EtCO2 level. Intubate patient. If patient is not intubated, using non-depolarizing muscle relaxant. Remove vaporizer. If it unable to remove, tape it off in off position. Replace breathing circuit and reservoir bag. Use activated charcoal if available. Use filter both in inspiratory and expiratory limb. During acute crisis, it should be used for 1 hour, but if it is used for prophylactic purpose, it should be used up to 12 hours. Administer dantrolene. Initial dose is 2.5 milligram IV bolus, rapid bolus, and watch for reversal of clinical sign. End-tidal CO2 should fall, come to normalize. If it is not, you should repeat a dantrolene bolus every 5 minutes up to 10 milligram per kg IV. Besides this, send lab investigation for ABG, electrolyte, and serum urine myoglobin, coagulation parameters, including fibrogen and platelet count. If patient is having features of hyperkalemia, showing arrhythmia, potassium level is more than 6 milliequivalent per liter, use a standard treatment protocol for hyperkalemia. Patient with metabolic acidosis with base deficit more than 8 milliequivalent liter, correct with soda bicarb, and follow ACLS protocol for all arrhythmia. But most of the time, arrhythmia is reverted back to sinus if acidosis, hyperkalemia, and hypothermia is treated. If patient's temperature is more than 39 degrees centigrade, use ice packs in axilla and groin. Decrease OT temperature, use hypothermic blanket, iced saline solution, and you can lavage cavities like bladder or gastric cavities with cold saline. Discontinue cooling if temperature reaches to 38 degrees centigrade. Maintain urine output up to 1 to 2 ml per kg per hour using IV fluid and diuretics. If patient is not responding to standard and supportive treatment for malignant hyperthermia, there are few case reports where ECMO has been used for refractory malignant hypothermia. Because these patients have recurrence in 24 to 48 hours, these patients should be admitted to ICU and monitored for the recurrence for rhabdomyolysis DIC. If patient's renal function is deteriorating, dialysis can be considered if indicated. Continue cardiac monitoring. Beside this, continue dantrolene, administer dantrolene at the rate of 1 milligram per kg IV every 4 to 6 hours or 0.25 milligram per kg per hour at least for 24 hours. Injection dantrolene can be stopped if patient is stable for 24 hours, core temperature is less than 38 degrees centigrade, and creatine kinase is not increasing, and there is no incidence of myoglobinuria and muscle rigidity. Patient may suffer complication if treatment is delayed, like DIC, acute renal failure, cardiac arrhythmia, even mortality. Dantrolene is a pale orange color powder, comes in powder form. It has to be reconstituted using saline. It's a direct acting muscle relaxant which acts on ryanodine receptor. It inhibits calcium release from sarcoplasmic reticulum, thus reduces the intracellular calcium concentration. It is said for optimal effect of dantrolene, sufficient magnesium level is required. These are differential diagnoses which can mimic malignant hyperthermia, like anesthesia-related diagnosis like insufficient anesthesia level, hypoventilation, increased CO2 absorption during laparoscopy, fever, thyroid storm, transfusion reaction, pheochromocytoma, neuroleptic malignant syndrome, sepsis, or serotonin syndrome. Patient who has acute crisis, once they have recovered, patient should be sent for confirmatory test, including in vitro contracture test. Most common is caffeine halothane contracture test or in vitro contracture test. And patient and family members should be counseled for genetic testing for gene mutation. To prevent malignant hypothermia, each patient should undergo appropriate preoperative history and examination, including family and anesthesia history, or if patient is having any history or suggestive of malignant hypothermia, avoid triggering agent, use non-triggering anesthetic agents. TY is preferred in these patients. No volatile agent and succinylcholine. Prepare anesthesia workstation, use charcoal filter. Keep malignant hypothermia cart ready with dantrolene, activated charcoal filter, cooling supplies, emergency drug, IV, and IV fluids. This is the flow chart where it shows how how to prepare anesthesia workstation is patient who is susceptible to malignant hypothermia. If you have clean, fresh anesthesia workstation, that can be used. If it is not available and you have sufficient time for preparation, remove all the vaporizer, anesthesia, and change all anesthesia breathing circuit, remove soda lime canister, bags, flush circuit with oxygen, air, and with maximum flow rate. But what time, that has to be anesthesia workstation specific. For this, we have to check for the manufacturer guidance. And once anesthesia workstation is ready to use, do not put on standby mode. Keep maximum fresh gas flow. If you don't have enough time for anesthesia workstation preparation, remove vaporizer, flush the oxygen, flush the circuit with, change the anesthesia breathing circuit and soda lime, and flush the circuit with oxygen, air at least with maximum flow rate at least for 90 seconds. Use activated charcoal, both inspiratory and expiratory limb. And keep anesthesia filter in place Because this is we are using as a prophylactic. Here, an activated charcoal filter can be used up to 12 hours. To prevent this treatable but rare and fatal complication crisis, staff training and malignant hypothermia and cognition and response is required. Patient and family education must be done, and medic alert bracelet is recommended. Just to summarize, malignant hypothermia is life-threatening but treatable condition. Careful pre-op evaluation regarding malignant hypothermia in family and personal history should be recognized, and early recognition and injection dentrolin along with supportive management is the key to successful treatment. No prophylactic dentrolin is recommended. Prevention and preparedness saves lives in malignant hypothermia. These are my references. Thank you for your attention. If you have any question, you may ask.
Thank you, Dr. Indu. I think Dr. Arvind is not around. You have very well elaborated this malignant hypothermia issue. Just for benefit of residents, just I want to ask two things. What is the earliest sign or recognition of this malignant hypothermia intraoperatively?
An increase in temperature and ETCO2 is the earliest.
Right. And dentrolin is commonly used, but what are the side effects of use of dentrolin? Highlight a few of them.
I'm not sure about the side effect.
Only mainly like it has muscle spasticity, hyperkalemia, hepatotoxicity, rashes, nausea, vomiting as usual with any drugs. So these candidates will be asked if they mention the name of dentrolin. Definitely they will ask what preparation is available, commercially available, what dose it is used for emergency cases, and post event dose.
Because, sir, during the crisis, it was very difficult to. This is because of malignant hypothermia or because of dentrolin. So I read that, but I was not able to sure this is how to differentiate between these two.
No, I was just telling that when you recognize the malignant hypothermia, then what dose should be used of dentrolin? I was asking that.
Dose is 2.5 milligram per kg for single bolus.
Dr. Arvind, sir?
Yeah, thank you. This one thing I want to share that the dentrolin is not freely available.
Yes.
It is a limitation of the availability. It's fine as per the theoretical point of view that what is the dose and the side effect, and things fine is so okay. But one thing as for the postgraduate point is you must know how to detect what is it malignant hypothermia and how can you differentiate with the other condition which can increase the end-tidal CO2. The first thing important is the malignant hypothermia. When the patient intraoperative malignant hypothermia detection is very, very important as per the postgraduate point, and how to manage. One thing is the most common management is that first is how to CO2 wash out, and the management of the temperature and the sympathetic outflow is to control. Right, sir? And second thing is that for the malignant hypothermia, it is nowadays very rare. This is very rare complaint. Previously, it was very, very common when we were using the other volatile anesthetic. And now the volatile anesthetic is very safer. And previously the things that causes the malignant hypothermia is not affecting that, but it's very, very important and nicely delivered the lecture. Thank you, Doctor. Most welcome.
Thank you, sir.
Thank you. Nice.
Thank you so much, Dr. Indubala. That was really a good and comprehensive lecture. And with this, we come to the end of the first session of the morning, and we are so grateful and so thankful to Ganga sir and Arvind sir for such good feedbacks, inputs to all the three lectures.
Thank you.
Students would
thank
be
you. Thank you.
benefited.
And they give us the opportunity to deliver the lectures.
Most
And
welcome, sir.
I'm the moderate mind of the Appec 25, and the best wishes for the remaining 2 days for that. Thank you.
Thank you so much, Arvind sir.
I
Thank
must
you,
have
Kamal. Thank you so much.
patient for whole whole week. You are busy from morning till evening. Thank you, doctor.
Thank you. Thank you so much. Thank you, sir. So with this, we come to the next part, the next session of day 5 today, which is a long case. I'm delighted to welcome Dr. Kavita Rani Sharma with us. Good morning, ma'am. Could we have the CV, please? So, ma'am, as we know, ma'am is the Director Professor and Head at the Department of Anesthesiology and Critical Care at Vardhaman Mahavir Medical College and Safdarjung Hospital. Ma'am is the Founder Fellow of Airway Management Foundation. She is an Honorary Fellow Indian Association of Pediatric Anesthesiologists. Ma'am has an ICCRE-TT Fellowship by the UICC. She's completed a project of management of pain in pediatrics at Children's Hospital, Boston, Harvard University. Ma'am is a member of World Congress of Anesthesiologists. She is a fellow, 2004 fellow from there. She's a AHA certified ACLS instructor. Ma'am has publications in various national and international journals and books. She's presented research papers at various forums nationally and internationally, including World Congress of Anesthesiologists 2004, ASA Annual Meet, San Francisco 2007, World Cancer Congress, Geneva 2010. Ma'am's area of interests are pediatric anesthesia, obstetric anesthesia, airway management, and thank you, ma'am. We welcome you. Over to you, ma'am.
Thank you so much. Am I audible?
Yes, ma'am, you are.
Good morning, ma'am.
Morning, ma'am.
Good morning. Good morning. We have Vignesh and we have Priya who are there with us, who will be completing the case presentation. So Vignesh is our postgraduate student. So without wasting any time, we will go ahead. It is a case, long case of PIH, that is pregnancy-induced hypertension. So Vignesh, can we start with the case presentation?
Yes, sure. We have a 35-year-old female who is a resident of Kirtinagar, Delhi, who is a homemaker by occupation and married since 7 years. The patient presented in a routine pre-anesthetic checkup with amenorrhea since 9 months plus 7 days and headache since the last 1 week. And coming to the history of presenting illness, during her routine ANC visit at 34 weeks of gestation, the patient complained of headache. The headache was sudden, throbbing, non-pulsatile, localized to bilateral frontal region, non-radiating, which was aggravated by exertion and partially relieved with rest. It was less responsive to over-the-counter analgesics. The EP measured was 168 by 120 millimeters of mercury, and she was started on BP medications twice daily. The patient doesn't give any history of visual disturbances, photophobia, phonophobia, nausea, vomiting, or seizures, with no history of any raised blood pressure prior to pregnancy. There was no history of any focal neurological deficits, facial deviation, seizures, or slurring of speech, with no history of any visual disturbances, palpitations, syncope, chest pain, dyspnea. There's no history of any periorbital or generalized swelling of the body, and no history of any jaundice, pruritus, bruisability, or petechiae, with no evidence of any hematuria or micturition or flank pain. Coming to the past history, the patient doesn't give any significant past history like any comorbidities like hypertension, diabetes, kidney disease, thyroid disorders, TB, bronchial asthma, or seizure disorders. Coming to the obstetric history, she had a last menstrual period on 12th of November 2025 and expected date of delivery was 8th of August 2025. Coming to the menstrual history, she achieved menarche at 13 years of age and it was a regular 5-day cycle with moderate bleeding. Coming to the obstetric first trimester history, the pregnancy was confirmed by ultrasound guidance after doing urine pregnancy test. She was a booked case in first trimester with no history of excessive nausea, vomiting, fever, or rash or bleeding PV, and no regular medication history except for folic acid. Coming to the second trimester history, she felt the quickening at 6 months. She received 2 doses of TT and calcium tablets were added. At 30th week, she complained to have a headache with elevated BP on antenatal checkup and was started on tab labetalol 100 mg BD. She doesn't give any history of breathlessness, fatigue, drowsiness, abrupt weight gain, or bleeding PV. Coming to the third trimester, it was uneventful. Patient compliant to ongoing medications and routine checkup. She perceived routine fetal movements. No active contractions were present. And 7 days back, she started having a headache again. Coming to the treatment history, she was taking folic acid tablets since first trimester. Iron tablets started since 20 weeks period of gestation. Calcium tablets since 20 weeks period of gestation.
and tab labital 100 mg BD since 34 weeks period of gestation. Coming to the family and personal history, she was a middle class as per socioeconomic status, vegetarian by diet, and normal sleep, bladder, and bowel movements. Coming to examination, on general physical examination, patient was conscious,
Vignesh?
alert, cooperative, and oriented to time.
Vignesh, just hold on. So you have given a detailed history. Let's just summarize. What is her chief complaint?
Ma'am, she was having headache since
Primary gravida.
gravida. Ma'am,
Primary
complained
gravida.
of headache since 34 weeks of gestation.
Yes. And other than that, no significant, any neurological signs are not there, no abdominal pain, no bruisability, no other significant complaints are there. And she is on medication. There is a positive history of taking labetalol ever since she is having these headaches. That is 34 weeks of gestation. She is on antihypertensive labetalol. Fine. And she was asymptomatic. Other than that, she has just
Ma'am, she was
after she took antihypertensive, there was no other significant complaint. But other
Yes,
than
ma'am.
that, she started having for last 1 week, again, the headaches have started coming back.
Yes,
That,
ma'am.
so that is the summary of the history. So a young lady, primary gravida, history of headaches, found to be hypertensive in ANC, regular ANC visits are there, and on antihypertensive, and no other significant history. Other than that, 1 week later, 1 week back, the headaches have come again. So we go with the examination.
Yes. Moving to the examination part. On general physical examination, patient was conscious, alert, cooperative, oriented to time, place, person, lying in left lateral position on the bed. And she was moderate build and weight was 65 kg, height was 158, BMI was 26.03, mild parallel was present, and pedal edema grade 1 was present. There was no history of any clubbing, cyanosis, icterus, lymphadenopathy, or engorged neck veins. She was ephemeral to touch. Pulse rate was 84 per minute, regular good volume with no radioradial or radiofemoral delay, measured in the left radial artery, vessel wall soft on palpation. BP was 134 by 78 millimeters of mercury, measured by auscultatory method on left brachial artery by dial sphygmomanometer in the sitting position after morning dose of labetalol. Respiratory rate was 16 per minute, regular and quiet, and it was thoracoabdominal type. Coming to airway examination. There was no obvious facial deformity was seen, no nasal flaring, mouth opening was adequate 4 centimeters, Mallampati grade was 2. She had a good oral hygiene with no missing or loose tooth or artificial dentures. Upper lip bite test was class 1. Neck range of movement was full flexion and full extension was demonstrated. And thyromental distance in the patient was found to be 7 centimeter. Hyomental distance was measured to be 6.5 centimeter. Sternomental distance was 13 centimeter with no restriction of neck movements. Neck circumference was 37 centimeters at the level of thyroid. Coming to abdominal examination. On inspection, abdomen was uniformly distended with everted umbilicus, with no dilated veins, scars or color change seen locally, stria gravidarum and linea nigra seen. On palpation, there was no local rise of temperature, no swelling, no hepatosplenomegaly. Fundal height was corresponding to 36 weeks of gestation and fetal movements were felt during examination. Coming to Leopold grips, on fundal grip, we could find a hard ballotable mass suggestive of head. On lateral grip, smooth curve suggestive of back towards right, knob-like irregular parts on the left suggestive of limb, and on Pauli grip, smooth mass suggestive of buttocks, and pelvic grip, presenting part was not engaged. Coming to auscultation, bubble sounds were heard and fetal heart sounds was heard, which corresponded to approximately 148 beats per minute. Moving on to systemic examination. Respiratory system examination was within normal limits. Normal on inspection, palpation, normal vocal parameters was present. Percussion was resonant over anterior and posterior wall, and auscultation, bilateral vesicular buzz sounds are heard, with no evidence of added sounds. Coming to the cardiovascular system, there was no precordial bulge, visible pulsation or engorgement of vein, and apical impulse not seen. And palpation, apex beat was felt in the fourth intercostal space in the midclavicular line. No parasternal heave or thriller pulsation in any area, and auscultation S1, S2 heard with no murmur was appreciable. Coming to the central nervous system, with the central nervous system was within the normal limits, higher mental functions was normal, cranial nerves were intact, motor tone and power were intact, sensory power functions were intact, and reflexes were normal. Coming to the investigation part, a complete blood profile was done and CBC showed HP to be 11.1, total count was 5,900, platelet count was 1.4 lakhs. Liver function test was done which showed liver total bilirubin 0.74, AST was 67, ALT 59, total protein was 5 and uric acid 5.5 milligram per deciliter. KFT was urea corresponded to 23, creatinine was 0.89, and urine routine examination showed the presence of albuminuria with 2+, and it showed no evidence of any cast blood or bilirubin. Urinary protein over 24 hours was found to be 345 milligram per day. Urinary protein by creatinine ratio was found to be 0.35. Serum electrolytes was found to be sodium 147 and potassium 3.89. INR was 0.98. Fundus examination done was normal. A 12 DCG showed normal sinus rhythm with heart rate corresponding to 108 per minute. RBS FPS was within normal limits. And some provisional diagnosis of the patient was it's a G1 P0 with 37 weeks period of gestation with a probable diagnosis of preeclampsia without severe features planned for elective cesarean section.
Okay. Thank you, Vignesh. You have made a diagnosis. One, she's planned for elective, that we'll know only when the surgeon send us a call. Other than that, the diagnosis is never planned for cesarean is never in the diagnosis. Fine. So you have made the diagnosis of preeclampsia without severe features. Can you please explain why do we call it pregnancy-induced hypertension or a PIH in this particular case?
Ma'am, a pregnancy-induced hypertension is defined when the hypertension starts in a pregnant female after 20 weeks of gestation. The
Yes.
it should be more than 140 by 90 millimeters of mercury. It should be two subsequent readings should be taken, which should be minimally 4 hours apart in a patient, and should be more than 145 by 90 millimeters of mercury. Ma'am, it can be present. It may present with features of other organ damage also, which should also be evaluated.
So when we say PIH or we say preeclampsia, preeclampsia is just high blood pressure, or there are some other signs and symptoms or investigative features which we should see, which we must see. What are the diagnostic criteria? What other things are there?
Ma'am, preeclampsia will show increased proteinuria in the patient with protein raised urine protein creatinine ratio more than 0.35, and
Yeah.
urine 24-hour urine protein will show more than 300 milligram per over 24 hours.
Okay.
Ma'am, with
Any signs or
added
symptoms also which are important in the diagnostic criteria?
signs and symptoms.
Any presence of any ocular disturbances or
The
decreased
patient complain of
consciousness?
headache, epigastric may complain of a epigastric pain. She may
Yes.
complain of visual disturbances. She may complain of blurring of vision.
So these are all again criteria which we are considered very important, and the presence of which point towards pregnancy-induced hypertension.
Yes, ma'am.
Can we briefly discuss the pathophysiology of pregnancy-induced hypertension? What exactly happens in the body?
Yes, ma'am. Ma'am, actually, placental-induced hypertension is a widespread endothelial dysfunction, which is mainly caused by the abnormal invasion of the placenta. Ma'am, it can be divided into two stages, an asymptomatic first stage followed by a symptomatic second stage. Asymptomatic first stage is basically caused by the abnormal invasion of the myometrial cells, which fail to elevate the constricted arterioles in the pregnant patient, which should ideally be 4 times in a normal pregnant patient, which is not usually happening. Second is usually a symptomatic second stage, which is caused by the abnormal angiogenic factors, particularly caused by SFLT1 soluble endoglin kind of factors, which will actually cause vasoconstriction in the patient with a reduced synthesis of other vasogenic factors like vasoendothelial growth factor will be decreased in the patient. There are multiple theories proposed to it. Other than that, it's an immunologic theory where there may be an elevated levels of NK cells, HLA-C type of cells, and other macrophages are increasing circulation that trigger.
Okay, so that means the problem which is occurring in the uteroplacental blood flow, from there the problem starts and it affects the endothelium at various organs. Yes?
Yes, ma'am.
Vignesh. So if it is affecting, it may affect the CNS, it may affect the liver, it may affect the glomerulus. So Like what happens? The proteinuria is classically called as a diagnostic feature of preeclampsia. Why does proteinuria occur?
Ma'am, actually, the renal capillaries are basically destroyed by this pregnancy-induced hypertension, that is preeclampsia, due to glomerular endotheliosis. The
Yes.
endothelium, when the endothelium gets broken, the large-sized protein molecules are freely filtered through the glomerulus into the capillaries, which fail to get reabsorbed and are eliminated in the urine.
Yes. So the amount of protein which is coming out, and especially when we take it in relation to the creatinine levels in the body, so that is also indicative of how severe is the damage in the endothelium. And so the proteinuria we are trying to quantify also in these patients, and we are trying to assess what is the degree of damage in the body. So that means the pregnancy-induced hypertension, it's not only a uteroplacental problem, but it is a vascular disease which has occurred all over the body, and it is a multi-system disease which is occurring. So now all the systems which are being affected, so they are the ones which are going to produce various signs and symptoms, and thereafter even the complications. And whenever we are treating these patients, all the consequences and the precautions what we are supposed to take depend upon these all damages which have occurred because of that. So now, since there is a hypertension, so there is a vasoconstrictive state which is present in the arterioles. So the patients are relatively, what is the volume status of these patients?
Ma'am, preeclampsia predisposes the patient to hypovolemia with a hypertensive kind of state. So
Yes.
patient will be volume deficit state with the increased systemic vascular resistance.
Yes. So one, they are hypovolemic, and moreover, because of the endothelial damage, the capillaries are also becoming leaky. So that is why when you said like pedal edema means just the edema present in the lower limbs. So that is if the patient is ambulating, so you will find edema in the lower limbs. But other than that, you can also find edema if the patient is lying down. Which area do we check for edema?
Ma'am, usually in the medial side of the shin or tibia
Yes.
is the most common site, or the sacrum, ma'am.
Yes, the sacrum. So does it have a consequence, this edema, for the anesthesiologist? Physically, there is a problem. Technically, there becomes a problem because of this edema. What is
Yes,
that?
ma'am. Sure, there's a ma'am. It creates a problem basically in the airway, ma'am. Airway.
Okay, one in the airway. Then,
Ma'am, second is ma'am, difficulty in ma'am, regional anesthesia. Regional anesthesia.
yes, with pregnancy, nearly full term, with an increased lordosis, if all the tissues are edematous in the back, especially when the patient is lying down, all the skin, the subcutaneous fascia, everything is edematous. So you find it very difficult to appreciate various landmarks. So this edema can be a real challenge for anesthesiologists trying to place a regional block.
Yes,
Okay. So once we have made this diagnosis and you have already done the investigations, you have done, so what are the investigations which are likely to be altered in these patients where we are specifically looking for? You already done all of them. Where
Yes,
all
ma'am.
can be the problems?
Ma'am, patient basically coming to the complete blood count, patient can present with a low platelet because preeclampsia predisposes the patient to widespread platelet consumption. So
Yes.
patient will be predisposed to thrombocytopenia.
Yes.
Ma'am, then coming to ma'am, basic liver function test. Ma'am, there will be deranged liver function test. Basically, SGOT is at least deranged 2 times the normal limit.
What is this syndrome called as? When the
Ma'am.
liver functions start getting deranged?
Ma'am, HELP syndrome.
What is the full form of HELP?
Ma'am, hemolysis, elevated bilirubin with low platelet count.
Elevated, L is elevated liver enzymes and low platelets. Okay. So liver functions we will carefully look at. What are the other investigations which can be faulty?
Ma'am, urine, ma'am, RFT is also
Yes.
getting decreased.
Yes.
Ma'am, increased proteinuria with a raised urine protein creatine ratio more than 0.3, and urinary protein will show traces of albumin, and along with that, patient will show 300 more than 300 milligram of albumin will be excreted over a 24-hour time period.
Okay. That's fine. So if this patient, like in your diagnosis only you have written, this patient comes to us for elective cesarean section, elective or emergency, it can come with both. The patient, like suppose this patient who is well controlled on Levotlor has come for an elective cesarean section. What would be your plan? How do you plan it? The patient is like the patient has come today and the patient is planned for tomorrow morning elective cesarean. So how will you optimize this patient further and how will you take up the patient? What is your plan of anesthesia?
Ma'am, our first primary concern is stabilizing the mother. Ma'am, for which we have to take into consideration the hypervolemic status of the patient. So the hypervolemia in the patient is to be corrected first. Then, ma'am, BP, patient will be having a very high blood pressure. So BP should be optimized.
Okay, this patient is already optimized. So you will just reconfirm that the patient is still optimized. So the first is the blood pressure. You will make
Yes,
sure that medications have been taken, Levotlor has been taken, and your
yes.
blood pressure is okay. How much blood pressure you will accept in the morning of surgery?
Ma'am, ideally, ma'am, less than,
Target pressure.
ma'am, target blood pressure is usually systolic blood pressure should be in the range of, ma'am, 120 to 130 millimeters of mercury, and diastolic BP around 90 to 100 ma'am, less than 90 millimeters of mercury.
So normally we accept easily, we say it is well controlled if it is less than 140 by 90. But
Yes,
in
ma'am.
case the BP is very high and we are trying to give Levotlol and trying to control it, then we may start the case even when the blood pressure is below 160 by 100 or so, we will still take up the case. Will
Yes,
not further delay the case.
Yes,
Okay.
ma'am.
Because what's the treatment of PIH?
Ma'am,
Ultimate treatment.
ma'am, definitive treatment of PH is, ma'am, termination of pregnancy.
Yes, because the pathology has started from there, so we need to terminate the pregnancy, especially if the blood pressure goes very high. What are the indications where the patients come in for emergency cesareans in a case of preeclampsia? Common conditions which we must know.
Ma'am, actually, ma'am, in a fetal compromise situation, ma'am, basically, when the fetal bradycardia is present, or the patient throws herself into a state of maternal compromise, when the patient throws herself into a state of seizure, ma'am.
Okay. The blood
Then,
pressure is not getting controlled, the patient going into HELP syndrome. So the
syndrome.
maternal indications are the first ones. When they are unable to control and if the HELP syndrome starts or the patient starts getting CNS symptoms and the BP is not controlled, then the surgeons would like to terminate the pregnancy for maternal indication irrespective of the period of gestation. While if the patient's BP, they are able to control it, even if it was severe, and they are able to control it by giving medications, then they would like to take the patients up to term that is up to 37 weeks. If it is beyond 37 weeks, then they would like to terminate the pregnancy irrespective of your control station. Patient very well controlled, still they will like to terminate the pregnancy. Okay,
Yes,
and most of the time they would like the patient to go into cesarean section rather than giving her a stress of
No.
the normal labor. Okay, so that is the common thing. What are the common medications we use to control the blood pressure and to control the seizures or prevent the seizures? Just enumerate the medications.
Yes, ma'am. Ma'am, the first line of drugs which we usually use for treating preeclampsia include labetalol, which is a non-selective alpha plus beta blocker. Then second is nifedipine. Third is ma'am, hydralazine.
Okay. And for prevention of seizures,
Ma'am,
or
for
if the patient has already gone into seizures, what do we use?
ma'am, magnesium sulfate is the prophylactic drug which we use for the prevention of seizures. And intraoperatively, if the patient goes into seizures also, we can use magnesium sulfate as a treatment
Okay.
therapy.
For giving magnesium sulfate, what route do we use in case the patient is in a severe state?
Ma'am, usually you prefer the IV route, magnesium sulfate administration by securing a two large bore IV cannulas with adequate fluid administration. Patient should be given 4 gram IV magnesium sulfate over 10 minutes, 15 to 20 minutes, followed by 1 gram per hour IV infusion.
Okay. And this is for what are the disadvantages or the complications which can occur by using magnesium sulfate?
Ma'am, magnesium sulfate is actually, ma'am, it's a proton vasodilator, and it can actually interfere with the neuromuscular blocking agents if we can't take the patient for a general anesthesia. It lowers actually, ma'am, it increases, ma'am, it decreases the urine output of the patient, ma'am. Actually, it can interfere with the urine output of the patient. Then,
So when the patient is on max health, we will keep monitoring three things. One
ma'am.
is the urine
Respir-
output. The second one is
ma'am, respiratory rate and patellar reflex, ma'am.
and the deep tendon reflexes. We usually use the patellar reflex. Okay, but you are giving an intravenous. There could be a problem that you are giving max health more than what was intended. So can it itself cause toxicity?
Sure, ma'am. Yes, it can cause toxicity if we are not continuously monitoring the serum electrolytes level, ma'am.
If the electrolytes go very high, the toxicity, the ranges as the level goes higher. It is also associated with certain signs and symptoms. So that
ma'am.
is why we are monitoring these signs and symptoms. And as the toxicity of the plasma level goes high, we will keep having slowly and slowly further cardiac problems can occur, and ultimately at a very high dose, ultimately a cardiac arrest. So various levels are associated with various levels of toxicity, signs and symptoms. So this is with respect to magnesium sulfate. Once the blood pressure is controlled and the surgeons still have time, it is an elective cesarean, we can still plan. What is your first line of plan of giving anesthesia for cesarean?
Ma'am, the first line of administration of cesarean for the preeclampsia patient is always, ma'am, regional anesthesia.
Okay.
Because, ma'am, general
Okay,
anesthesia.
you are giving regional.
Yes,
Any
ma'am.
problem with regional anesthesia that you tell me, or contraindication where I'll not use regional?
Ma'am, particularly thrombocytopenia, ma'am, in preeclampsia patient.
Okay.
Ma'am,
Thrombocytopenia is only one thing. Other than that?
ma'am, coagulopathy, tendency of a coagulopathy in the patient.
We'll do the INR and we'll try for a coagulopathy. We'll look out for coagulopathy. So anywhere where I feel that putting in a needle can lead to a damage to any of the epidural blood vessels, and I'm scared about an epidural hematoma, I will try and not touch the spine of the patient. Fine. That is the basic thing. Okay. Other than that, what other problem can occur with regional? One, it is technically difficult in an edematous patient. Okay. What happens to the fluid status after giving spinal?
And hypotension is the most common problem following spinal anesthesia. So already patient is having a very hypervolemic state with leaky capillaries. So co-loading may be also not advisable in this patient because the patient may predispose to get pulmonary symptoms like complications like pulmonary edema if we overload the patient too much.
So co-loading is advisable, but not a big preloading. So when we have to give fluid, we are supposed to be very careful, giving it slowly, and along with that. Are these patients more prone for hypertension as compared to the same blood pressure of an essential hypertension, or slightly less or more?
Ma'am, hypertension, ma'am, less prone to hypertension.
Like if another patient of essential hypertension is there with BP of 160, 100, and a patient of PIH is there with the same blood pressure, the patient of PIH may not have that exaggerated fall in blood pressure as compared to an essential hypertension, but definitely it is more than any other normal healthy parturient. So that is there. So what precautions do we take when we are giving a regional anesthesia? And what is the regional? We give spinal, or we try and put an epidural?
Yes, ma'am. Ideally, ma'am, if the platelet count is, we should preliminarily check the total platelet count in the female. It is preferably advised to keep the platelet counts above 1 lakh, ma'am. So more than 1 lakh, we can safely administer regional anesthesia in the patient. So, ma'am, more than, ma'am, between like less than 80,000, ma'am, it's a gray zone. So we preferably try to assess the risk-benefit ratio. Less than 50,000 is mostly we do not administer regional anesthesia in the patient.
Okay. So what we are trying to say is epidural is a thicker needle. A single shot spinal anesthesia given with a thin needle by a neck in expert hands where multiple pokes are not there and the tissues are handled very gently. Like we don't go with the needle and go and hit the posterior longitudinal ligament. Then regional anesthesia remains very, very safe in expert hands. And so PIH can easily be done in a spinal anesthesia, and we can do it. Okay.
Yes, ma'am.
So this patient in the morning, you planned for a spinal anesthesia and getting a cesarean done. So what are the pre-op orders you will put in this patient when she's coming in from the ward to the OT? You'll have to put the orders the night before surgery.
Yes, ma'am.
Enumerate the pre-operative orders.
Ma'am, patient should be, ma'am, kept nil by mouth at least so for solid food 6 hours and for 2 hours for clear fluids, ma'am.
Okay.
With anti-expiration prophylaxis to be given to the patient. Preferably we give H2 blockers injection ranitidine 150 mg followed by ma'am.
Injection 150. Why do you need to inject?
Sorry,
You
ma'am,
are
tablet.
giving oral or injectable?
Ma'am, tablet is preferable.
Huh?
Ma'am, tablet is preferable.
Tablet. And injection is 150 milligram. No, slip of tongue.
Ma'am,
How much
50.
is the injection?
Ma'am, 50.
50. Okay. So as long as the patient is taking orally, we can easily use ranitidine and give it the night before surgery or the morning of surgery. Fine. So fasting guidelines, anti-aspiration prophylaxis. Anything else?
Ma'am,
How to shift the patient? No
ma'am,
fetal distress, nothing.
patient should be shifted in an oxygen trolley, preferably in a left lateral position.
Yes. Why?
Ma'am,
If there are no signs of respiratory distress in a child, in a fetus, like you already said, FHS was normal. In spite of that, would you like to give oxygen to the patient while you're shifting?
ma'am, it is to be on the safer side, ma'am.
To be on the safer side. Are these fetus or these neonates more prone for oxygen deficiency?
Yes, ma'am. Ma'am, because of vasoconstriction, ma'am, placental vasoconstriction is happening. There's a decreased exchange of gases between the mother and fetus are more prone to acidemia and hypoxemia.
Okay, so these fetuses, you must have seen there is a very high incidence of IUGR and low birth weight and delayed development. That is small for date babies in cases of PIH. The fetal development does get affected because of an abnormal placentation which has occurred. So
Yes,
it is always a good idea to give oxygen while you're shifting the patient for a cesarean section, especially if it is an emergency cesarean section. So fluid balance, do not overload, try and shift. What other, you have still left out few pre-op orders.
ma'am,
Think you're putting in the case sheet, then you will always get all of them.
ma'am, written informed consent should be taken and a high-risk consent should be taken prior to pregnancy.
Okay.
And ma'am, since preeclampsia patients are more prone to develop seizures in the intraoperative and the postoperative period, and preferably an ICU with ventilator bed should be kept ready for a backup.
All PIH, do you keep an ICU ventilator bed? We don't.
Ma'am, for a refractory case, hypertensive patient.
This one, this particular patient,
No, we don't need an ICU.
you don't need an ICU bed. You'll be reserving all your ICU beds only for PIH otherwise. Okay, nothing. This patient is well controlled and she's planned for an elective cesarean. Fine. If she was an eclampsia who's throwing seizures and the patient is coming for an emergency cesarean, then we will keep an ICU bed. Otherwise, no. Okay.
Yes.
So other than that, as usual for any other cesarean, we will keep a blood group and cross match done and keep adequate blood available for her. Fine. That's okay. So it is like a routine cesarean which is coming and you are giving. Only thing is technically difficult to give spinal. There is a chance. So we use a thin gauge needle, single shot and in expert hands, and we try and give oxygen. So this is your plan. You'll be doing it. Co-loading occurs and we are careful with the amount of fluid what we are giving. When the patient is lying on the OT table, any specific precautions you will take? After giving spinal you're giving in sitting or in lateral position?
Ma'am, preferably, ma'am, it should be given in lateral because pregnant patients are more prone to, ma'am, supine hypertension syndrome. So,
in sitting position, supine hypertension will not occur.
ma'am, it will happen.
Sitting position, supine hypertension. Supine occurs in supine position.
Yes, ma'am.
Not in sitting position. That is postural hypertension. So if the patient is grossly obese, then it is easier giving the spinal in a sitting position. But in case the patient is normal weight, then lateral position, patient is more comfortable lying down. And if the landmarks can be palpated, the trick is that in case there is a lot of edema on the back, so where you expect, just put with your thumb, just put a continuous pressure on the spinous processes. Just for 1 or 2 minutes, just put pressure at 2 or 3 of the spinous processes in between the center line at the spinous process. And the edema fluid gets displaced. And then you can easily palpate all the landmarks, and then you can go ahead with your spinal. Just displace the edema fluid, nothing else. Okay. And after the spinal has been given, then you turn the patient supine. At that time, what will you take care?
Ma'am,
Make
patient.
supine? Just now
Ma'am,
you said supine hypertension syndrome. Can you prevent?
Yes, ma'am. Ma'am, leftward displacement of the uterus with 15 to 30-degree tilt, ma'am, and placing of a wedge under the right hip will prevent
Hip.
the
Hip,
compression
which is placed under the
right-
hip.
ma'am,
The
right hip.
purpose is that the uterus, the weight of the pregnant uterus does not lie over the major vessels. So we are supposed to provide a wedge, that is the left uterine tilt. Okay, so left uterine tilt, the wedge is supposed, the upper edge of the wedge is supposed to be starting at the upper end of the iliac crest, from there till the mid thigh. Mid thigh. So this all area, the height of the wedge, the size of the wedge is supposed to be from this place to that place, and so much is the height. Roughly a 10 centimeter height will lead to a displacement. If you make it into a wedge shape, it is comfortable, but a raise of roughly 10 centimeters on one side of the table will lead to around 15 degree of the tilt. But make sure it is not only under the hip, it is from the whole of the iliac crest till the mid thigh, so that the wedge is placed and the uterus displacement occurs. So that will more likely not compress the aorta and the inferior vena cava. That's fine. What is your plan for post-operative pain relief in this case?
Ma'am, in the cesarean section with the patient preeclampsia, we prefer transverse abdominal spine block.
Okay. Okay. When you are giving, what are the drug of choice for giving spinal in a PIH patient? What are the common medications you use for giving spinal?
Ma'am, we usually give ma'am bupivacaine 0.5% with additives, as mostly we give fentanyl.
How much of it?
And other additive, ma'am, usually we give ma'am 5 to 10 mics of fentanyl.
Okay. What about levobupivacaine? Any advantages of levobupivacaine over bupivacaine?
Ma'am, levobupivacaine ma'am produces less motor blockade compared to bupivacaine. So,
And ropivacaine? These are the 3 drugs what we use in the present day. So you should be
yes,
able
ma'am.
to differentiate between them. Okay. In case the patient is coming in for an emergency cesarean and you need to, the surgeons have said it is a fetal distress, you plan to give general anesthesia, then what are your concerns as an anesthesiologist?
Ma'am, general anesthesia, coming to general anesthesia, the main concern is the inadequate fasting status, maybe the inadequate fasting status of patient with the tendency for aspiration pneumonia in this patient.
Okay.
So give adequate aspiration prophylaxis to the patient before taking the patient into OT.
That we are doing for all the cesareans. Why only this one?
Yes, ma'am. Ma'am, along with the patient have a difficult airway, risk of a very difficult airway.
What is the difficulty?
Ma'am, difficulty is mainly. Ma'am.
What is so very difficult in this case?
Ma'am, actually, the preeclamptic patient have a very high pharyngeal-laryngeal edema in the patient with a decreased tracheal diameter, and the capillaries are also very friable. So, during an attempt at a laryngoscopy, the patients are more prone to bleed with a very high response to laryngoscopy. That can predispose the patient to a raised hyperensive response, and consequently, patient can develop intracerebral bleed and hemorrhage.
Okay, so how do you prevent all this? What precautions do you take?
Ma'am, ideally, we should go for a rapid sequence induction in this patient with.
That is for all cesareans.
Yes, ma'am.
What is specific in this case?
Ma'am, specific, ma'am, we should give we can give fentanyl to blunt the sympathetic response, like opioids, or esmolol, or labetalol itself antihypertensives can be given 5 to 10 mg.
You use opioids in a PIH patient where the baby is already compromised. How many times have you used? We don't use them. What are the other methods without depressing the child that we can obtain the laryngoscopic response?
Ma'am, antihypertensives can be used, ma'am. Preferably
Esmolol,
labetalol can be used.
Labetalol or
Labetalol,
esmolol. Common ones,
NTG can.
which everyone gives every time. Don't you use a
Ma'am,
preservative-free lignocaine?
Yes, ma'am. Lignocaine.
Xylocard. That's the commonest one which is being used. We try and avoid opioids until it is the BP is so high that you are scared of doing laryngoscopy. But then, you know, the concerns in the fetus will start coming in. The neonate might come out depressed. So we don't do that. Okay. So one, as you said, edema is there, airway edema is there. So try and have a gentle laryngoscopy. The size of the endotracheal tube is one size usually smaller, what we are using, because the tracheal edema might be there. So because of that we'll use a gentle and a quick laryngoscopy can be done. That is with respect to GA. What are the medications? Are there any problem with the medications, what we are using? You said earlier in the part.
Maxelf, the drug which we usually give to for decreasing the hypertensive patient eclampsia seizures in the patient, that itself can prolong the duration of action of the muscle relaxant which we give, particularly the neuromuscular blocker like vecuronium. It prolongs the action.
For rapid sequence induction, what is the choice of drug? What you are planning to use? The muscle relaxant, succinylcholine or rocuronium?
Ma'am, I prefer rocuronium with Sugamadex combination.
Yes. Now that we have Sugamadex available with us, we are avoiding succinylcholine because it further increases the blood pressure and increases the ICP. We already might be having some level of cerebral edema might be there, especially if some symptoms are there. So we try and avoid that. And we can use rocuronium safely now that we have Sugamadex available with us. Okay. And the rest of the precautions remain the same. With you are supposed to use the inhalational anesthetics very judiciously, because exaggerated fall of blood pressure might be there, but more or less isoflurane does a good job, and CO and is present, that also we can use. And the post-op pain, you have already said that the common ones what we are using is the tap block in the present day, especially it is supposed to be an ultrasound guided tap block. Okay, so now I think most of it you have already covered. We go ahead with the presentation by Dr. Priya.
Yes, ma'am.
He needs 15 minutes, around 18 minutes is there, and then we need some time for question answers. So Priya, share your slides.
Ma'am, I'm sharing. Yes, ma'am.
Yes.
Good morning, ma'am. Good morning, everyone. I'm presenting on the topic of anesthesia for pregnancy-induced hypertension. Hypertension is the most common medical disorder of pregnancy, affecting 6 to 10% of the pregnancies and the leading cause of maternal and fetal morbidity and mortality. Now, this is the ACOG classification of hypertensive disorders in pregnancy: gestational hypertension, preeclampsia without severe features, severe preeclampsia. Chronic hypertension with superimposed preeclampsia. Now come to the gestational hypertension. In gestational hypertension, this is a new onset of hypertension, systolic BP greater than equal to 140 mm of Hg, or diastolic BP greater than equal to 90 mm Hg, or both that develops after 20 weeks of gestation. It usually resolves within the 12 weeks postpartum. Now come to the chronic hypertension. Chronic hypertension, systolic BP will be greater than equal to 140 mm Hg, or diastolic BP greater than equal to 90 mm Hg, or both before pregnancy or diagnosed before 20 weeks of gestation, and it is not attributable to the gestational trophoblastic disease. The hypertension may persist beyond 12-week postpartum. Now come to the chronic hypertension with superimposed preeclampsia. In this, there will be new onset of proteinuria greater than equal to 300 mg per 24 hours after 20 weeks of gestation in previously hypertensive patient. Now come to the important topic, that is preeclampsia. In this, the systolic BP will be greater than equal to 140 mmHg or diastolic BP greater than equal to 90 mmHg on 2 occasions or more, at least 4 hours apart after 20 weeks of gestation in a woman with previously normal BP and one or more of the following features. First is proteinuria greater than equal to 300 mg per 24-hour urine collection, or urine protein is to creatinine ratio of greater than equal to 0.3 or dipstick reading of greater than or equal to 2+, or other maternal organ dysfunction that we will discuss later. Now come to the preeclampsia with severe symptoms, with severe features. In this, systolic BP will be greater than equal to 160 mmHg or diastolic BP greater than equal to 110 mmHg. And platelet count will be less than 1 lakh per mm³. There will be renal insufficiency and the serum creatinine level will be raised greater than 1.1 mg per deciliter or twice the baseline. Impaired liver function will be there, elevated liver enzymes to more than twice the normal concentration, and patient may present with severe persistent right upper quadrant pain or epigastric pain. Pulmonary edema might be there, new onset of headache, unresponsive to medication and not accounted for by alternative diagnosis or visual disturbances. These are the risk factor for preeclampsia: advanced age, black race, genetic factors, previous history of preeclampsia, family history of preeclampsia, history of placental abruptio, fetal growth retardation, medical conditions, that is obesity, chronic hypertension, diabetes, chronic renal disease, Epla syndrome, SLE. Obstetric conditions, multiple gestation, hereditary mole, and cigarette smoking is not a risk factor. It reduces the risk of preeclampsia. Partner related factors are nulliparity and limited preconceptional exposure to the paternal sperm. Now come to the pathophysiology. Pathophysiology has already been discussed. It is basically a two-stage disorder. In the first asymptomatic stage, the cytotrophoblast invasion was incomplete and the spiral arteries remain small, constricted, and hyper-responsive to the vasomotor stimuli. There will be failure of normal angiogenesis, which results in superficial placentation, and abnormal placentation will result in decreased placental perfusion, placental infarcts, predispose the fetus to the growth retardation. In the second symptomatic stage, there will be release of anti-angiogenic factors and maternal endothelial dysfunction will be there, and attenuated systemic inflammatory response that will lead to preeclamptic syndrome. Now come to the clinical manifestations of a patient with preeclampsia. In cardiovascular system, there will be increased vascular tone and increased sensitivity to the vasoconstrictor, hypertension will be there, vasospasm, end organ damage, increased BP. There will be a depletion of the intravascular volume due to leaky vessels and vasospasm. In respiratory system, there will be more pharyngolaryngeal edema as compared to the normal parturient, increased risk of pulmonary edema due to decreased oncotic pressure and increased vascular permeability. In CNS system, due to altered brain perfusion, there may be headache, visual abnormalities. In some patients, due to severe systolic hypertension, cerebral hemorrhage might occur, convulsions due to cerebral irritability. And there's Press syndrome, posterior reversible leukoencephalopathy syndrome, in which the autoregulation of the posterior circulation of the brain is hampered. Now come to the hematological system. Most common abnormality is thrombocytopenia, alteration of the coagulation, and patient may land up into DIC and multiple organ failure. In renal system, there will be glomerular capillary endotheliosis, more leaky vessels, more proteinuria will be seen, decreased GFR, and increased uric acid. Oliguria and acute renal failure might seen in patient with preeclampsia with severe symptoms. In hepatic system, there will be periportal hemorrhage, fibrin deposition in the hepatic sinusoids, increase serum transaminases, hepatic edema, right upper quadrant pain may be there. Now come to the eye, there will be retinal arteriolar constriction, retinal detachment or blindness may occur. There is decrease in the uteroplacental circulation by 50 to 70%, which leads to decreased placental perfusion, placental ischemia, infarction, placental abruption, IUG, and fetal loss. These are the complications of severe preeclampsia: maternal complication, antepartum hemorrhage, postpartum hemorrhage, cerebrovascular accident, eclampsia, pulmonary edema, HELLP syndrome, hepatic failure, or renal failure. Fetal complications will be intrauterine growth retardation, preterm birth, intrauterine death can occur. Now come to the principles of management of preeclampsia. The definitive treatment is delivery. The time of delivery will depend on the gestational age, maternal fetal condition, and the severity of the preeclampsia. The BP should be controlled. Patient should start on antihypertensive medication. Anti-seizure prophylaxis should be started. Assessment of airway should be done, and evaluation of the coagulation status should be done. The patient with severe preeclampsia should be hospitalized, and the acute treatment of antihypertension should be started. Optimization of intravascular volume status should be done. Administration of corticosteroid for lung maturity when the POG is less than nearly 34 weeks, and anti-seizure prophylaxis should be started. Now come to when control of hypertension. The treatment is to be started when the BP is greater than by 110 mmHg or greater than 140 by 90 in patient with end organ damage. ACE inhibitors, ARBs, are contraindicated as they cause severe adverse fetal effects. Esmolol is also avoided as it crosses the placenta. There is risk of fetal bradycardia. Atenolol and hydrochlorothiazide to be avoided. Now, the management of non-severe hypertension, oral antihypertensive agents. These are preferred drug is methyl-dopa. Second line agents are labetalol, nifedipine, hydralazine. These will be given by the obstetrician. Now come to the acute control of hypertension. Then labetalol is the drug of choice. It is an alpha and beta blocker. It decreases the maternal SVR without increasing the heart rate. We give 20 mg over 2 minutes. Then then we wait for 10 minutes. If the repeat BP is high, we double the dose. Then we again wait for 10 minutes and double the dose, 80 mg, and wait for 10 minutes. Maximum dose we can give is up to 300 mg, and it is avoided in cases of severe asthma, CHF, heart block, and bradycardia. If the BP is still uncontrolled after giving labetalol, second drug will be hydralazine. Hydralazine is a potent, rapid onset, short duration of action. 5 mg will be given over 2 minutes. Then we will repeat the BP after 20 minutes. The BP is great. If BP is still high, then we can repeat 10 mg IV. Maximum dose of hydralazine can be given is up to 20 mg. Now come to the nifedipine. Nifedipine is a calcium channel blocker. Immediate release of oral nifedipine. We start the dose with 10 mg. We repeat the dose. If the BP is still high, we can repeat the dose after 20 minutes. That is 20 mg. After 20 minutes, if the BP is still high, we can repeat the another dose of nifedipine. That is 2 mg. And the BP is still high, then we can consider IV labetalol 20 mg. In nifedipine, the side effect of nifedipine will be increased maternal heart rate, and the sublingual is not approved by the ACOG. The other second line drugs are nicardipine, nitroglycerin, sodium nitroprusside. Now come to the optimization of intravascular status. We should optimize the fluid status before giving antihypertensive, and judicious hydration should be used in these patients to prevent pulmonary edema. Now come to the seizure prophylaxis. The drug of choice is magnesium sulfate. It should be started with the onset of labor and 24-hour postpartum. For a patient with C-section, it should be started 2 hours before the section till 24-hour postpartum. The mechanism of anticonvulsant effect of magnesium, it reduces the cerebral vasospasm, vasodilatation, and it acts on the central NMDA receptors and raises the seizure threshold. We usually use the Zuspan regime, in which we give IV loading dose of 4 grams slowly over 15 to 20 minutes, followed by 1 to 2 gram per hour infusion. When we give MagSelf infusion, we should consider maternal monitoring of respiratory rate, urine output, and the reflexes. It should be judiciously used in patient with renal insufficiency. It may cause magnesium toxicity as it is eliminated by the renal system. This is the table showing the toxicity of magnesium sulfate. The magnesium sulfate has a narrow therapeutic index, that is 4 to 8 milliequivalent per deciliter. After 5 milliequivalent per deciliter levels in the plasma, there will be ECG changes, prolonged PQ interval, wide QRS complexes. Beyond this level, loss of deep tendon reflexes, patient may land up into respiratory depression, respiratory arrest. Further increase in magnesium level results in conduction defects and cardiac arrest may happen. Whenever there is toxicity of magnesium sulfates, stop the infusion of magnesium and give patient to a calcium gluconate over 10 minutes. If respiratory compromise is there, intubate the patient or mechanical ventilate the patient. Now come to the eclampsia. Eclampsia is the occurrence of generalized convulsions or unexplained coma during pregnancy, labor, or postpartum period in a woman with signs and symptoms of preeclampsia in the absence of epilepsy or other condition predisposing to convulsions. Most commonly, the seizure occur intrapartum or within 48 hours after delivery. Seizures have abrupt onset, tonic-clonic in nature. Now come to the management of eclampsia. It is ABC, airway, breathing, circulation. Turn the patient to the left side and give a jaw thrust to prevent tongue bite. Secure the airway. Give supplemental oxygen to the patient. Attach pulse ox. Secure the IV access. ECG and BP monitoring should be done. If needed, we can give Mexif to the patient, and small doses of barbiturates and benzodiazepine can also be given. Expedite delivery of the baby is done after maternal stabilization. If the seizures are persist or patient is not breathing, RSI can be done and intubation should be performed. Now come to the anesthetic management. Role of anesthesiologist is to provide the liver analgesia, anesthesia for C-section, resuscitation, intensive care management. Now come to the liver analgesia. It is appropriate for women with preeclampsia in the form of continuous epidural or continuous spinal with epidural. Early administration of epidural analgesia attenuates the hypertensive response to pain and avoid GA in even of emergency cesarean section. It reduces the circulating catecholamines and stress-related hormone. In the first stage of labor, the level should be T10 L1, and the second stage sensitivity level required for analgesia is in first stage of labor is T10 to L1 and second stage S2 to S4. Now, pre-anesthetic consideration, condition of the mother should be stabilized, start antihypertensive medication, anti-seizure prophylaxis, difficult airway to be managed, reduce the plasma volume, risk of pulmonary edema, coagulopathy, renal dysfunction, hypoproteinemia, liver dysfunction, and there is increased sensitivity to the neuromuscular blocking agent with magnesium sulfate. Now, these are the investigations that we require in the patient with preeclampsia. First is the CBC with platelet count, and if we are suspecting HELLP syndrome, then we will require peripheral smear. In patient with we require liver function test, including LDH. If we are suspecting HELLP syndrome, renal function test, coagulation profile, urine routine, blood sugar, peripheral blood smear, BGCM to be sent, magnesium level, and fundoscopy, papilledema. If there is an increase, IHCP. Basic monitoring is to be done, non-invasive BP, ECG, pulse ox, capnography, urine output, fetal monitoring, temperature monitoring, and neuromuscular monitoring, as we are using magnesium sulfate with NMBS. Additional parameters, intra-arterial BP monitoring is needed if there is poorly controlled BP or we are using nitroglycerin or sodium nitroprusside. CVP is needed if there is multi-system disorder, that is sepsis, modes, pulmonary edema, cardiomyopathy. Regional anesthesia, neuraxial anesthesia is preferred in patient with preeclampsia as it avoids the disadvantages of general anesthesia in the form of single shot spinal epidural or combined spinal epidural. The patient with severe eclampsia experiences less frequent, less severe hypotension than healthy parturients. Pre-co-loading should be given to the patient with the posted for regional anesthesia. Oxygen should be administered at 6 liters per minute, as we discussed earlier. And the level should be raised up to the level of T4. If there is an hypotension, we can use small doses of vasopressors, phenylephrine 25 to 50 mics IV or ephedrine. Avoid ergot alkaloids. Now the coagulation status with neuraxial block. Neuraxial block can be given when the platelet count is greater than 80,000. When the platelet count less than 50,000, we should avoid neuraxial anesthesia. Between 50 to 80,000, the risk and benefit of the neuraxial anesthesia must be weighed against the risk of general anesthesia. Now, what are the indications of general anesthesia? Coagulopathy in patient with preeclampsia, coagulopathy or severe thrombocytopenia, severe ongoing maternal hemorrhage, pulmonary edema, fetal distress during the emergency LSCS, eclampsia, and patient refusal. Then what are the hazards of general anesthesia? There is a risk of aspiration, upper airway edema, worsening of Mallam putty grading, difficulty in laryngoscopy and intubation, severe hypertensive response to laryngoscopy and intubation can result in intracranial hemorrhage, Maxell therapy interfering with the muscle relaxant. Then how to induce a patient with preeclampsia for GA? First, we give the aspiration prophylaxis. IV lines should be secure. Arterial line placement is indicated in severe preeclampsia patient or uncontrolled hypertension. All vital monitors should be attached. Difficult airway cards should be ready with working suction. All emergency drugs with the general anesthesia, antihypertensive, anticonvulsant drugs. Now pre-oxygenate the patient with 100% oxygen. Rapid sequence induction can be done using propofol at the dose of 2 to 2.8 mg per kg, succinylcholine or rocuronium. To prevent the hypertensive response, these are the drugs we can use. Injection labetalol 5 to 10 mg IV, lignocaine, anti-G, sodium nitroprusside. Intubation should be done with the small size tube. Maintenance is to be done with the nitrous oxide and oxygen. And oxytocin is the drug of choice. Ergotamine ergot alkaloid should not be given. And before extubation response is to be pre-treated with lignocaine or beta blockers. The anticonvulsive therapy should be continue in the post-op period. Now come to the post-operative care. For analgesia, we will give tab block. And now come to the HELP syndrome. HELP syndrome is a variant of severe preeclampsia, hemolysis, elevated liver enzymes, low platelet count. Patient may complain of right upper quadrant pain, nausea, vomiting, hypertension. This is the diagnostic criteria of HELP syndrome. Now the management of HELP syndrome: immediate hospitalization, stabilize the mother, antihypertensive medication, anti-seizure prophylaxis, correction of the coagulation abnormality. Platelet transfusion is needed if there is significant bleeding. If platelet is less than 20,000 or less than 50,000, undergoing the surgery. Thank you.
Okay, thank you, Priya. You have summed up everything, including complications, eclampsia, and the HELP syndrome. So
Yes.
we have 1 hour, 15 minutes was the initial time. So 1 hour is over. So we still have some time for the questions if the organizers say.
Ma'am, we don't have any questions now in the chat box.
So maybe Priya did such a good job that there are no questions left. So fine, we have saved 15
Absolutely,
minutes.
ma'am.
We have saved 15 minutes of yours. That was 15 minutes running late.
No,
Yeah.
Ma'am, we have one question. I'm sending in the
Very
it
chat.
was really a very, very impressive. Yeah.
Okay.
Sure.
Let's have the question, please. Where is the question?
Chat box.
Ma'am, should I read it? Ma'am, I'll read the question. Is it safe to use Sudhir? It has gone. Wait a minute. Ma'am, is it safer to use succinylcholine in pregnancy as a whole, or should it be avoided as much as possible?
See, now that we have Sugammadex available, we can easily use rocuronium. If there is a specific indication that succinylcholine not to be used, especially in hypertensive patients or an increased ICPs there, then we are avoiding succinylcholine. But frankly telling you, we are still using succinylcholine in all the routine general anesthesia. I think that's what is being done at most of the places.
And maybe the reason is because Sugammadex is not available in all the institutes. So maybe
it has started
that could be-
coming. We are having it freely, but still, when we find like there is no gross problem with succinylcholine, we are still using succinylcholine. We try to avoid it in all the raised intracranial pressure cases, or any case where there is a CNS disorder or a known epileptic, or like cases of PIH and all. We are avoiding it.
Right.
Yeah.
Any other questions, Sudhi? I think that's it, ma'am.
Okay.
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 Thank you so much, ma'am. It was really a very inclusive and exhaustive discussion. I don't think there's need of any questions. Every question has been answered already.
So
And-
thank you so much for the organizers, Dr. Neerja, Dr. Namita, for calling us. And
Thank you so much, ma'am, for gracing the occasion.
both the residents have done a good job. They have been working on it for past few days.
Absolutely.
And I hope they have learned a lot during this preparation themselves. Thank you,
Well
everyone.
done, Priya and Vignesh. Thank you. Thank you so much. Thank you.
Thank you.
So with that, before breaking for tea, we would like to have the MCQs for the day. Okay, the first question is, which of the following anesthetic agents is safe in a pregnant patient to know malignant hyperthermia susceptibility? A, halothane, B, isoflurane, C, sevoflurane, and D, nitrous oxide. Question 2, the gold standard for retrieval of foreign body bronchus is A, flexible bronchoscopy, B, Heimlich's maneuver, C, thoracotomy, and D, rigid bronchoscopy. So that's it. With this, we would break for tea, and we'll resume at 11:30 sharp. See you soon. Thank you. Welcome back, all of you. Good morning, Dr. Pradeep, sir.
Okay, good morning.
Just before going on to the next session, the answers to the questions that we had just asked. So, which of the following anesthetic agent is safe in a patient with known malignant hypothermia susceptibilities? So, the answer is nitrous oxide. So, none of the inhalational agents are safe. And the gold standard technique for retrieval of foreign body bronchus is rigid bronchoscopy. Thank you. So going on to our next session, we are delighted to welcome Dr. Pradeep Jain, who's chairing our next session. Good morning, sir.
Thank you. Thank you for inviting me as a chairperson.
So it's an honor to have you amongst us. Sir is the HOD and Director Pain Medicine at Sir Gangaram Hospital. Sir's area of interest are pain management and pediatric anesthesia. So the speaker for the lecture, the topic of the next lecture is labor analgesia. And we have amongst us Dr. Anju Grewal. Good morning, ma'am. So would you please introduce them?
Good morning, everybody. I have the pleasure of introducing Dr. Anju Grewal, who is professor and head of the department at AIIMS Batinda in the Punjab. And her achievements include editor-in-chief anesthesia of the various publications, then the National President Association of Obstetric Anesthesia, India, President-elect, RSACP, and she's the former editor-in-chief of the JOACP. She has been awarded the honorary fellowship of the Obstetric Anesthesia, India, and the Airway Fellowship. And she is the associated editor of the International Journal of Regional Anesthesia, that is IURA, and the editor board member of the Indian Journal of Anesthesia. Her area of interest includes obstetric anesthesia. Of course, she's going to speak on labor analgesia, CPR airway, acute pain management, trauma anesthesia, and she is in totally very professional anesthetist, and she is expert in all the fields of anesthesia. Basically, today she will be speaking on labor analgesia. Dr. Anju Grewal, please.
Thank you so much, Dr. Jain, for such a generous introduction. Pleasure having you as my chairperson.
Thanks.
A very good afternoon, respected chairpersons and dear friends. At the outset, I take this opportunity to thank the organizers of Appec 2024, especially Dr. Neerja, for giving me this opportunity to talk to you on labor analgesia. Now, we all know that childbirth is a natural phenomenon, and hence this question has been arising in the minds of all since centuries, that do we really need to relieve this pain? If you look at the severity of labor pain on the McGill Pain Index, it has been found to be equivalent to the pain experienced on digit amputation, high up on the red part. So we all know that how severe the pain could be. In addition to that, it leads to increase in circulatory catecholamines, increase in maternal cardiac output, oxygen consumption, hyperventilation, resulting in a decreased uterine blood flow and a leftward shift of the oxygen dissociation curve in fetal acidosis. And unrelieved labor pain in many mothers has been found to result into postpartum stress, post-traumatic stress disorders, depression, and persistent pain. And therefore, the beneficial effects of labor analgesia are multifold. Not only does it result in relief of anxiety and fatigue and prevents the postnatal stress depression, it also results in good effects on the fetus as it decreases the fetal acidosis or eliminates it entirely. It converts a dysfunctional labor pain to normal and therefore has been found to be quite beneficial. So to begin the process of labor analgesia, it is important that we have a mother who consents for this pain relief. And for that, we need to provide her with good information so that she's able to make a good choice. For a valid consent, as I said, sufficient information to make a good choice is important. A capacity to be competent to understand and comprehend it is important. And also, the mother should be able to voluntarily give her consent freely. As to the validity of consent, it has been found and repeatedly reinforced, even legally, that a laboring mother does have a normal capacity for decision making, and she has the ability to comprehend information, which is never affected by neither by labor pain nor by opioid pre-medication, anxieties, or education group. What is important is to provide her good patient information, that is, the treatment options with their relative risks and benefit in either verbal or leaflets or media or video at various time intervals whenever they require, whenever they come to you for antenatal checkups or during labor. And the most important thing is that this conversation should be documented. We must be able to answer all their questions, especially the common questions that these mothers will have or their families will have is backache, is epidural compulsory, what is the effect on baby, when do I take it, and are there any nerve damages? And it is pertinent on the part of the provider to be able to answer all questions to the mother, and adequate disclosure is a fundamental duty of the anesthesia provider and of course the obstetric provider. We should be able to tell all of these complications in a more a proper manner, making them relate to the incidences and understanding them in the real sense, meaning thereby that common, you should be able to make her understand what is the meaning of common and very rare in relation to their, normal parlance, so that they're able to comprehend it well. And therefore, documentation of the discussion is very important. The consent can be both verbal and written, but however, I would still recommend in current times that the consent be written, but the documentation of the discussion is which is more important. So what are the criteria for an ideal labor analgesic? It should be able to provide maternal and fetal safety, have ease of administration, consistent, predictable, and rapid in onset, and provide pain relief through all stages of labor without any motor blockade. That's very important. And of course, should be able to supplement analgesia and in some cases anesthesia as well. So what are the techniques that are available to us? We have non-pharmacological techniques. We have the pharmacological parenteral opioids and non-opioids, the inhalational, especially the Entonox, and of course the gold standard, the central neuraxial blocks. We look at the non-pharmacological techniques. They range from parent craft antenatal classes to continuous labor support. In many countries, there are doulas which are trained to be with the mother during entire labor. Touch, massage, hypnotherapies, biofeedback techniques, like Lamaze's technique, the breathing techniques, acupuncture, TENS, intradermal water injections, all have been tried. And a Cochrane review has looked at the efficacy of that, and what they have found to have none to mild analgesic benefits. But what is important is that it does reduce anxiety, tension, and fear. And we should be able to offer compassion, understanding, and professionalism if we are exercising any kind of labor analgesia, especially non-pharmacological, but that is true holds for even for other pharmacological techniques as well. Among the inhalational ones, we know Entonox has been there since ages, has been able to provide good efficacy of pain relief up to 50% and is comparable to mepridine. The big advantage it gives is the mother self-administers if she feels a sense of self-control and therefore has better maternal satisfaction. Of course, there are side effects, and we must remember that we must administer them through the pre-packaged equipment and not through your workstations. That's very important. Nitrous oxide has come under a lot of cloud because of potential for neurotoxic effects and for crossing the placenta and genotoxic effects, and hence has now, and also it's a greenhouse gas and therefore is now going out of use. Among the parenteral, we have all of these opioids on board, which can be either given by intermittent boluses or by patient-controlled analgesia infusions, which offer better patient satisfaction and pain relief. So these are indicated when you're in a low resource setting, you have mother who's refusing neuraxial analgesia, the contraindication to neuraxial procedures, we can offer them parenteral opioids. But remember that maternal oversedation, desaturation can occur, and so you need to really monitor this mothers, as well as facilities for neonatal resuscitation should always be there. Mepridine is the most commonly used since ages. It has been used by midwives intramuscularly, but we need to remember that it has an active metabolite in the with a long half-life. So neonatal depression is definitely an entity in these, especially if the imminent delivery is there within the first 4 hours of administration. Then the new kid on the block is remifentanil. It is now available in our country. We must know the bolus, the lockout intervals, and of course the background infusion. But what is more important is to remember that we must be able to monitor these mothers' respiratory rate, sedation scores, and of course the pain scores. And the nursing supervision and the anesthesiologist supervision needs to be very vigilant and one-to-one. There has been an advent of patient-controlled intranasal fentanyl analgesia. However, it has been found to increase risk of neonatal respiratory depression, so needs more studies before we can recommend it for routine use. Among the other non-opioids, these agents have been used. What we must remember that ketamine should not be used at all. Clonidine has a propensity to cause profound hypotension. And these drugs have not been approved as yet for safe use in obstetrics, and hence we must not preferably be using them. And also, if we look at this pyramid on the efficacy of labor pain relief, we find that, remifentanil, and of course, on the top is the gold standard, the epidural, or the neuraxial analgesia that we can offer to these mothers. That they have been found to offer superior pain relief, not only for entire labor, but also for instrumental delivery or an episiotomy, allows extension of anesthesia for an inadvertent cesarean section during labor. And more important is that it avoids the maternal and neonatal respiratory depression that occurs with IV opioids. So has been found to be the most effective and the least depressant, allowing participation of an alert and awake mother. Having known the advantages of this gold standard technique of neuraxial techniques, we need to also understand the stages of labor and the pain pathways in labor. So we all know that during the first stage of labor, the afferent nerve impulses from the lower uterine segment and the cervix causes visceral pain. So they cause visceral pain, and these nerve cell bodies are located in the dorsal root ganglia of T10 to L1. During the second stage of labor, the afferent nerves innervating the vagina and the perineum cause somatic pain. So it's more because of the stretching up there, and these are impulses travel by the pudendal nerve to S2 to S4. So we need a good, ideal labor analgesic via the neuraxial route should cover sensory loss from T10 to S4 or S5, I would say, with minimal or negligible motor blocks, so that we can provide analgesia throughout all first and second stages of labor. Among the indications, we have to remember now, since 1992, maternal request for a mother who is in active labor is enough a justification for pain relief during labor. You do not need a specific cervical dilatation to go ahead and put the epidurals, right? So a maternal request is good enough an indication, and no particular cervical dilatation scores are needed for citing the epidural. So among the other apart from maternal requests, that is the most important indication is hypertensive disorders of pregnancy, pre-existing medical diseases, even mild to moderate stenotic lesions, or heart diseases, multiple pregnancies, previous cesarean section, a trial of labor after cesarean section, prolonged labor, fetal growth restriction, difficult backs, difficult airway, especially morbid obese patients. You need to look for a window of opportunity to cite your epidurals timely, because in case they need an emergency section, you have a working epidural on board, which can be easily converted for anesthesia, right? Among the contraindications, maternal refusal, inability to cooperate, coagulopathy, thrombocytopenia, local skin infections, severe systemic infections, and allergy to amide local anesthetics are absolute contraindications. Relative contraindications are inadequate staffing, facilities, or inadequate experience, maternal pyrexia, uncorrected maternal hypovolemia, gross spinal deformity, severe fetal distress, or a raised intracranial pressure. For the techniques that are offered to us for neuraxial analgesia are epidural, the combined spinal epidural, and the dural puncture epidural, where an epidural catheter is inserted after the epidural pole, but we do not give an intrathecal drug. Whereas in CSC, we do administer an intrathecal drug, right? So, so these are apart from the epidural, the combined spinal epidural, the dural puncture epidural, we can also offer single shot and continuous spinal for analgesia. Now let us look at them one by one. And the conventional epidural has stood the test of time and still found to be most efficacious as it provides continuous analgesia. You do not do a dural puncture, so there is no chances of there is a flip side because you're not puncturing the dura is in the sense that large drug doses will be required for sacral spread might be patchy. But having said that, there would be no PDPH coming on board. The only caveat is that inadvertent dural puncture can, of course, create complications. But the good thing is that we have the ability to extend analgesia to anesthesia for a cesarean section, right? And the disadvantages, as I said, is there is a preferential cephalite spread and sparing of sacral dermatomes, especially if you are not using higher volumes of low concentration of local anesthetics. And therefore, breakthrough pain and patchy blocks are a possibility for these mothers who receive epidurals. So of course, you need good management of these epidural catheters, which have stood a good test of time and good track record. The other option is a combined spinal epidural, where you go in and put an intrathecal drug into the intrathecal section, and then come out, and then you thread the catheter in the epidural space, and then continue to give your epidural local anesthetics. So it is indicated for early and uniform analgesia. It's a very good choice for mothers who have come a little late in the first stage of labor, are experiencing severe pain, and they're in advanced labor, but they can position themselves for you. So you can go ahead and provide intrathecal drug, and then with the help of the intrathecal drug, you would give them immediate pain relief, and then you can site your catheters properly. The good thing is that you know that you're in the midline, you have confirmed that you're in the epidural space because you have seen a return of CSF from the spinal needle when you did a spinal dural puncture. So you know that you're in the right place. So it's a good technique to be offered to mothers who are morbidly obese, difficult spines, or you need to resite the epidural catheters because the epidural catheters were not working, conventional catheters were not working. It does provide us rapid onset of uniform thoracic as lower thoracic or lumbar and sacral analgesia. Lower doses of local anesthetics and opioids need to be given intrathecally so that there are minimal maternal and umbilical cord concentrations. There is complete analgesia with the intrathecal component if you're using opioid alone and not using a local anesthetics. And of course, as we said, because you are now certain that you're in the midline in the right place, that there is a decreased incidence of failed epidural and an ability to extend the analgesia to anesthesia. But there has been a flip side of a higher risk of fetal bradycardia, because as you give the fetal opioid, the intrathecal opioid dose or the local anesthetic dose, more so with an opioid, it causes a sudden decrease in the epinephrine or the stress hormone concentrations that are there in the mother, because there is an instant pain relief, and that leads to uterine tachysystole in some cases. This can be easily treated by intrauterine fetal resuscitation, does not need a start section. You need to put the mother in left lateral, fluids, oxygen, and of course, terbutaline can be given if uterus hypertonus is suspected, right? So we have a lot of advantages of CSC over epidural. And I would say that the biggest advantage is that we know that the epidural catheter is inserted in the midline, in the right place. Therefore, there is reduced incidence of breakthrough pain and a superior analgesia with sacral spread due to transfer from dural hole, right? And that, of course, results in less motor block and less local anesthetic compensation. And in the first and the second stage of labor are also shortened up there, right? The newer kid on the block is the dural puncture epidural, where you go and do puncture the dura, but you do not give any intrathecal dose. So it provides us rapid onset of analgesia. The chances of asymmetric block are less. There is early bilateral sacral block because through the dural hole, the epidural drug keeps, there is a transmeningeal flux and it keeps seeping through and provides you good sacral analgesia. Of course, there are fewer maternal and neonatal side effects. So we are not giving a drug in the spinal component in the intrathecal compartment, but we are only creating a dural hole up there. So what has it resulted in is in an early onset of pain relief as compared to conventional epidural, fewer patient top-ups, physician top-ups needed, lesser need for supplemental analgesia as compared to all the other modalities. And of course, it has decreased the incidence of side effects, especially itching, pruritus, hypotension, and of course, uterine hypertonus and fetal bradycardia as well, right? So as I said, it creates rapid onset of analgesia, less chances of asymmetric block, and of course, an early bilateral sacral block. But what has been found that the analgesia provided is superior when you're using 25 gauge spinal needles in comparison to 27 gauge spinal needles. So the success depends upon needle size. The wider the bore of the needle, the better the dural hole and more the transmeningeal flux. And of course, also on the volume of epidural drug mixture that you're administering. More the volume, the more the seepage across the dural hole, and better is the sacral spread. So, but we still need further investigations onto this aspect, which is being provided, stated for superior pain relief. Now, there could be mothers who come very late in labor and are in severe pain, cannot set up. So we can offer them pain relief with the help of a single short spinal, because it's technically simple. It provides you rapid onset of analgesia and immediate sacral analgesia. So that's an advantage. You can also thread and spinal catheter, especially if you have a difficult epidural catheter placement. You cannot put an epidural catheter. There's a previous spine surgery, severe morbid obesity, super obese women, and severe cardiac disease. Now, severe cardiac disease, I would like to refrain you all from severe stenotic lesions. That's a gray zone which we should not venture into. But of course, mild to moderate can be, of course, offered this option. The advantages are it provides rapid onset of analgesia. You really need very low doses of local anesthetics. 1 to 2.5 milligram of heavy bupivacaine is all that you need. And an opioid, you need 10 to 20 microgram of fentanyl. And that is all that you need in these doses. And with the catheter, you are able to extend the analgesia to anesthesia in contrast to a single short spinal. But what you really need to remember with continuous spinal catheters is that one, asepsis has to be strictly maintained. We do not want the risk of meningitis coming up here. And that they need to be labeled properly, closed and knotted, and only handled by a single provider, because there is a possibility of overdose. You can inadvertently give an epidural dose through this spinal catheter, thinking it to be a epidural catheter and not a spinal catheter. And that can result in total spinal anesthesia if you mistakenly administer the epidural dose. So that is a point of safety that you really need to mention. Among the dose drugs, we all know we have been using bupivacaine, ropivacaine, and levobupivacaine. All have equal performances. Along with fentanyl, an opioid needs to be added for visceral analgesia. And we have moved from high concentration, low volume schemes and traditional administration to low concentration, high volume, because when you go low on your volumes for bupivacaine to as low as 0.0625 and for ropivacaine to as low as 0.08%, you have greater efficacy, fewer side effects, and better outcome, because you're giving higher volumes for better spread and low concentrations for lesser motor block. So the total local anesthetic consumption decreases, and it helps in larger uniform spread in the epidural space. Therefore, there is effective and improved quality of analgesia, less maternal hypotension, and higher rates of spontaneous vaginal delivery with negligible incidence of instrumental delivery rates. Ropivacaine, of course, has been found to provide lesser motor block with bupivacaine, but the pain relief offered is at par with or similar to bupivacaine. So either mixtures can be used. What are the doses that we use? As I said, we have moved to low dose mixtures. That means we have gone to 0.0625% concentrations of bupivacaine, or 0.08% or 0.1% of ropivacaine. And since the concentration is decreased, now we need to increase the volume, that is 15 to 20 ml for initiation of labor epidural. And this needs to be given slowly over 10 to 20 minutes. Slowly monitoring your patients, right? In the combined spinal epidural, the intrathecal component can be taken care of with 0.5% bupivacaine, 1 milligram to 2.5 milligram. And the fentanyl needs to be added to a maximum of 25, but I would like you all to restrict yourself to 10 to 15 micrograms intrathecally, or a sufentanil dose of 2.5 to 10 micrograms. Having put an intrathecal dose, the epidural dose in the epidural component would be 5 to 10 ml of the same low dose mixture, 0.0625% of bupivacaine or 0.08% of ropivacaine can be offered to this mother. In continuous spinal anesthesia, again, the intrathecal bolus dose should needs to be limited to 1 to 2.5 milligram and 15 to 20 microgram of fentanyl. So these are the doses that we need to remember for initiation. Now, for maintenance, we might use many dosing. We can start from the conventional intermittent manual boluses, which are labor intensive. And of course, they have a problem that they can be delay in analgesia coming in. So continuous basal infusions and the help of infusion pumps have been added. But the flip side is that local anesthetic consumption gets greater. And therefore, there's a high risk of motor blockade and vigilance for monitoring the breakthrough pain. So there have been issues with intermittent epidural boluses, though they have been good, but then issues about sterility. You need to open the epidural each time to give. So, and analgesic delays can occur, and then you really need to rely on the anesthesia provider, the attendant going and informing us, and we coming in to do that. So, it increases the workload. And on the other hand, a continuous epidural infusion does not address the change in intensity of pain, the progress of labor, the interpatient variability, and therefore control over analgesia is poor. And that is why smart pumps came into picture. We have now the PCEA pumps and the programmable intermittent epidural boluses pumps there. And they have been found to do one excellent, superior analgesia to these mothers. You can program them on their basal rates, the bolus dose, the lockout intervals, and put a safety hourly dose limit as well. They offer us advantages of giving the mother a sense of self-control because she can administer those epidural boluses herself. In addition, the programmed intermittent boluses will continue to go mandatorily to the mother, and therefore we can adjust to the needs of the progressing labor, the interpatient variability, and of course, in addition, we get an advantage of reduced motor block, lower breakthrough pains, and good, superior analgesia and better maternal satisfaction. The PIEB offers automated mandatory boluses, and that has been found to be extremely advantageous in reducing the risk of breakthrough pain and avoiding fluctuations in sensory levels, provides superior widespread sacral analgesia, especially during second stage of labor. So why is this important? We need to understand the physiology behind it. So when we give continuous infusion, all that you get is the limited spread of the local anesthetic in the epidural space. Whereas with the help of a intermittent bolus with greater injection pressures, it allows the drug to exit from all holes of the multi-orifice catheter and leads to a more wider spread and uniform spread and superior analgesia. So this is the kind of spread that you see in the epidural space. And that is the reason that programmed intermittent epidural boluses have been found to be best. And they work very well with a background administration with the PCA pump technique. So combination of PCA with the PIB has been found to offer much better uniform and, good analgesia. And of course, also have found to result in almost negligible rates of instrumental delivery, right? We can use all of these settings for these mothers. And there is a recent advance into computer integrated where a computer integration program is there to analyze the mother's local anesthetic requirement in the last 1 hour. And this helps to adjust the background infusion. It reduces or increases accordingly. These, of course, the computer integrated PCA pumps have not hit our markets in India, but it does lead to a 4-fold decrease in the incidence of breakthrough pain. So that's a very big advantage that you come. So to optimize outcome would mean that we are able to provide superior analgesia, reduce breakthrough pain, and a negligible rate of instrumental vaginal delivery. We need to move to large volumes of dilute local anesthetics and low-dose opioid solutions, both for initiation and maintenance of labor analgesia. All the techniques work easily well, but however, having said that, epidural technique, the conventional, has stood the test of time. The CAC technique is a good technique to offer to mothers who come to us in advanced labor and are able to set up for the procedure. And of course, for maintenance, use of programmed intermittent boluses combined with the PCA This is something which really gives you good maternal satisfaction and optimizes outcomes. And you can have this chart. I would recommend you all to read this article, which was published in Indian Journal of Anesthesia by our founder president of AOA, Dr. Professor Sunanda Gupta ma'am. And so it gives you a good guide on what are your dosing, the initial bolus doses, the maintenance doses, the lockout intervals, and of course the dose of opioids. Every complication is fraught with, every technique is fraught with, complications. And therefore we must know that we must become, vigilant for higher total spinal block, hypotension in case a higher concentration of and large volume has gone, and of course local anesthetic systemic toxicity. A few points about troubleshooting. I'll just talk about breakthrough pain. We need to remember that if there is inadequate block, patchy block, or breakthrough pain occurring, we need to first, of course, inject another additional dose of 10 to 15 ml of low dose mixture. If that doesn't work, especially in breakthrough pain, we can increase the concentration of local anesthetic plus minus the opioid. And if they are unsuccessful for the next doses, we need to monitor this mother for another 30 to 45 minutes. And then if unsuccessful, we must be ready, have a low threshold to replace the catheter. In addition to that, always be vigilant about bloody taps. Withdraw your catheters, flush them with saline. And if it is doubtful, please replace your catheters. If you have an accidental dural puncture and you have an intrathecal placement, then you really need to be vigilant with these mothers, and therefore having safety mechanisms behind us very important. Having said that, if you enter the dura inadvertently during a conventional epidural, we can, rather than reflexly removing the catheter or removing the needle, first inject a low dose, that is 1 to 2 milligram of heavy bupivacaine with 10 to 15 microgram of fentanyl, and then remove it. Or we can put a catheter and leave it there for 48 hours so that there is fibrosis and less chances of a lower incidence of the severity of PDPH. But then you have to remember that this epidural catheter, which has been placed in the intrathecal compartment, needs to be handled very vigilantly with strict asepsis and should be labeled well so that no inadvertent epidural dose goes in. These are the safety caveats that are there. A few thoughts about whether to site your epidurals in the lateral position or sitting. Both positions are good. We need to only remember that lateral position offers you advantages of a lesser orthostatic hypotension and continuous fetal heart rate monitoring, whereas the sitting is better. It gives you a better, easy first pass success. The uterus falls forward. There is less compression, is indicated in obese. But we must remember that we must not put the mothers in tight fetal curl position, because that can lead to an increased incidence of venous puncture. To reduce that, we can have a recumbent head down position while the mother is in lateral position. Of course, we all now know that loss of resistance to saline is superior to air because of many advantages that it offers to us. There is, of course, newer advances now coming in. We are having portable optical epidural needle, real-time epidural anesthesia guidance. Until they hit the markets and help us into real-time guidance into epidural space, we can upskill ourselves, improve our skills into use of pre-procedure ultrasound to identify midline, intervertebral level, and the distance to ligamentum flavum, especially in difficult backs, previous spinal surgeries, or in obese parturients. As I said, safety issues are very paramount. So you must have a checklist. You must perform a team timeout. You must have an intralipid 20% placed on your labor floors, in the fridge, wherever you're putting epidurals or using regional anesthesia. Please make it sure that your hospital is well stocked with intralipid, and of course, with all the proper checkups up there, the equipment, the drugs, the patient evaluation, whiteboard IV cannula, hydration, and we must take active measures to minimize local systemic anesthetic toxicity. So you must aspirate before administration of each dose, must look for passive return of CSF and blood, and keep talking to your mothers at all time and documenting the sensory and motor blockade. A word about epidural test dose. So the conventional epidural test dose that we were using of lignocaine 2% with epinephrine are now being questioned because, one, labor pain causes tachycardia. So we are not sure that the tachycardia that has been caused is an epinephrine effect or a secondary to labor pain. Two, the dose of local anesthetic, the 2% lignocaine with epidural 3 to 4 ml, can cause fatal consequences should the catheter be intrathecal. So we do not want more harm to be coming to this mother. And therefore, each dose of the dilute local anesthetic that you are giving for labor analgesia itself acts as a test dose for the mother. You need to go slowly. You need to have all safety precautions, especially if you're moving to OTs and your shifts are getting over. Safe handovers, documentation, and auditing your practices are very important. So in the end, I would say that all mothers should be offered pain relief, all options of pain relief, and they should receive continuous labor support. A compassionate continuous labor support is very important. You must offer them all options and let them take those options and decide about that. Epidural labor analgesia is, of course, the gold standard. And in that, we must now move to low dose dilute solutions of local anesthetics with low dose opioids, but use larger volumes, that is 15 or 20 bolus doses given slowly over 20 to 30 minutes. PCA pumps using the programmed intermittent epidural boluses option are offering better patient satisfaction, reduced local anesthetic consumption, and lower risk of block, resulting into better outcomes and lower instrumental deliveries. And of course, as I said, safe practices should be made a norm into your places. And with this, I thank you all for a patient hearing.
Thank you, Dr. Anju Grewal, for excellent presentation and covering all aspects of labor analgesia in a very simplified manner. Thanks a lot. I don't know whether question answer session, I ask the organizer, we can have 1 or 2 questions. No?
So we do have question answer session, but we don't have any questions right now in the chat box.
Okay.
So anything, sir, that you want to add
it's
or
okay.
any
It's
inputs
okay.
from your
Basically,
side?
we are also using, and now this intermittent bolus is lower analgesia. We are using PCA pumps, PCEA as such. And but now we have seen lately this intermittent bolus where the PCA pump is much more effective and lesser complication, better analgesia, superior analgesia is being provided by this technique. So new techniques are coming up. Computer integrated will come up. It will make things much safer, much better, superior analgesia. But till that time, I think, but one should use labor analgesia. We are in our hospital also using it. We have the labor analgesia services, and the dedicated anesthetics should be there. One thing important is the obstetric confidence should be there. The obstetrician must have confidence in the anesthesiologist who is giving epidural. If that is there, then the acceptance becomes much more. So the dedicated anesthetists are required. That is a requirement, I think, for better anesthesia services, labor anesthesia. Thank you very much. Thank you very much for giving me the opportunity to chair the session.
Thank you. Thank you so much, Anju ma'am, for that exhaustive and totally inclusive lecture. And thank you, Pradeep sir, for all your input. I think it was a very useful session for the postgraduates. Thank you so much, ma'am.
Thank you very much. Thank you very much.
Thank you so much. It's been a pleasure. I know I used my previous recording, but I would actually say that the things and the kind of advances have still stayed the same since last year, haven't much of change. But what Dr. Pradeep said is extremely important. Building the confidence in your obstetrician requires good teamwork. And I would exhort all of you to become, to take a step further. You have to move out of your comfort zones, be there, be seen in the labor floors at all times, especially during the second stage or when the mother is crowning and delivering, and more often than not, they switch off your epidurals and then there is breakthrough pain. So those are the crucial times that you should be there. And of course, needless to say, monitoring of the mother is extremely important. It is labor intensive, but it pays you rich dividends. It is really, a very, very satisfying experience to have a mother smiling and having a baby in her arms with pain, who's pain-free. So that is very important. And I also would like to take this opportunity to invite all of you to this year's national conference of the Association of Obstetric Anesthesiologists at AIIMS Bhubaneswar from 31st October to 1st of November. And we are also having a webinar on PDPH on 5th August, which will be taken up by experts across the world. So it is indeed heartening to see that Dr. Neerja and her team, you all are very dynamic, and this is extremely good. And thank you so much for giving us this opportunity. So on behalf of my chairperson and I would like to thank you all for giving me this opportunity. If there are questions, we'd like to answer if you want me to stay over.
Ma'am, no, ma'am, we don't have anything in the chat box. So I think we can wind it up. Thank you so
Thanks
much,
a lot.
ma'am, for all your inputs. Thank you, sir.
Thank you.
Thank you, sir.
So
Thank you.
that-
Thank you.
Yeah. So with that, we move on to the next part of today's session. It's a long case discussion. A 23-year-old G1P0 full-term pregnant patient with severe mitral stenosis planned for elective cesarean section. So the case discussion would be taken by Dr. Kirtinath Saxena. Ma'am is a director professor and ex-HOD at Maulana Azad Medical College. She has more than 100 papers in national and international journals and 13 book chapters. She has been the editor of 2 books and editor-in-chief of Journal of Indian College of Anesthesiologists. Ma'am has numerous awards and professional achievements. She is a WHO fellow in trauma from Liverpool, Australia. Ma'am has been a railer for the McMaster online rating of evidence system. Ma'am is an expert on anesthetics, resuscitation and allied equipment, Section Committee of Medical Equipment and Hospital Planning Department, Bureau of Indian Standards. She is an expert at UPSC for the Government of India. She is an expert resource person for Delhi Subordinate Service and Selection Board. Ma'am is a member of Education Committee of Indian College of Anesthesiologists. She is an expert in National Board of Education. Ma'am is a member of NHA Medical Cell of Ayushman Bharat, Government of India. She is the recipient of WTG Morton International Distinguished Professor and Researcher Award 2023. And she is also an award. What do you see this? So we welcome you, Kirti ma'am. Over to you.
Okay, so good morning, everybody. And we'll start with the case presentation of parturian having severe mitral stenosis. So, Dr. Subhajit, can we start?
Yes, ma'am. Good morning, ma'am.
Good morning.
Ma'am, my patient Rani, a 23-year-old married female, resident of Paschim Bihar, Delhi, presented to the OPD with chief complaints of amenorrhea for 9 months and shortness of breath for 2 months. My patient was apparently all right 2 months back. She developed shortness of breath 2 months ago, which was insidious in onset, progressive in nature. Initially, she experienced breathlessness while climbing stairs, which soon progressed to breathlessness while doing her daily activities. Her symptoms aggravated on physical activity and was relieved at rest. She can lie down flat and has no history of waking up during her sleep. It's not associated with chest pain, swelling of limbs, dizziness, syncope, fever, cough, sputum production, hemoptysis, diurnal variations, or hoarseness of voice. She has no history of blurring of vision or slurred speech. She had visited the emergency for the same, and after evaluation, she was started on some medication which alleviated her symptoms. Now she is admitted in the ward for safe confinement. History of past illness. Patient had history of recurrent fever and sore throat with multiple joint pains in her childhood. She was advised an intramuscular injection every 3 weeks, but was not compliant with her treatment. There is no history of hypertension, TB, cerebrovascular accident, diabetes mellitus, asthma, seizure, thyroid disorders. There is no history of any drug allergies, no history of any surgical intervention in the past. Currently, she is on tablet metoprolol 25 mg 1 tablet twice daily, tablet furosemide 20 mg 1 tablet twice daily, injection benzathine penicillin 1.2 million units IM every 3 weekly. Her menstrual history is she attained menarche at 12 years of age. Her cycles are regular at interval of 25 to 28 days, bleeding for 3 to 4 days, and there's no history of menstrual irregularities. She is a primary gravida G1P0 status with the LMP at 15th of November 2024. Our expected date of delivery was 22nd August 2025. Period of gestation is now 37 weeks. She is a book case and immunized. First trimester, the pregnancy was confirmed by urine pregnancy test. Second trimester, quickening was felt at 18 weeks. Presented in the casualty at 6th month with shortness of breath, for which evaluation was done and put on medications. Third trimester, the fetal movement perception was normal. She belongs to lower socioeconomic status as per modified Kupuswamy scale, educated up to class 12th, vegetarian by diet, no history of any addiction, no history of any drug or food allergy. She's born out of non-consanguineous marriage, and there's no history of similar illness in the family. My patient is conscious and oriented to time, place, and person. She is average build. Her height is 155 centimeter with a weight of 62 kilogram. The pulse rate was 84 beats per minute, low in volume, no radioradial delay. All peripheral pulses were felt. Modified Allen's test was positive. Blood pressure measured to be 108 by 62 millimeters of mercury in the right arm in sitting position. The respiratory rate was 16 per minute. JVP was not raised. Temperature afebrile to touch, and there was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, fetal edema. For airway examination, there's no obvious facial deformity, no deviation of nasal septum or nasal crusting, no TMJ subluxation. Mouth opening was adequate, more than 3 finger breadths, no loose or artificial or absent burp teeth, no macroglossia. Our modified Mullen-Beatty grading was 2. Thyromental distance and sternomental distance were normal. Neck range of motion was normal. The cardiovascular system examination. On inspection, no obvious chest deformity was seen. Precordium was normal. No scars or engorged veins. All the inspectory findings were confirmed on palpation. No local rise in temperature. The apex bit was tapping in nature at the left fifth intercostal space, just medial to the midclavicular line. Parasternal heave was present. Heart rate was 84 beats per minute. S1 was loud. S2 was loud. And low-pitched rough rumbling mid-diastolic murmur of grade 3 intensity was heard with pre-systolic accentuation in the left lateral position. The respiratory system examination. Movement of the chest was bilaterally symmetrical. No superficial veins or scars. No signs of use of accessory muscle. The respiratory rate was 16 per minute. Were confirmed movements bilaterally symmetrical. Parameters bilateral equal. Bilateral resonant mode present all over areas. And on auscultation, vesicular breath sounds were heard. Abdominal examination, the abdomen was globular, umbilicus was everted, linea nigra and stria gravidarum seen, no scar of previous surgery present. Fundal grip, the fundal height of 36 weeks, soft, broad and irregular mass felt, probably buttocks. Lateral grip, back was felt on the right side. On pelvic grip, smooth, hard and globular mass was felt, probably head, freely floating and not engaged. On auscultation, the fetal heart sound was central nervous system examination. Patient is conscious, oriented to time-place person. Her higher mental function are normal. No signs of cranial nerve involvement. No sensory, motor or focal neurological deficit. Examination of spine. Spine appears normal without any scoliosis or kyphosis. No deformity of shoulders. And there are no scar mark or sinus seam. The investigations were complete blood count of hemoglobin 10.8 grams per deciliter, TLC of 5,700 per millimeter cube, DLC of lymphocyte neutrophil 70, lymphocyte 35, basophil 5, and monocyte 1, platelet of 2 lakh per mm cube. KFT, her kidney function test, her blood urea was 36 milligram per deciliter, 0.05 milligram per deciliter. Serum sodium was 136 milliequivalent per liter. Serum potassium 3.6 milliequivalent per liter. LFTs total bilirubin 0.6 milligram per deciliter. Enzymes were 25 and 28 international unit per liter. ALP was 125. Total protein 7.25 gram per deciliter. RBS was 107 milligram per deciliter. And her PT and INR were 11.5 seconds and 1.0. The ECG showed a heart rate of 88 beats per minute with sinus rhythm. There were bifid P wave in probably P mitral, right axis deviation with right ventricular hypertrophy, chest X-ray, straightening of left heart border, 2D echo, left atrium is dilated, normal left ventricular size, right ventricular hypertrophy with right atrial enlargement, thickened mitral valve, no calcification, mitral valve area was 0.9 centimeters square. Mean transvalvular gradient was 10 millimeters of mercury. Pulmonary artery pressure was 30 millimeters of mercury. The ejection fraction was 55 to 60%. And there was mild tricuspid regurgitation. No thrombus or vegetation or clot was seen. So the provisional diagnosis was, my patient is a 23-year-old female, a primary gravida at 37 weeks period of gestation with rheumatic heart disease, with severe mitral stenosis, with pulmonary hypertension on medical treatment, posted for planned LSCS due to cephalopelvic disproportion.
Okay. So now can you tell me, Subhaji, that your patient had some fever during childhood?
Ji,
No?
ma'am.
So
Yes, ma'am.
now why is she suddenly having problem during pregnancy?
Ma'am,
She never had a problem.
yes, ma'am.
Hmm.
Ma'am, probably the fever and the associated sore throat and joint pain was due to acute rheumatic fever that led on to rheumatic heart disease, most commonly mitral stenosis. And during her pregnancy, as the physiological changes occur in cardiovascular system, that is increase in intravascular volume by 50%, increase in cardiac output by 50%, and increase in heart rate by 20%. These all symptoms, these all physiological changes bring about her symptoms during mitral stenosis in pregnancy.
Right. So pregnancy often unmasks mitral stenosis, which was not so evident earlier. Okay.
Ji, ma'am. Yes, ma'am.
Okay. Now coming to her diagnosis. So would you recommend, you have written for X-ray chest, but do you recommend X-ray chest during pregnancy for any patient?
Ma'am, the chest X-ray was the older chest X-ray that was probably recommended during her initial episode of respiratory distress. But chest X-ray is not recommended in pregnancy because of exposure to X-rays and fetal teratogenicity.
Yeah,
If to be done, it should be done with proper abdominal shielding.
yes, it should be done with abdominal shield. That is what is important. Okay, and usually the changes can be now evaluated by ultrasound also. Okay.
Yes, ma'am.
So what is the grade of, how do you grade mitral stenosis? Why do
Mitral
patients
stenosis.
go into failure in mitral stenosis? Firstly, why do patients go into failure and what kind of failure in mitral stenosis?
Ma'am, in mitral stenosis, mostly it's a stenotic valve. Therefore, the end diastolic left ventricular volume is low, and therefore they can go into a left ventricular failure. But most commonly, they go into right ventricular failure because of the back pressure on the pulmonary system and on the right heart.
No, left-sided failure is very much there. These patients have
Sorry, ma'am.
pressure. Back pressure over the left atrium.
Yes, ma'am. Left atrium further into the.
Yes, there is pressure on the left atrium, and as it becomes more and more severe, there is pulmonary edema. So pulmonary edema is a very common presentation of mitral stenosis.
Yes, ma'am.
Okay. So then how do you classify mitral stenosis?
Mitral stenosis can be classified into three grades: mild, moderate, and severe, based on the mitral valve area, the transvalvular gradient, and the pulmonary arterial pressure. Usually, this mitral valve, normal mitral valve area is 4 to 6 centimeters square. In mild mitral stenosis, it's 1.5 to 2.5 centimeters square, with a transvalvular gradient of less than 5 millimeters of mercury and a pulmonary artery pressure of less than 30 millimeters of mercury. And in moderate, it's 1 to 1.5 centimeters square with a transvalvular gradient of 5 to 10 millimeters of mercury and a mean pulmonary artery pressure of 30 to 50 millimeters of mercury. And in severe, it's less than 1 centimeter square with a transvalvular gradient of more than 10 millimeters of mercury and a mean pulmonary artery pressure of more than 50 millimeters of mercury.
Right. So on the basis of these, you have made the patient, you have classified the patient as severe mitral stenosis. Okay.
Yes,
now, since it is a cephalopelvic disproportion, the patient would normally not be allowed to go into labor.
Yes, ma'am.
She would go for an elective cesarean section. So if this patient comes to the pre-anesthetic checkup clinic of the hospital, and you are evaluating her, what else would you like to evaluate?
Ma'am, since she is a already a diagnosed case of mitral stenosis, I'd look at the severity of her mitral stenosis, the symptoms that her progression of symptoms, and her period of gestation, and the medications she's on, and whether the disease is controlled on the medication or not.
Okay, from anesthesia point of view, do you want to see anything?
Ma'am, I would like to investigate her with further cardiac evaluation and a 2D echo to know her current status of the disease.
Yes, so a fresh echocardiogram is always indicated in patients with heart disease. Why?
Ma'am, since in pregnancy, the cardiovascular changes are progressive and it increases from trimester to trimester, the disease can progress or worsen.
Yes, but at term, what is the change?
Ma'am, her intravascular volume starts increasing at first trimester, but it peaks around 28 weeks. So, and in her term, the cardiac output can also increase to almost 50%. And her heart rate will also increase by 20 to 25%. Her SVR might fall to 10%. And her pulmonary vascular resistance can also decrease by 20%.
Okay, so what else will you evaluate apart from this part? Anything else you want to?
Ma'am, I'd like to order a complete blood count to look for the hemoglobin as as a baseline, and also if she has anemia, it can worsen the disease. And secondly, a total leukocyte count to look for infections. Thirdly, a platelet count as a baseline, and I'm planning for regional anesthesia. Secondly, I'll go for liver function test, as right heart failure can cause liver failure. Thirdly, I'll go for a kidney function test with serum electrolytes because she is on diuretics. Then I'd like to have a baseline random blood sugar and prothrombin time and INR to for my regional anesthesia. And a fresh electrocardiogram and a 2D echocardiogram, as I said.
Yes, so a fresh ECG should always be done because this was an ECG which was done earlier, and a fresh ECG to evaluate whether patient might be going into atrial fibrillation or any other arrhythmias, and a fresh cardiac evaluation also at term. Okay.
Yes, ma'am.
We have
Yes.
also admitted the patient and fresh evaluation should be done. But before that, an airway evaluation should be done, a fresh airway evaluation of the patient.
Yes, ma'am. Airway evaluation should be done.
Yes, because pregnancy is progressing and the degree of fluid retention is likely to increase in pregnant patients. So the evaluation must be done at term. Now coming to the anesthetic management. So what anesthetic management will you plan for this patient for elective cesarean section?
Ma'am, since she's a case of
What orders will you write?
ma'am, in the pre-op orders, I'll go for nil per oral for 8 hours for solid foods, 2 hours for clear liquids, and I'll go for anti-aspiration prophylaxis with tablet metoclopramide 10 mg the night before surgery and 2 hours before the surgery. Next, I'll go for written informed consent with high-risk consent because with provision for post-operative ICU care and post-operative mechanical ventilation, and send blood grouping, cross-matching, and arrange for blood and blood products, arrange for ICU or HDU bed, and fresh serum electrolytes on the morning of surgery, metoprolol to be continued on the morning of surgery, and
no antacid.
Sorry, ma'am?
You don't want to give antacid?
Yes, ma'am. 0.3 millimole sodium citrate can be given to the patient.
Okay. So, and what about ranitidine?
Yes, ma'am. Ranitidine can also be provided. At a tablet ranitidine 100 ml
Okay, so
2 hours before the surgery.
yeah, so aspiration prophylaxis has to be done for exactly as you do for any other pregnant patient. Okay. What about her other drugs? She's on beta blocker, she's on furosemide. What about these drugs?
Ma'am, patient can be on beta blockers for rate and rhythm control. She can be on diuretics.
What about the hospital for these drugs?
Ma'am, if the patient is in heart failure, she might be started on digoxin or
What I'm talking about. See, the patient is already on beta blocker and
yes,
diuretic.
ma'am.
So what
Yes,
about
ma'am.
postoperatively? You don't want to give these?
Yes, ma'am. I'll continue the metoprolol on the morning of surgery, and diuretics may be stopped on the morning of surgery as it may precipitate hypotension intraoperative.
No, normally patients are continued on diuretic. Why? Because these patients are given these drugs for failure. Okay.
Ma'am.
So what will you choose? What anesthetic technique will you choose?
Since my patient is a case of severe mitral stenosis and is planned for an elective LSCS, I would like to go with Neuraxel anesthesia, preferably graded epidural anesthesia in this patient.
Okay, so what are the advantages of Neuraxel block over general anesthesia? Why don't you want to give general anesthesia?
Ma'am, in Neuraxel anesthesia, there is no airway manipulation. There is good perioperative analgesia. There is decreased risk of DVT because of early ambulation. There is the polypharmacy associated with general anesthesia is avoided, and there is early breastfeeding, mother-child bonding. And pertaining to my case particularly, the Neuraxel anesthesia will bring about peripheral vasodilation, which will accommodate the auto-transfused blood, and this will decrease the risk of perioperative, peripartum heart failure and pulmonary edema.
Yes, also abdominal folds are better in Neuraxel blockade, and there is less bleed.
Sorry, ma'am.
Apgar score of neonate is better with
Yes,
regional
ma'am.
anesthesia, and
Yes, ma'am.
bleeding is less
Yes, ma'am. The risk of bleeding is less.
with new regional anesthesia compared to general anesthesia.
Yes, ma'am.
So how will you give?
And the
Tell me how you will proceed. Now your patient has received all these drugs. How will she be transported and how will you proceed?
Ma'am, my patient will be wheeled into a pre-prepared OT in left lateral position with oxygen supplementation. After shifting her to the OT table, I'll secure 2 wide bore cannulas, preferably 18 gauge. Thereafter, I'll attach all the standard ASA monitors, 5-lead electrocardiogram, non-invasive BP monitoring, and pulse oximetry, and later on temperature and capnography. Thereafter, under local anesthesia, I'll I'll cannulate her left radial artery for invasive BP monitoring, and we'll proceed with Neuraxel anesthesia in either sitting position or left lateral position at L2, L3 or L3, L4 intervertebral space with a 18 gauge 2 hoist needle. And after placement of the epidural catheter with the help of 2% lignocaine, I'll achieve my surgical level of anesthesia in small graded doses of
Did you give a test dose?
Ma'am, usually test dose with epinephrine is not recommended because epinephrine systemic absorption can cause tachycardia that may worsen the symptom. So the lignocaine that we are providing, the first dose of epidural medication will act as the test dose, ma'am. We'll look for intrathecal or intravascular symptoms.
Okay. Anything else?
Ma'am, if it's intravascular, the ligno can cause CNS excitation symptoms, and like she might feel tinnitus or perioral numbness or drowsiness. And if it's intrathecal, there can be a rapid onset of motor blockade.
Yes. So what else? What other precaution will you take?
Ma'am, we will make sure that she is in normal sinus rhythm. We'll avoid tachycardia, and will maintain a good preload. Will not want to have a hypervolemia or hypovolemic state, and so we'll maintain euvolemia. Third, a good cardiac contractility is to be maintained, and her afterload is to be maintained. If needed, with injection phenylephrine can be used at a dose of 0.5 to 0.75 microgram per kg per minute infusion. And the causes of increased pulmonary vascular resistance should be kept at bay, like hypercarbia, hypoxia, or acidosis, hypothermia, pain.
Okay, so pain will not be there if epidural is given. Then another very important thing is to give gradually. Graded epidural means giving gradual boluses of epidural drug. So you wait for the effect of each bolus to see whether there is hypotension or tachycardia or bradycardia after each dose, so that you can treat it simultaneously. So you give a small bolus. This is an elective cesarean. There is no urgency, and we can give 3 to 4 ml, and then give another 3 to 4 ml. Like that, we can keep giving the drug till the level is achieved. What is the level we are aiming for?
Ma'am, T6 to T4.
Why?
Ma'am, during LSS, there might be uterine stretching and fundal pressure. The peritoneal stretch will cause pain if it's not at the level of T4 or T6.
Okay. So we aim for a level of T4, and the biggest advantage of graded epidural is that we can keep giving fluids accordingly. So whenever there is a little hypotension, we can give a fluid bolus, and these boluses have to be small. So just 200
Yes,
to 250 ml of fluid. And then if there is hypotension, we can give vasoconstrictor like phenylephrine. So we can keep treating the hypotension simultaneously, so that excessive hypotension does not occur, which is hazardous for the baby. Okay. Right. Now, once the level is reached, the surgeon will do any other precaution you should have taken, which you do in every cesarean, which you did not mention.
Uteronic drugs, ma'am.
Left lateral tilt must be given.
Left lateral tilt.
To prevent supine hypotension syndrome.
Supine.
So all the features, all the basics of cesarean section must be kept in mind, apart from mitral stenosis. Okay. So once the baby is delivered and the surgeon has finished, what will you do?
Ma'am, once the surgery is finished, we'll shift the patient to a HDU or ICU unit with the epidural catheter in situ, and monitor her for her hemodynamics and give her regular epidural medications. And we'll advise to keep the patient in a propped up position and monitor her vitals and input-output chartings.
Why are you doing this? Why are you keeping the epidural?
Ma'am, the post-partum period is the period where there is highest incidence of heart failure and pulmonary edema because of autotransfused blood. So epidural medications will keep the peripheral vessels dilated and increase the venous capacitance that can accommodate this blood, ma'am.
Right. So the capacitance is increased and this prevents failure. So, and a head-up tilt also helps in this.
Yes, ma'am.
One should keep monitoring the patient for failure. Okay. So supposing that this patient had something in some problem in the lumbar area and you are not able to give regional anesthesia. So you will have to give general anesthesia.
Yes, ma'am.
So how will you proceed with general anesthesia in this patient?
Ma'am, for general anesthesia, I'd like to go with rapid sequence induction, ma'am, in this patient. Once the arterial line is secured as earlier, we'll proceed with pre-oxygenation with 100% oxygen for 3 minutes with tidal volume breath, and thereafter we will give injection etomidate 0.3 to 0.4 milligram per kg, followed by succinylcholine 1.5 milligram per kg, and we can also give esmolol 0.25 to 0.5 mg per kg to obtundate her laryngoscopic response and intubation attempt response. And then we will do gentle laryngoscopy and do intubation, probably limited to 30 seconds with a tube of 6.5 or 7 millimeter internal diameter tube.
Okay.
And then maintain her on oxygen, air, and sevoflurane, and give muscle relaxant vecuronium or rocuronium of adequate doses.
What about opiate?
Ma'am, opioids can be given in this patient, but the pediatrician needs to be made aware of this, and naloxone should be available for in case the newborn baby goes into respiratory depression.
Why do you want to use opiate?
Ma'am, opioids will obtundate the laryngoscopic response, ma'am. So, opioids.
So you already have esmolol, no? You can use other drugs also. So opiates
Yes,
are
ma'am.
generally avoided, but in severe cases, they may be used during induction, before induction,
Yes, ma'am.
to reduce the tachycardia and obtain the response. Okay, but this is a controlled patient, and you can use esmolol and proceed with etomidate. Now coming to, okay, so intra-op now, you've intubated the patient. What about ventilation?
Ma'am, will keep the tidal volume at 6 ml per kg, and will give a peep of 5 centimeter of water, and will avoid nitrous oxide, as this might cause increase in pulmonary vascular resistance.
Anything else? Avoid hyperventilation.
Yes, ma'am. Hyperventilation should be avoided because it might shift the oxygen dissociation curve to the left and deteriorate her symptoms.
It can deteriorate already the patient is having pulmonary hypertension.
Yes, ma'am.
So this can lead to oxygenation
VQ mismatch can.
as well as shift of the HbO2 dissociation curve leads to less delivery of oxygen to the baby,
Yes,
to the
yes,
fetus.
ma'am.
And the blood supply to the fetus will also suffer. There will be vasoconstriction leading to reduced umbilical blood supply.
Yes, ma'am.
And this can lead to
Fetal acidosis and hypoxic encephalopathy, ischemic encephalopathy to the child.
Yeah. Ischemic? What is
Encephalopathy. So, HIE, ma'am. Hypoxic ischemic encephalopathy.
Yeah. So these all can happen. So we keep the PaCO2 to normal limits. That is how much?
In 35 millimeters of mercury, ma'am. The 35 to 40 millimeters of mercury, the normal range.
5. In pregnant patients, it is less. So
Yes, ma'am.
keep it like that and then not less than that. Okay. So hypoxemia should be avoided. Hypocardia should also be avoided. So both hypercardia and hypocardia should be avoided. What about reversal? Can we give opiates after this once the baby is delivered?
Yes, ma'am. Once the baby is delivered, we can give opioid, ma'am. But we have to delay our breastfeeding as well.
So what opiate can you give?
Ma'am, fentanyl can be used in this patient.
Right. We can give fentanyl and then reversal.
Ma'am, if our hemodynamics are normal and there are no signs of pulmonary edema, we can plan for reversal. We'll reverse with neostigmine and glycopyrrolate, ma'am. And we'll try to opt in.
Would you like to do anything else before you reverse the patient?
Ma'am, we'd like to obtundate her extubation response also with either.
Hello? Can't hear you. Can't hear you. Dr. Surjit, you are not audible. Will the text team please see? Okay. So what we'll do is we need to give a block also. So multimodal analgesia has to be given to the patient. We don't want the patient to have pain. Dr. Surjit, have you left? Okay.
Yes, ma'am, there was a slight
So would you not like to give a block to the patient?
yes, ma'am. Under G, we'd like to give tap.
So you'll give a tap block, no? So
Yes,
that
ma'am.
has to be before you reverse the patient.
Yes, ma'am.
So patient does not have post-operative pain. And what kind of analgesia will you give?
Ma'am, intravenous multimodal analgesia can be given to this patient, ma'am, in the form of paracetamol, NSAIDs, and small doses of opioids, tramadol, and
Paracetamol also before you reverse the patient.
yes, ma'am.
Okay. And give something to reduce the extubation response.
Yes, ma'am.
Okay. Then you extubate the patient.
Yes, ma'am.
After extubation, what do you do?
Ma'am, post-extubation, we'll look for signs of pulmonary edema because she's moving from positive pressure ventilation to normal breathing, which can precipitate her otherwise subdued pulmonary edema. Second, so we'll keep her in a proper position, give oxygen supplementation, and monitor her vitals and input-output monitoring.
Okay. So this is the most important period because patient is most likely to go into pulmonary edema at this time. And extubation can also precipitate pulmonary edema. Extubation by itself. And very often in severe mitral stenosis, we may not extubate but ventilate, do elective ventilation for some time in these patients. Okay. So what else? Anything else?
We'll
Would you like to give oxygen supplementation to the patient?
yes, ma'am. Oxygen supplementation should be provided to the patient.
Yes, because this patient is likely to go, there are multiple changes, hemodynamic changes at this time. And because of the water transfusion, the load is increasing on the heart. So it is best to give oxygen to the patient. And this is the reason why we keep the patient in a in a propped up position to prevent pulmonary edema.
Yes.
Okay. Depending upon how the patient behaves during anesthesia. At the end of anesthesia, one should always look for creps behind the patient's chest, because if failure is occurring, the creps are likely to be in the back. And we have
Dependent parts.
presented for the first time with mitral stenosis post-operatively, because they were missed. Mitral stenosis was missed pre-operatively by the obstetrician, missed by the anesthetist, and post-extubation, the patient went into pulmonary edema, had to be reintubated. Then I had a patient in the ICU. When I saw in the ICU round, she was full of creps in the interscapular region, because patient is lying down, so the creps will be
Yes.
in the interscapular region.
Yes.
And the patient had creps, and when we got the echo done, she was diagnosed to be mitral stenosis. So this is very important. And if you find creps like this intraoperatively, then it is better to go for elective ventilation of the patient for at least 24 hours and then see how she fares. Okay. So these are some of the things that we need to keep in mind. Okay, thank you. Anything else you'd like to add?
Intraoperatively, we should look out for arrhythmia, heart failure, and pulmonary edema and manage according to the complications.
Right. So we have taken a simple, straightforward case, but this patient could also have atrial fibrillation, or she could be in active failure. So accordingly, we have to manage. So Dr. Anisha, now can we have your presentation, please? Is Dr. Anisha there?
Yes, ma'am. Yes.
This is summing up of the mitral stenosis case with pregnancy.
Good morning, ma'am. I shall be summing up the case in the next few slides. So the epidemiology, the incidence of heart disease in pregnancy is around 0.3 to 3.5%. And the most common cardiac lesions in India are of rheumatic origin, followed by congenital in origin. And the most common valvular heart lesions are mitral stenosis and or regurgitation, followed by the aortic valve diseases. So the maternal mortality in rheumatic heart disease is less than 1% in asymptomatic patients, but it can go up to 17% in complicated cases, and therefore a complete evaluation of these patients is very essential. So how are the cardiovascular diseases in pregnancy classified? So we use various tools to classify the cardiac complications in pregnant women, and two of the most commonly used classifications are modified WHO classification and the Appec scoring. So this is how the modified WHO classification is. It ranges from class 1 till class 4 and has various cardiac lesions in each class. So as we can see in class 1, there is no detectable increased risk. And as the class increases, the risk of maternal mortality in pregnancy is going to increase. So mechanical valves, which are often put in these patients, which are surgical candidates, that is classified as class 3, which signifies that these patients have a significantly increased risk of maternal mortality and morbidity. Although severe mitral stenosis and asymptomatic stenosis is classified as class 4. That is, pregnancy is highly discouraged in these patients because they are not able to take the hemodynamic burden of the disease. This is the Appec score. It is Appec 2 score actually, which is a modified version of the original Appec, which is used nowadays. So it has 10 predictors. Each predictor is given a certain point from 3 to 1, depending on the severity. So whatever predictor is present in the patient, we add those points and we calculate the predicted risk of the primary cardiac event, which will be from 5 to 41% as per the scoring of the patient. So this is how we classify the cardiovascular diseases in pregnancy. Now, coming to the etiopathophysiciology of mitral stenosis can be acquired or congenital. Acquired is largely because of rheumatic origin, or it can be because of calcifications. So what is the pathophysiology? As already discussed in the case, mitral stenosis causes left atrial dilatation, which will eventually cause stasis of blood in the left atrium and might predispose the patient towards atrial fibrillation. It also results in increased left atrial pressures, which will cause pulmonary venous hypertension, leading to pulmonary congestion, and eventually that will cause right ventricular hypertrophy and right heart failure. So, as we discussed earlier, the cardiovascular changes in pregnancy. Now, as we know, the changes in pregnancy include increase in the blood volume by 35 to 45%, increase in cardiac output and heart rate, while there is a decrease of the systemic vascular resistance. But because of mitral stenosis, there is an effect on the patient due to mitral stenosis pathophysiology as well. Therefore, the hemodynamic goals that we have to maintain in patients of valvular stenosis are the exact opposite of the changes in pregnancy. So when the patient has a higher blood volume in pregnancy, which needs to pass through the stenotic lesion, that will cause an increased pressure on the left atrium and pulmonary circulation, causing worsening of symptoms. Similarly, increased cardiac output will cause an increased blood volume in the left atrium, causing worsening of symptoms. Therefore, in such patients, we need to reduce the blood volume and cardiac output. Heart rate increases by 15 to 25% in pregnant patients, but tachycardia will predispose such patients with decreased diastolic filling time, causing a decreased left ventricular end diastolic volume. Therefore, we need to prevent tachycardia in these patients. And lastly, systemic vascular resistance decreases by 20% in these patients, but a significant fall of systemic vascular resistance will cause decreased perfusion pressure. Therefore, we need to increase the SVR. So, as already discussed by ma'am and Dr. Subhajit, severity of mitral stenosis is according to the mitral valve orifice, the mean transvalvular diastolic gradient, and pulmonary artery pressures. The normal orifice ranges from 4 to 6 centimeters square, and mitral stenosis is classified into mild, moderate, and severe category as per the orifice area. Mild is 1.5 to 2.5, moderate is 1 to 1.5, and severe is less than 1 centimeter square. As the severity of mitral stenosis increases, the pulmonary artery pressures increase from less than 30 mm of mercury to more than 50 millimeters of mercury. So what are the stages of mitral stenosis? The patient presents at various stages as per the grading of the mitral stenosis. So it starts from at risk and can progress up to symptomatic severe mitral stenosis. So as we can see from stage A to D, as the severity increases, the mitral valve area reduces to less than 1.5 centimeters square, and the diastolic pressure half time will increase to more than 150 milliseconds. At the same time, the hemodynamic changes would include a severe LA enlargement and elevated pulmonary artery pressures. As you can see, in symptomatic severe mitral stenosis, the patient will present with symptoms of dyspnea and decreased exercise tolerance. So this gives us a brief description about how to approach a patient of mitral stenosis in pregnancy, how to classify, as we have already discussed, and what should be the plan of delivery, whether it should be vaginal or cesarean. When is it planned? Is it term, early term, preterm? Where it is supposed to be done, that is, it depends on the type of medical center, and eventually how, that includes the anesthetic and medication plan. We shall cover this in the next few slides. So what is the management of mitral stenosis? It is largely divided into surgical, medical, and obstetric. Coming to the surgical management, now these patients, as we already discussed, as per the modified WHO, are class 4 patients. So therefore, they should be considered for percutaneous balloon mitral valvotomy before conception. However, if this patient is not a candidate of this surgery, we need to perform a commissurotomy. or whether if a valve replacement is done, then a bioprosthetic valve is preferred in these patients. The ideal time to perform surgery in patients with severe symptoms is during the second trimester, wherein a valvuloplasty is performed. But if the patient has intractable heart failure or pulmonary edema, these both are signs that an urgent surgical intervention is required. So what are the indications of the surgery? PBMC is performed before pregnancy in patients with symptomatic severe MS or asymptomatic patients with severe mitral stenosis, but a favorable morphology for the surgery. During pregnancy, if the surgery is to be performed, it is ideally performed between 12 to 14 weeks of gestation so as to minimize the fetal radiation exposure during the period of organogenesis. However, if we place the patient on medical therapy and the patient is stabilized, then we can delay the procedure to 26 to 30 weeks of gestation. So what is the medical management? Ideally, we give these patients prophylaxis against rheumatic fever. We need to avoid unnecessary physical stress so as to prevent tachycardia and tachypnea. We control the ventricular heart rate with beta blockers, digoxin or calcium channel blockers. Very commonly, beta blockers are used. We relieve the symptoms of congestive heart failure, give the patient anticoagulants and endocarditis prophylaxis. So what are the indications of anticoagulation? The class 1 indications include a patient with mitral stenosis with AF, or a patient with prior embolic event in sinus rhythm, or the patient having left atrial thrombus. While class 2B indications are when the patient is symptomatically severe mitral stenotic patient with LA dimensions of more than 55 millimeter by the echocardiography. So how is the anticoagulation therapy instituted? It is started with subcutaneous or IV heparin for the first trimester, that is up to 12 weeks antepartum, and we need to monitor the APTT at this time. It is eventually bridged to warfarin from 12 to 36 weeks while maintaining the INR between 2.5 to 3, and eventually shifted back to subcutaneous or IV heparin after 36 weeks of gestation. So if such a patient with anticoagulation is taken up for surgery, there can be two scenarios largely. Either the patient is taken up for an elective case or the patient is taken up for an emergency case. When the patient is taken up for elective scenario, the treatment is usually with warfarin and the INR is maintained between 2 to 3. If the patient has a mechanical bioprosthetic valve, we need to continue the antithrombotic medication and we monitor the INR levels between 2 to 3. However, when warfarin is discontinued, we bridge warfarin with an intravenous unfractionated heparin, maintaining the APTT to more than 2 times the control. In case of an emergency case, if the patient is on warfarin, we reverse its effects using fresh frozen plasma, 15 ml per kg, or with vitamin K injection. But if the patient is on heparin, we reverse it with protamine, which is 1 milligram for every 100 units of heparin, which is instituted to the patient. So this table briefly tells us what is the target INR for patients with bioprosthetic valve and how we need to maintain it. So coming to the obstetric management, as already discussed, such patients should be preferred for vaginal delivery with the labor analgesia, which is the preferred mode of delivery. However, there are certain indications of cesarean section that include cardiovascular deterioration, which necessitate an early emergent delivery, failed induction of labor, breech presentation, fetal distress, cephalopelvic disproportion, which was our case, history of previous cesarean delivery, antepartum hemorrhage, prolapsed umbilical cord, uterine rupture, and maternal refusal. So what are the anesthetic goals that we maintain? As discussed earlier, we avoid tachycardia in these patients. We preserve or restore the sinus rhythm, maintain adequate intravascular volume while preventing an increase in the central blood volume, prevent systemic vasodilation, and avoid increase in the pulmonary vascular resistance by preventing hypothermia, hypercarbia, hypoxia, and acidosis. So what is the pre-op assessment? We look for the severity of mitral stenosis and the associated complications, which is pulmonary hypertension, atrial fibrillation, and cardiac failure. So what is the a laboring parturian taken up for. Ideally, a laboring patient is taken up for combined spinal epidural analgesia or labor analgesia. We should institute early insertion of a neuraxial catheter for a complicated parturian, and a continuous infusion epidural analgesia is recommended in such patients. What are the drugs to be used? We can use lower concentration local anesthetic combined with opioids, and patient-controlled epidural analgesia should be promoted in these patients. So what are the advantages of this technique? The advantage is an intrathecal opioid in the first stage provides excellent analgesia without any sympathetic blockade. And during the second stage, as we discussed in the case, epidural analgesia will facilitate a gradual increase in the venous capacitance. So it accommodates any acute increase in the venous return of the patients, therefore preventing postpartum pulmonary edema. And it also provides uninterrupted pain relief to the patient. So what are the drugs used? We can use local anesthetic injection bupivacaine in the dose of 0.0625 to 0.125% or ropivacaine 0.1 to 0.2%. Along with opioids, commonly used is injection fentanyl 1 to 2 mics per ml. So is a test dose recommended? Ideally, the test dose should include lignocaine, and low dose of lignocaine anesthetic in aliquots is to be given. And adrenaline should be avoided because it can precipitate tachycardia in these patients. Now, coming to the advantages and disadvantages of a general versus regional anesthesia in a patient of cesarean section. General anesthesia, though it provides a better secured airway and control over the ventilatory parameters, however, it has certain disadvantages which preclude its use, which include difficult airway in obstetric patients. A laryngoscopy and intubation attempt will cause tachycardia, and positive pressure ventilation can eventually, after removing the patient from positive pressure ventilation, can worsen the pulmonary artery hypertension also. Therefore, regional anesthesia has certain advantages. First is the rapid onset. It has improved analgesia. We have the ability to titrate the dose and also use low dose spinal. There is a room for postoperative analgesia. It avoids airway manipulation, and the incidence of deep vein thrombosis is decreased in patients with regional anesthesia. So how do we institute a regional anesthesia for cesarean section? Ideally, in patients who have moderate to severe heart disease, it is a fixed cardiac output state, and therefore single shot spinal anesthesia is not recommended. The recommended technique is a graded epidural analgesia, and graded epidural should be instituted, as discussed in our case, with low dose of 2% lignocaine in aliquots, and a surgical anesthesia level of T4 to T6 should be achieved. A non-invasive cardiac output monitoring is used in these patients, and hypotension should be very aggressively monitored and managed. The vasopressor commonly used is phenylephrine rather than ephedrine. And oxytocin or methergin, what is the uterotonic agent used? Oxytocin should be used as an infusion. Boluses should be avoided because they precipitate tachycardia. Methergin is largely contraindicated in these patients. Now, a word about the graded epidural technique, which is largely practiced. It is the preferred mode because it provides gradual onset sympathectomy of the epidural local anesthesia. The commonly used injection is 2% lidocaine given in small aliquots every 3 to 5 minutes, titrated to achieve a surgical level of T4 to T6. What is the advantage? It helps increase the venous capacitance and accommodate blood volume, thereby reducing the chances of pulmonary edema and providing adequate pain relief to these patients, therefore preventing all such hemodynamic consequences like tachycardia and tachypnea in these patients. Now, a word about the general anesthesia for cesarean section. It is ideally given with modified rapid sequence induction with a cuffed endotracheal tube on mechanical ventilation. Standard ASA monitors should be used, and arterial cannulation is ideally not included in the guidelines. However, in severe mitral stenosis patients, it should be given so as to have a beat-to-beat monitoring of the blood pressure. Injection etomidate is commonly used because it is a very cardiostable agent, and succinylcholine is used in modified rapid sequence induction. Maintenance is done with sevoflurane and bolus doses of vecuronium or rocuronium as the muscle relaxant. Opioids, if at all, are used earlier. The pediatrician should be informed so that they can anticipate neonatal respiratory depression. Otherwise, after the delivery of the baby, injection fentanyl is commonly used. What are the drugs to be avoided? the drugs should be propofol, ketamine, pancuronium, atracurium, nitrous oxide, and methyl ergometrin. They need to be avoided because of their hemodynamic effects. And oxytocin should be instituted as an infusion rather than a bolus. Fluid management should be done very judiciously and guided. We need to avoid both hyper and hypovolemia, and hypotension should be aggressively managed with phenylephrine. So what are the uterotonic drugs? Though we have methyl ergometrin, oxytocin, and prostaglandins, the commonly used agent is oxytocin, and it is given as an acute bolus. But in these patients, a continuous low dose infusion is preferable in the dose of 0.3 to 0.9 international units per minute IV. Coming on to the post-operative care after general anesthesia, these patients should be shifted to ICU for a minimum of 24 to 48 hours, whether extubated or whether intubated, because they are at the risk of arrhythmia and heart failure in the postpartum period due to autotransfusion. And continuous cardiac monitoring is given as per the individual patient requirement. Propped up position needs to be maintained to reduce the preload. Continue the nil per oral until the bowel movements are adequate. Continue with oxygen supplementation. Fluid management is done according to the hemodynamic parameters, and adequate analgesia should be given with paracetamol, NSAIDs, and opioids, and temperature monitoring needs to be done. While after regional anesthesia, the patient is again shifted to an HDU or ICU for monitoring. Epidural analgesia should be continued in the postpartum period so as to promote peripheral vasodilation so that it can accommodate the autotransfused blood volume and decrease the probability of heart failure in these patients. It should also be adequate analgesia should be maintained. Propped up position is maintained in these patients. And if at all regional anesthesia was given, then we continue with the post-operative low molecular weight heparin as follows, which is given here. A single dose is instituted after 6 to 8 hours, while double dose is instituted after the first 24 hours. The catheter is removed after 10 to 12 hours after the single dose and 24 hours after the double dose. So what are the causes of mortality in these patients? It is largely untreated mitral stenosis causing progressive pulmonary and systemic congestion, followed by systemic embolism, pulmonary embolism, and infection. Therefore, to sum it up, we need to understand the changes in patients' pathophysiology, the impact of pharmacotherapy on physiological and peripartum status to manage these patients optimally. Because the alterations continue after first 24 hours after the delivery, adequate cardiovascular monitoring should be maintained from peripartum to the postpartum period so as to reduce the morbidity and mortality in these patients. Thank you so much for your patience. Thank you.
Okay, so that was very nicely presented and very comprehensive. Thank you, Dr. Alisha. Now, back to the thing. Do we have any questions?
Ma'am, no questions yet in the chat box. I guess there's no room for questions. The whole discussion was so detailed and every aspect has been covered. Just let me confirm. Do we have any questions in the chat box? I don't think so. I can't see any. No, ma'am. None.
Okay, so thank you for the thank you to the organizers for giving this opportunity and doing the case presentation. And Dr. Alisha has done a very good job of giving a very comprehensive presentation, and Dr. Subhajit did the case presentation. So thank you, both of you.
Thank you so much, Kirti ma'am. It was a very, very fruitful, and I'm sure our PGs would be greatly benefited by this discussion. This is one case, there are definitely few of them are going to get this case. So thank you so much, ma'am. And good job, Subhajit and Alisha.
Just they'll get this case. They'll get this case during their practice also. After doing MD, many of them will become senior residents or go into practice, and they will be getting these cases.
Ma'am, could we take a couple of minutes? There's a question in the chat box. I'll just get it reflected.
Yeah.
Ma'am, the question is, what about securing CVP line in this case?
No, there is no need for CVP line because CVP line does not help. There is a stenosis. So CVP does not reflect the status of filling. Patient was in failure earlier. That is why she was given this treatment. And catheters have their own drawbacks. So catheters can introduce infections in these patients and they do not give us useful information. It is better to go for non-invasive monitoring. So fluid status will be given by ultrasound. Okay. By seeing the IVC collapsibility and by seeing the pressures. So these are better ways of monitoring, and their transthoracic impedance monitoring can also be done. Echocardiography and impedance can also be used. So now we have non-invasive, very good non-invasive cardiac monitors also, which give you all the information about cardiac failure. And these cases should not be done in the peripheral centers. They should go to a tertiary care center. So in a tertiary care center, you are likely to have these such monitors and have ultrasound availability.
Right. Okay, thank you. Thank you so much, ma'am. So by that, we wind up this session. Thank you once again, ma'am. Thank you, Subhajit and Alicia. So with that, we move on to the next part of the session. May I now invite our next chairperson, Dr. Anil Kumar Verma, sir. Sir is a professor and head of department at GSVA Medical College, Kanpur. His area of interest are regional anesthesia, hypotensive anesthesia and ventilation, difficult airway management, and hemodynamic monitoring. Sir is the president RSACP Uttar Pradesh. He's an elect ICCM Uttar Pradesh. He was a past president ISA Uttar Pradesh. He has various publications in national and international journals and chapters in bench to bedside critical care medicine and yearbook of anesthesiology and patent of product of AM Bronco Trainer. We welcome you, sir.
Thank you very much, madam. So, first of all, I convey my thanks to the organizing committee regarding it. So, madam, please, would you be okay to introduce the speaker?
Sure. The speaker of the lecture, we welcome you, Dr. Manpreet Singh. So,
Thank you so much.
Sir would be talking on the breathing circuit, soda lime and circle system. Sir is a professor in Government Medical College and Hospital, Chandigarh. He has been awarded with State Award of Meritorious Extraordinary Services of Oxygen Management in Chandigarh, Indusem Award by Dr. Kelly Cafe as Academician of the Year 2019. And he has many manuscripts in his name, around 127. He has around 75 chapters published. He has been a guide for 38 theses. He has edited 2 books. He has attended many conferences as a guest faculty, and various. Sir is owner of many fellowships. We welcome you, sir.
Thank you so much. Am I audible?
Yes, sir. Yes, so you are.
Okay.
Could we have the presentation, please?
Thank you, Dr. Anil.
Welcome, Dr. Manpreet.
Thank you so much. Good afternoon, all. I am Manpreet Singh from Chandigarh. I am thankful to Appec 2025, which is 7 days of rigorous online learning, which is done by Department of Anesthesia, ABVIMS, Dr. RML Hospital. So the important thing is I am given the topic very important, which is everyone is fond of asking in the table viva, that is the breathing circuits, soda lime, and the circle system. So let's see the objectives of this lecture. It is the definition, function, and classification, components, the functional analysis, and the circuit checks and closed circuits.
The breathing circuit is an assembly of components connecting the patient's airway to the anesthesia machine. It delivers the anesthetic gas mixture from the anesthesia machine to patient's alveoli in a set concentration, shortest possible time, and minimal rebreathing and minimal resistance. The essential functions of the breathing circuit are delivery of anesthesia gas mixture, then carbon dioxide elimination, then conservation of heat and moisture, and it is used in spontaneous or assisted or controlled respiration. If you see this, the ideal breathing circuit, it is quick and accurate delivery of the anesthesia gas mixture which is given. Then there is an effective elimination of carbon dioxide, conserves the heat and the moisture, minimal resistance, minimal dead space, most economic and easy to use and sterilize. The main classification is open system. Then open system is when there is no reservoir, no breathing, rebreathing, no carbon dioxide absorber. Patient breathes ambient air directly. An example is the open drop ether, which is a shimble mask, which is not used nowadays because of the safety and the control issues. Then there is a semi-open system, which is the fresh gas flow is much higher than the minute ventilation. There is no rebreathing, no carbon dioxide absorber, and high gas wastage is there, but prevents the carbon dioxide buildup. Examples are Mapleson A2F, Jackson Rees modification, and Bain septic. Then we have third one, which is a semi-closed system, which is a partial rebreathing of the exhaled gases. Carbon dioxide absorber may or may not be used. Moderate fresh gas flows are there, and examples are the Mapleson circuits with lower fresh gas flows, circle system without complete carbon dioxide absorption. Closed system, you all know, that is the fourth one. That is a complete rebreathing is there. No gas is lost to the atmosphere. Carbon dioxide absorbed chemically with the soda lime or the other one. Then very low fresh gas flow may be required, and it requires tight control of gases, pressures, and composition. You all know the example is circle breathing system with low fresh gas flow and a circle carbon dioxide absorbed. So this classification was given by Drips, and then later on given by the Conway, which is the modified Conway's classification, that with the CO2 breathing circuits with CO2 absorption, when there is unidirectional flow, that is closed circuit, bidirectional flow when it is a waters to and fro circuit. Without carbon dioxide absorption, that is unidirectional flow is Mapleson A with non-rebreathing valve, then bidirectional flow when the Mapleson A to F. If there is third is the afferent reservoir system, Mapleson ABC, efferent reservoir system, that is a Mapleson DEF. So Mapleson's breathing circuit can be, they have the components like breathing tubes, adjustable pressure limiting valve, reservoir bag, and connectors and adapters. If you see the breathing tubes, it's a large bore, minimal resistance, corrugated flexibility, and prevents the kinking. It acts as a reservoir in some circuits. Distensibility is present, but cannot prevent the excessive pressure. Then adults have 22 millimeter of wide, and pediatric has 15 millimeter wide diameter, and then silicone, rubber, or plastic is the material with which these breathing tubes are formed. Then there is a reservoir. If you see that, then there is an adjustable pressure limiting valve. It can be called as pop-up valve, as expiratory valve, scavenger valve, anything. It has a one-way adjustable spring-loaded valve. You can see this diagram. And whenever there is an increase in the pressure of the circuit, then the excessive pressure exceeds the valve opening pressure. It raises the valve, or you can adjust according to the pressure which is required in the breathing system. Reservoir bag is the next part. It is from 0.5 liters to 3 liters size, highly extensive, but it has a distensible part of the breathing system, and it prevents the barotrauma because it goes with the extra pressures also, and monitors the patient's ventilatory pattern also, and it is used to assist or control the ventilation. It accumulates the fresh gas flow during the expiration reservoir for the peak inspiratory flow 3 to 4 minute ventilation. There are connectors which connect from one part of the circuit to the other, and it increases the dead space and resistance, increases the chances of disconnection. Let's discuss now Mapleson circuits which are available. Mapleson's A circuit. It is also called as McGill circuit, and it has a fresh gas flow away from the patient but near to the reservoir bag. This is the fresh gas flow. You can see this, follow this cursor. This is the reservoir bag, and this is the APL valve, and this is the patient sink. So it is away from the fresh gas flow is away from the patient sink. APL valve is near to the patient sink. Then functional analysis, we can see that there is a fresh gas flow which goes from here, and then bag is immediately near to that, equal to one time the minute ventilation or the spontaneous ventilation. Preferred for spontaneous ventilation, and negligible rebreathing is there in the spontaneous breathing. In the controlled ventilation, this circuit has a APL valve partially closed. Fresh gas flow is increased 3 times the minute ventilation for controlled ventilation. There is excessive rebreathing, waste of gases, and not preferred for controlled ventilation. If you see this, the advantages are it is best for spontaneous ventilation, less fresh gas flows for spontaneous breathing. Disadvantages are rebreathing, waste of gases, may cause OT pollution, not suitable for controlled ventilation. Then there is a lax modification. It is what happens is that expiratory limb is added in between the expiratory, inspiratory, this limb, which was available in the Mapleson A. So, and there is an addition of scavenging system here, and the APL valve, thus it is close to the fresh gas flow and the reservoir bag. It can be in the parallel tube, or it can be on the coaxial configuration. This is the coaxial configuration, and this is the parallel one. Both are shown in this same diagram. So this is the lax modification which is available as a circuit. Now checking of the circuit, Mapleson A, occlude the patient end, close the APL valve, and pressurize the system. APL valve can be controlled by opening and closing it. Lax system, there is an integrity of the inner tube. There is attach for the integrity of the inner tube, you can always check. Attach a tracheal tube to the inner tubing at the patient end. Blow down the tube with the APL valve closed. There will be movement of the bag if there is leak between the two tubes. If there is no leak, there will be no movement. Second is you occlude both the limbs at the patient's connection with the valve open, and then squeeze the bag. If there is leak in the inner limb, gas will escape through the valve and the gas will collapse. Bag will collapse. Otherwise, the bag will not collapse. In Mapleson's B and C circuit, it is similar to each other. If you see, this is the B circuit, this is the C circuit. In B circuit, the fresh gas flow is near to the APL valve. In C circuit also, it is near to the, both are things are nearer. Then there is a reservoir bag with the corrugated tubing. This corrugated tubing is characteristic of the Mapleson's B circuit, whereas there is no corrugated tube inside the C circuit, and this is the C circuit. So very high fresh gas flow is required. It may cause OT pollution, wastage, and it is always non-economical. That's why these two circuits are not used nowadays in the routine practice. Water's to and fro circuit, if you have heard of that, I'll show you the slide later. It is same as the C circuit. Then we have Mapleson's D circuit, which is the most efficient for control ventilation. Here the fresh gas flow is nearer to the patient end, so more of oxygen goes into the patient directly without any rebreathing. and there is a APL valve which is present here near the bag. So before filling to the bag, the expired air carbon dioxide goes from here out. So it is most efficient for controlled ventilation. T-piece is one and FGF tube. This is the T-piece it makes, patient end, and then this corrugated tubing and the fresh gas flow. And 6 millimeter of diameter tube supplies the fresh gas flow from machine end. This efficiently gives with the high velocity of the fresh gas flow. Bain circuit is modified D circuit. If you see that in this is the Bain circuit which you are daily using, it has a fresh gas flow which runs coaxially inside the corrugated tubing. Diameter of outer tube is 22 millimeter, inner tubing is 6 millimeters, and length is 1.8 meters. Remember this. The volume of air which can be there is more than 500 ml. So outer tube is transparent so that the inner tube can be easily seen if it is kinked or it is disconnected. So if you see this Bain system, it is very simple. There is a APL valve here. It is a machine end and the reservoir bag is here only. This is the patient's end. From here the patient, and this is the fresh gas flow which is after the valve. Then this tubing goes from inside and fresh gas flow with the high velocity goes into the patient. When the patient expires, it cannot go into the fresh gas flow tubing because it is of the high velocity. So it goes into the outer tubing, which is a corrugated expired tube. And then from here, APL valve, it is released outside. This is how it works. And in the spontaneous respiration, APL valve is fully open, minimal rebreathing, fresh gas flow should be 1.5 to 2 times of minute ventilation. The factors influencing rebreathing are fresh gas flow, respiratory rate, expiratory pause, and then tidal volume. And in the controlled ventilation, APL valve is partially closed. Minimal rebreathing is there. The rest of things are similar of the spontaneous ventilation. So advantages are in the Bain circuit is of lightweight, minimal drag, low resistance, used for both spontaneous and controlled ventilation. Then length is long where patient is not accessible as in MRI suites while transporting the patient from one place to the other place for dialysis when the patient is shifted from ICUs to the other places. When the patient is shifted from the operation theaters to the ICUs, this is all from inter-hospital and intra-hospital transfers. This circuit is commonly used. The warming of the inspired fresh gas is the advantage by the exhaled gas which is present in the outer tubing. Disadvantages are there are multiple connections. There is a risk of disconnection. Wrong assembling is there, that is malfunction of the circuit. Then there can be high fresh gas flow may cause the theater pollution and increased cost. Then there can be damaged fresh gas supply inner tube blocking. This may cause the hypoxia or hypercarbia and may cause the delayed recovery of the patient, or due to hypoxia, patient go into the desaturation. So it cannot be used in pediatric patients weight less than 20 kgs. How to check the Mappleson's T circuit? You occlude the patient's end, close the APL valve and pressurize the system. Open the APL valve, the bag should deflate easily. Outer tube integrity, you can always check with the wet hands with spirit. Blow the air through the tube, wipe the tube with wet hands, and then leak will be produced, chillness into the hands. Then how to check the Bain circuit? There is a Fox Crompton Smith test that checks the integrity of the inner tube. Set the flow at 4 to 6 liters per minute. Occlude the inner tube at patient's end. Observe the flow meter indicator. If the inner tube is intact and correctly connected, the indicator will fall. Now, second test is the Appec test, which is the activate the oxygen flush and observe the band. Due to Venturi effect, the high flow from the inner tube to the patient and will create a negative pressure in the outer exhalation tubing and this will suck gas from the bag and bag will deflate. So when the bag will deflate, this means that there is an inner tube intact. If the bag is further inflated, this means the inner tube is damaged. Mappeson's E circuit is a IRS T-piece. If you see this, it was given by Phillips at 1937. It has this type of T-piece where a fresh gas flow comes from here and then reservoir tubing is attached here and to the patient it goes from here. So one metal tube, 1 centimeter diameter, 5 centimeter length with the side arms. These things are asked commonly by the examiners when you are given this circuit. Functional analysis is that it functions as a non-rebreathing system. Fresh gas flow enters through the side arm. Expired gas is vented into the atmosphere, and there is no rebreathing and requires high fresh gas flow. The Mappeson's E circuit is another circuit which is in which the reservoir tubing at the expiration port is there. This is the reservoir tubing. If you see, it is when T-piece is attached to the reservoir tubing. So what happens is this T-piece functions as a IRS T-piece and Mapleson E corrugated tubing is added without any bag. So it has a capacity more than expected tidal volume. In Mappeson's F circuit, it was the bag was attached here in the E circuit. Rest of things are same. If you see, a bag is attached and there is a valve here on the open tail end or valve at the tail end. Here it is, earlier it was open tail end. The bag was cut from here, or here the valve was attached. So what happens is you can control the ventilation through the closing, partially closing and opening of the valve. So the gases went out, excessive gases went out from here, and it is useful in controlled ventilation. It is used in neonates, pediatrics, infants, patients. The fresh gas flow required in this is 2 to 3 times a minute ventilation. Now the functional analysis is that there is advantages of this circuit. It is easy to assemble, inexpensive, low resistance system due to absence of valves, and lightweight. Disadvantage is high fresh gas flows are required. It may cause atmospheric pollution. There is no humidification of the gases, and barotrauma can be there with overinflation during the controlled ventilation. This is the table which is a summary of all the circuits. If you see that the position of fresh gas flow in the reservoir bag and APL valve, this all differentiates the positions, differentiate from circuit A to F, and then this on the right corner, it is the how much time you have to give the minute ventilation so that it functions properly. So Mapleson A requires 0.8 to 1 times, that is spontaneously breathing patients, and then 1.5 to 2 in B and C, 2 to 3 in D, E, and F. This is another table which is given here. I will give you the slides later on. You can get it from the organizers. A to F, it is the location of fresh gas inlet, valve location, reservoir bag, and corrugated tubing present or not, and what is the example of this. This clearly depicts all the circuits in detail. This is a mnemonic which is given. I have taken this slide from the internet for you. And this is I found it very good. So I added it here in my lecture. A, B, C, D, and E, and F. The A is for APL, APL at patient's end. B is both APL and fresh gas flow at patient's end. C is the corrugation tube is absent into the C circuit. D is distal APL and APL located distal from the patient's end. E is there is a elimination of the reservoir bag, and F is free from APL. There is no APL in these patients, in these circuits. So best circuit is spontaneous circulation. You can remember like this, all dogs can bark, A, D, C, B. Controlled ventilation, you can remember dead bodies cannot argue, so DBCA. So this is how it is. Later, you can remember this. This is the waters to and fro I was saying. This is the canister of closed this chemical soda line which is attached here in between. Otherwise, it is a C circuit in which the closed circuit is attached. So it is a circuit with carbon dioxide absorption. This is now the next topic is closed circuit or circle system. This is the important thing because nowadays in all the anesthesia workstations, you are using the closed circuit and circle systems, which are useful for the low flow anesthesia. So it saves our anesthesia drugs, prevents the OT pollution, and helps in the scavenging of these drugs indirectly. So if you see this closed circuit, the whole circuit, this is the patient end. From here, there is a expiratory limb where there is a expiratory valve present, and then after that expiratory valve, the gases go into the carbon dioxide canister, this absorber canister, and some into the breathing bag. Here the ventilator is attached, and there is a pressure release valve. Whenever there is increased pressure, it is released. And then in this, the circle absorber, the carbon dioxide is absorbed, and then the oxygen is released, and then it comes from here with the addition of the fresh gas flow, and then from here it goes into the inspiratory limb, and then patient takes the inspiration. Principles of circle system are unidirectional valves must be placed between patient and the bag. Then fresh gas flows either upstream or downstream of inspiratory unidirectional valve. APL valve must be between the expiratory unidirectional valve and the canister. So remember how the valve positions are there, which control the rebreathing and control the absorption of the carbon dioxide. These are the canisters which are available. It is two-chambered or single-chambered. Most of the times, two-chambered are used. It is each chamber has 900 grams of soda lime, and total volume is 1800 grams in the two-chambered. Carbon dioxide absorption is there, 26 liters carbon dioxide in 100 grams. It is absorbed. Efficiency after channeling is 20 liters per 100 grams. 1800 grams soda lime will absorb 360 liters carbon dioxide. 12 liters carbon dioxide is produced every hour, and 1800 grams canister will last for 30 hours. These are the characteristics you should all remember because this can be asked in any of the examinations. Soda lime and absorb are the two types of carbon dioxide absorbers. So in soda lime, there is a calcium hydroxide 85%, sodium hydroxide 3 to 5%, and potassium hydroxide 1 to 2%. In absorb, which is latest, that is the calcium hydroxide 75%, calcium chloride 1%, 14 to 19% of water in both, and then silica for hardening and to reduce the formation of the dust. This is the characteristic of the newer one. And 4 to 8 size granules are there. Reactions, if you see with the inhalational agents in soda lime, it is highly alkaline, pH 12, and reacts with sevoflurane and produces the compound A, which is the nephrotoxic. So in the larger concentrations of sevoflurane, it produces compound A. In absorb, it is a less alkaline, does not react with inhalational agents, but it is very costly because of its lightweight, and it is available with the smaller sizes, and it is so thus it's a costly. When you see the indicators which are put into the soda lime, that is a phenolphthalein, ethyl violet, Clayton yellow, ethyl orange, mimosa Z. These are the 5 types of indicators, but commonly used are phenolphthalein and ethyl violet, which turns from white to pink or white to purple. So normally it comes with the white and it turns into the pink or from white to purple. Reaction of the soda lime, you can see that carbon dioxide from the expired gas adds with the water and it forms the sodium, the H2CO3, and then ultimately it releases the water and it really forms this NaOH and KOH plus calcium carbon. So carbon dioxide wholly is absorbed. Second thing is it is an exothermic reaction. It may increase the temperature of the, if more carbon dioxide is formed and there is a soda lime is expired one, then it may cause the warmth, the temperature of the soda lime covering is, or the in which the soda lime is put, that can become the hot one or the warm one. So that is the indicator now that you have to change the soda lime. The another important advantages are the closed circuits have conserved heat and humidity. They are cost effective, reduces the atmospheric OT pollution. Disadvantages are it needs vigilance, extensive monitoring of gases, accumulation of the byproducts. The important thing which I want to say about soda lime is it is an exothermic reaction. So when the important question next comes is, when do you want to change when do you know that it is the time to change now the canister, the soda lime from the canisters? One is when the temperature of the canister starts increasing. Second point is when the color of the indicator changes from white to the whatever indicator which is put inside, and it changes from one color to the other color. Third is that when the EtCO2 starts rising and the inspired carbon dioxide increases in the monitor, then it from 1 to 3. This means now it is highly time to change the soda lime. This is the important thing which is to be remembered, and it is always asked into the examinations. So the points to ponder about the breathing circuits are: Mappleson's A circuit is for spontaneous ventilation. Bain circuit is for universal circuit. It is a universal circuit, can be used for both spontaneous and the controlled ventilation. Then closed circuit is most economical and prevents the pollution. Nowadays, it can be used for the low flow anesthesia with the proper monitoring of EtCO2 and the gas concentrations. So best of luck and thanks. Any questions you want to ask, you can always ask me. And my WhatsApp number and email is mentioned here.
So there's a question in the chat box. Could I ask that?
Yes,
Manpreet
please.
sir, can you hear me? Yeah. The question is, some old Mapleson A black colored circuit. It has a switch at the back side. What is its use?
Hello.
Hello, sir. Should I repeat the question?
Yes.
Some old Mapleson A black colored circuits have a switch at the back side. What is its use?
That was just for the opening of the circuit, I think. That was not for any other purpose. And that was older in the heavy circuits. It was given this privilege in the Boyle's machines. And these circuits are not now used, as these are just for putting in the museum now. So it was just for
Right.
opening the circuits for the fresh gas flow.
Okay, so that's it. We don't have any other question in the chat box. Dr. Anil, sir, you want to give some inputs or add something to the presentation?
Yes, Dr. Manpreet, first of all, I just congratulate you for such a concise presentation, because it is always confusing to the students to find out which circuit is which one. And probably has been given in such a concise manner. That's why that is the reason why the questions are not available. But the
Sir,
point is
could you
very
switch on
well
your
raised.
camera, please, sir?
Okay, fine.
And Manpreet sir as well.
Yeah. Is it okay?
Yes, sir.
Yeah.
Fine. So, in the breathing circuit, Dr. Manpreet has already raised certain issues, like certain points which has to be kept in mind by the students. First of all, the identification of the Mapleson A and Mapleson D circuit. One very favorite questions by the examiners, that the Bain circuit is the modification of which circuit, and what is the basic modification which is being found. And the third one is the Jackson-Lee circuit. and the ISTPs. So they are being very well covered and wonderfully talked about the closed circle system. So hopefully there's nothing left. That's why students are quite satisfied with the presentation.
Thank you so much. Thank you, Dr. Anil. And the circuit
Okay.
part is very important, actually. So in every exam, it is asked, and they give you the three parts. And then every examiner is fond of asking which circuit, make this circuit, make this circuit. Then that is the main thing when you have to read the whole physiology, how the fresh gas flow goes inside, and then how from where the expired air comes. If you understand that, the students understand that, that is the best thing. You don't have to mug it up everything. So it's a very
Yeah.
simple, yeah.
And many times the parts of the spare parts, the accessories are being wrongly connected with the circuit.
Yeah.
And they found difficult to ventilate the patient, and that may also lead to raised CO2 because of rebreathing is continuously over there.
Yeah.
So that is very important.
Thank you so much. Thank you, organizers, for giving me the opportunity.
Thank you so much, Manpreet
Thank-
sir. It was an excellent presentation, and I think it made things very easy for our PG students because this is an often asked questions and looks pretty complicated. You have made it really easy. Thank you,
Thank you
Manpreet
so
sir.
much. Thanks a lot.
And
Thank
thank you,
you very
Anil
much.
sir, for your useful
Thank you very much.
inputs. Thank you so much, sir. Thank you.
Thank you.
So next, before breaking in for the lunch, I'd like to display two more quiz questions or MCQs for the day. Could we have the MCQs? So the first question is, which circuit is best for spontaneous breathing? A, Mapleson E, B, Mapleson F, C, Mapleson A, and D, Mapleson D. Question number 2. A 23-year-old primary gravida, G1B0, at full term with known severe mitral stenosis is scheduled for an elective LSCS. Which of the following is the most appropriate anesthetic plan for this patient? A, general anesthesia with rapid sequence induction. B, spinal anesthesia with a standard dose of local anesthetic. C, combined spinal epidural anesthesia with slow titration of local anesthetic. D, epidural anesthesia with bolus doses of local anesthetic. So we'll be back at 2 o'clock with the answers of these questions. So we'll break for lunch right now, and it's almost, it's 1:51. See you at 2 p.m. Thank you so much. Good afternoon. Can we resume? Good afternoon, sir. Dr.
Good afternoon,
Amitabh
ma'am.
Datta.
How are you?
Sir, I'm good. Thank you, sir. We'll just, I'll tell the answers for the MCQs that we asked before the lunch.
Yes, please, ma'am.
Yeah. The answer to question 1 is the circuit which is best for spontaneous ventilation is, as we know, answer C, Mapleson A circuit. And the second question, that was a clinical situation. Question 2, the answer to that is combined spinal epidural anesthesia with slow titration of local anesthetic, that is C. Thank you. So with that, we resume our day with the first session post-lunch. So it's our pleasure, Dr. Amitabh Datta, to welcome you on board. And sir is an MD from PGI Chandigarh. Sir is a senior consultant and professor at the Institute of... sir, just sorry, the slide is not clear to me.
No problem, ma'am.
Okay. At the Institute of Anesthesiology. He's a member of Ethics Committee at Sir Gangaram Hospital. Sir is a chairman of Ethics Committee at Fortis Hospital, Vasant Kunj. Sir is from, as we all know, Sir Gangaram Hospital. He has over 100 publications. Thank you, sir. So welcome.
Thank you, ma'am.
And the speaker for this session is Dr. Dhirja Sharma. Ma'am would be speaking on ethics and informed consent in anesthesia. So would you like to introduce ma'am, please?
Yeah. Good afternoon, everybody. Today we are going to venture into an area which is we don't naturally go into in anesthesia practice and academics, but I am happy that APPEC 2025 has chosen to take up this area and disseminate the idea around informed consent and overall ethics in anesthesia. So with this, I will welcome Dr. Dhirja Sharma, who is medical advisor, Venture Brick, Max Healthcare. And she has a lot of achievements, as we can see. And her area of interest is medical ethics and quality and AI in healthcare. She will be delivering lecture on ethics in anesthesia and informed consent. Welcome, Dr. Dhirja. You may please start.
Thank you.
Please, ma'am.
Today, I will be talking about ethics in anesthesia and informed consent. This is the topic which is something that we usually don't talk about, but it is very important in practical day-to-day life of an anesthesiologist. What is medical ethics? Medical ethics is a specialized branch of ethics that focuses on applying moral principles and values to the practice of medicine and scientific research. It provides a framework for healthcare professionals to make ethical judgments and guide their behavior in complex situations. Medical ethics is rooted in the tradition and practices of medicine, emphasizing the fundamental obligation to protect and promote the health and well-being of patients. We are all aware of the Hippocrates Oath. From ancient time onwards, doctors have been exhorted to do good, avoid harm, and remain free of intentional injury. Three of the classic principles that are cited as the core of moral practice of medicine, that is medical ethics. What are the goals of ethics education? To appreciate ethical dimensions of patient care, we must educate to understand the ethical principles of medical profession, to have competence in core ethical behavioral skills such as obtaining informed consent, assessing decision-making capacities, discussing resuscitation status, and use of life resuscitating sustaining treatments, advanced care planning, breaking bad news, and effective communication. To know the commonly encountered ethical issues in general and in anesthesia, to have competence in analyzing and resolving ethical problems, and to appreciate cultural diversity and its impact on ethics. The practice of anesthesia involves unique ethical challenges due to patients' vulnerability. Ethical practical principles guide decision-making in patient care, ensuring patient autonomy, beneficence, non-maleficence, and justice. Informed consent is a crucial component of ethical anesthetic practice, safeguarding patient rights and fostering trust. Anesthesia is a specialty which was amongst the first ones to talk about bioethics and medical ethics. As early as 1957, Pope Pius XII was invited to address the International Congress of Anesthesiologists about such fundamental issues as whether the use of artificial respiratory equipment was required in even hopeless cases, whether the physicians were under obligation to remove such therapy, if such withdrawal will result in imminent patient death, and whether permanently comatose patient can be considered dead even before circulation has ceased. John J. Bonica, the first chair of anesthesiology at University of Washington in Seattle, was an early advocate for labor analgesia at a time when religious institutions considered pain relief for laboring women, morally controversial. Thus, at that time, his research and his views were considered unethical, while today they will form a core of ethics of obstetrical anesthesia. There are 4 core principles of ethics, the first being beneficence. That is, the anesthesiologist's primary duty is to act in the best interest of patient, aiming to do good and promote their welfare. This includes preserving life, restoring health, relieving suffering, and maintaining or restoring function. Now, interesting dilemma which often an anesthesiologist may come across with respect to this core principle is in case of obstetrical anesthesia, where sometimes what is correct for the mother may be at crossroads with what is best for the fetus. In which case, what is the anesthesiologist to do? But remember, for us, mother is our patient. The first patient is the mother. Therefore, oftentimes an anesthesiologist may put the mother's concerns first and override the fetal concerns, if such a dilemma does occur. Non-maleficence is the principle which emphasizes the obligation to do no harm. While many anesthetic procedures carry inherent risks, the anesthesiologist must carefully weigh the benefits against potential burdens and avoid any intervention that is inappropriately burdensome or with which they are unfamiliar or unskilled. A very important principle to remember for all anesthesiologists. If there is an anesthesia procedure, anesthesia skill you are unfamiliar with or not skilled enough, then please do not do it on the patient. It is important to first get credentialing for that particular skill before anesthetizing the patient with it. Autonomy is respecting the patient, meaning acknowledging their right to make informed decisions about healthcare, including accepting or refusing diagnostic or therapeutic interventions. This forms the basis of informed consent. Justice is the principle which calls for fair, equitable, and appropriate treatment of all patients, regardless of factors like race, social standing, or religion. It also relates to the ethical distribution of healthcare resources. Patient vulnerability and dignity is very special in an anesthetized patient because they are particularly vulnerable, and the anesthesiologist has a responsibility to protect the physical and psychological safety, comfort, and dignity. A very small example. When and patient is anesthetized, then a simple act of unclothing the patient is something an anesthesiologist should be intervening in if there is an ethical dilemma with respect to patient's cultural belief or patient's own bodily dignity. Maintaining patient modesty and respecting feelings and safeguarding confidential information are crucial aspects of this responsibility. In today's time, when we are increasingly using electronic health records, confidentiality of patient data is a factor which an anesthesiologist must be cognizant with. In end-of-life care, ethical dilemmas surrounding do not resuscitate orders and the discontinuation of life-sustaining treatment are particularly relevant in anesthesia. Discussions and guidelines exist to respect patients' wishes and navigate conflicts between patient autonomy, family preferences, and physician obligations. The Supreme Court has now allowed in India the writing of living will, and we will increasingly encounter patients who have given the orders for how they want to be treated at the end of life. Now, as per the ethical principles, we must honor the patient's living will or honor the patient's end-of-life directive. However, when the patient is already comatose, many times the decision-making is done by the surrogate decision-maker, such as family member, and their decisions may be at variance with the patient's own decision. And that is a dilemma an anesthesiologist needs to tackle. Early terminal sedation in palliative care is another ethical dilemma in end-of-life care. There's a school which says that early terminal sedation hastens death in end-of-life care and therefore should not be administered, while there is another school which says that early terminal sedation markedly improves the quality of life in end of life and should be offered to the patient as soon as possible. Now, interprofessional relationships are very important as anesthesiologists interact with diverse teams, including surgeon, nurses, and technicians. Ethical challenges can arise from differing opinions on patient management, workload distribution, communication breakdown, and potential inadequacy or incompatibility within the surgical teams. These are situations that as anesthesiologists we encounter every day. The surgical colleagues have their own perioperative management principles, while anesthesiologists may insist on another perioperative management principle. We actually come across where the surgical teams may not have competence to do the procedure, but they're undergoing, and that is an ethical dilemma the anesthesiologist has to face. Anesthesiologists play a role in research and have ethical obligations to protect human subjects and maintain the integrity of scientific research and publications. Addressing issues like research fraud, data fabrication, ensuring proper ethical review, and informed consent for research participants are vital for anesthesiologists. Decision regarding the allocation of scarce resources, for example, equipment and medication, may arise, requiring anesthesiologists to uphold the principle of distributive justice. Another common day-to-day occurrence for us is the emergency cesarean, which comes to disrupt the normal routine list going on. And we know what is the ethical decision in such a case. Maintaining professional competence and skill is a primary ethical duty. Recognizing and addressing conflicts of interest, including financial relationship with industry or institution, is also essential. Addressing issues like physician impairment, physical or mental, and ensuring safe and ethical practice for themselves and their colleagues are also part of their ethical responsibility. If you see a friend who's running a fever, not feeling well, or who's been doing duty for maybe 36 hours, is too sleepy, then please ensure that he or she is not asked to do anesthesia duty or give anesthesia to a patient. That is the correct ethical behavior. Addressing ethical issues requires adequate training and education for anesthesiologists, including during residency training, like we are doing today. Continuing education, case discussions, and ethics consultations can help anesthesiologists navigate complex situations. Professional organizations like ASA have published guidelines for ethical practice to guide anesthesiologists, and I have shared in detail the ASA guidelines at the end of the PowerPoint. I will not be speaking them out loud, so I request all of you to do a self-study when you receive the reading material. Informed consent in anesthesia is a process where the patient voluntarily agrees to a procedure after being fully informed about its benefit, risk, and alternatives. The purpose is to empower patient to participate in decision-making about their treatment and respect their autonomy. The elements of informed consent are disclosure of information, comprehension by the patient, voluntariness, that is, there is absence of coercion, competence of the patient, and actual consent. The anesthesiologist should explain the nature of anesthetic plan and procedure, including the risk, benefits, and alternatives. Information should be tailored to the individual patient need and delivered in a language they can understand. Disclosing all material risk, those that a reasonable patient would consider significant, is essential. The anesthesiologist should assess the patient's understanding of the information provided. Methods like the teach-back method can be used to ensure the patient has grasped the key details. Using simple language and visual aids can enhance comprehension. Voluntariness and competence, the consent must be given voluntarily, free of any pressure or influence from the medical team or family. The patient must possess the mental capacity to understand the information and make a reasoned decision. Here I have shared 3 photographs of a range of patients that we deal with. And what do you think about the competence for giving consent in these? The patient's consent, typically in written form, confirms their agreement to the anesthetic plan. Documentation of consent process, including the discussion and patient understanding, is vital. If possible, high-risk should be detailed by patient in own handwriting in language understood by him and signed off. Preferable to have witness signature on the consent form too. Now, patients with impaired capacity, like the photographs I had just shared with you earlier, in case of minors, unconscious patient, or those with cognitive impairments, surrogate decision makers such as parents and legal guardians may be necessary. In emergency situations, if life-threatening emergencies, treatment may proceed without full informed consent if delaying treatment is deemed more harmful. Specific informed consent is recommended for regional anesthesia techniques outlining risk and benefit. Very often, the anesthesia consent itself is a part of the surgical consent. So you must remember that there should be a separate anesthesia consent, and within that anesthesia consent, there should be a separate consent for general anesthesia, separate consent for regional anesthesia, neuraxial anesthesia, and even something like peripheral nerve block or post-operative analgesia, which will be continued. The implication of existing do not resuscitation orders in perioperative period require careful discussion and documentation. As far as training and research is concerned, consent for training purposes and participation in research must be obtained ethically and in accordance with guidelines. In conclusion, upholding ethical principles and ensuring informed consent are central to the practice of anesthesia. Effective communication and thorough documentations are critical for both legal and ethical anesthetic practices. Ongoing education and training are essential for anesthesiologists to navigate complex ethical dilemmas and provide optimal patient-centered care. Any questions?
Thank you, Dhirja ma'am. That was a really, really good lecture and an often undermined topic, which the PGs, although they encounter on a daily basis, they don't really study about it. Ma'am, I don't think there's any question in the chat box yet. Amitabh sir, over to you.
Thank you, ma'am. Dr. Dhirija, you have succinctly discussed and described each and every critical aspect of ethics in anesthesia and informed consent. I just want to put up 2 more points to clarify your points further. Number 1, what we are talking about is it's the anesthesiologist who is attending anesthesiologist, who is assessor anesthesiologist is important, and he or she should be well credentialed, competent, and of having execution proficiency. Because it may happen that somebody is active in transplant anesthesia but is called upon for obstetric anesthesia. So their proficiency matters. So what we want is to fit each cause. Second point is I want to put up a difference between what is an obligation and what is a responsibility. Obligation is an active proponent that calls for do no harm with your actions, with your commissions, and with your interventions. But when we talk about responsibility, it includes the passive proponent of do no harm. That is, I take responsibility that I will not let my patient harmed in any other way also. That means to say, when the patient is anesthetized, I am sitting there throughout and seeing to it that patient's privacy and confidentiality is preserved. There is a clear communication with all the stakeholders, including surgeon, about the betterment and better care of the patient, and so on and so forth. So with these 2 points, I would like to say, do no harm is not simply do no harm. Do no harm is a responsibility. And the other thing which I told, anesthesiologists should be credentialed and competent and proficient. All 3 things. Third thing, when we talk about beneficence means I am here to provide you benefit, but not in terms of medical benefit, because we are not going to treat or do anything for the benefit of the patient medically. But we reassure and promise them that your surgical sojourn will be smooth and complication free. And when you wake up, you will have least of the problem other than a bit of residual pains secondary to the surgical sutures. So what I mean to say is there is a lot to talk about, but I am impressed the way Dr. Dhirija has represented herself into the rare area of anesthesia ethics. Anesthesia ethics per se is altogether different from medical ethics. And I hope the next generation will see different works that will come up and put anesthesia in a special bracket as long as ethics is concerned. Thank you, Dr. Dhirija. Thank you, organizers, for including me in this program.
Yeah, thank you, Doctor. Yeah, I'll just speak one thing. Dr. Datta, you very nicely put up the point so well. And I especially like the point about responsibility. Like we are now the older people and we are happy to see newer generation coming up and taking anesthesia, but responsibility aspect is so important.
Yes, ma'am.
And not only is it about ethical conduct, but Dr. Datta will tell us how important it becomes when we even face litigations.
Yes.
Where this is where it would come that did you do proper? All these are the 4 principles against which the conduct of anesthesiologist is measured. So it's really important. And I must thank also Dr. Datta for very nicely moderating this session, and Appec committee and Nidhi and Dr. Nisha also being here for giving me the opportunity to speak. Thank you so much.
Thank you, Dr.
Thank you
Nishad.
so much, ma'am. Thank you, Amitabh sir. Thank you so much.
Thank you, ma'am.
So with that, we move on to the next part of this session. I'm delighted to introduce the chairperson of the next session, Dr. Nisha Kachru. Ma'am is a director, professor anesthesia at ABVMS and Dr. RML Hospital. Ma'am has number of publications and book chapters in national and international journals. She is the founder member and secretary Neonatal Anesthesia Society. Her areas of interest are pediatric anesthesia, transplant anesthesia, and difficult care. Welcome you, ma'am.
So
And
good
the speaker of
afternoon.
the session is Dr. Asha Tyagi.
Good
Ma'am, over to
afternoon,
you.
everybody. And now I would like to welcome you to the next session. I hope you're having a very informative and knowledgeable Appec so far. Now, as far as the next session goes, we all have to sometimes deal with pregnant patients who come for non-obstetric surgery in any of the 3 trimesters. They are of concern to us because, as usual, we are dealing with 2 lives. And to discuss this topic in detail, we have Dr. Asha Tyagi, who is the Director Professor of Anesthesia in the Department of Anesthesiology at UCMS and GTB Hospital. Dr. Asha has over 150 indexed publications, is the associate editor for BMC Anesthesiology and section editor for JOACP. She has also been a reviewer for several national and international journals. Her area of interest include obstetric anesthesia, which we will be discussing today, critical care research methodology and artificial intelligence in anesthesia and healthcare management. I would now invite Dr. Asha to give her talk.
Very good afternoon. We are discussing a non-obstetric surgery conduct in a patient who is pregnant. Is the topic important? Yes, because almost 1 to 2% of pregnant patients may require or will require surgery for a reason which is not related to the pregnancy. Maximum incidence occurs in the first trimester, almost 42% of the cases, and the commonest procedures remain abdominal in nature. Appendicectomy leading the front, followed by maybe cholecystectomy. And yes, maternal trauma remains an important indication. What does the maternal outcome look like in a patient who is pregnant and is undergoing this kind of a surgery, a non-obstetric surgery? Complications due to the surgery can occur. The commonest is reoperation, and thankfully the least is mortality. But is the outcome different if I compare these with a non-pregnant patient who has undergone the same surgery? The most recent evidence from the American College of Surgeons says the outcomes are not different. Whether it is a 30-day mortality or the overall morbidity, they are no different for abdominal pelvic procedures. What is the apprehension then? Why is this case scenario different? It is different because here the fetal well-being does not have to be preserved just for the duration of surgery, unlike a cesarean section. You need to preserve it for during the surgery and hopefully till the end of the entire period of gestation. The risks which the fetus runs include teratogenicity, asphyxia, a fetal loss or preterm delivery, and neurotoxicity. Perhaps the oldest standing discussion has been for fetal teratogenicity, which implies a detrimental change in the function or the form of a child secondary to the prenatal treatment. It has been said for a long time that this depends upon the drug which is used, the amount it is used in, the route, and of course the period of gestation, because the 3rd to 8th week is when organogenesis takes place and drugs have the potential to exert the most serious teratogenic effects. Is there actually evidence in humans to prove that this occurs? No, it is inconclusive at best. So for clinical use, as of today, we say that all modern anesthetic agents used at clinical doses have no reported teratogenic effects. A greater risk actually in reality is of fetal asphyxia, which results from maternal hypotension and hypoxia, which are way commoner during the surgery. And this is because it results in a decreased uteroplacental circulation and oxygenation, since this has no autoregulation. There is also almost a 50% greater or increased chance of a preterm delivery in these patients, maximum in the third trimester. They can also have a higher incidence of abortions if the surgery is being conducted in the first trimester. Both incidences are least in the second trimester, most with intra-abdominal procedures, and hence the recommendations are we should minimize uterine manipulations, avoid ketamine, which increases the uterine tone. You should monitor for uterine contractions and offer tocolysis if indicated, not as a routine prophylaxis though. Even though it remains unclear whether this fetal loss and preterm delivery is a result of the maternal condition for which the surgery and anesthesia was being conducted, or it is maternal factors per se. But yes, it remains a heightened risk. Fetal neurotoxicity. It all started in 2017 when FDA issued a warning that there was the potential for adverse effect of general anesthesia on the developing fetal brain. There were preclinical studies which showed altered neuronal apoptosis and synaptogenesis, and it was shown that these resulted in subsequent learning and behavior abnormalities. As of today, there is evidence, it remains an area of ongoing research, but the evidence is insufficient at the moment to tell us whether a drug A is better than a drug B or an anesthetic technique is superior to the other when we are talking about effects of general anesthesia on the developing fetal brain. But yes, let us try and limit the overall duration of anesthesia that is recommended and use regional anesthesia if feasible. So being made aware of these fetal consequences, then the question arises, should we postpone the surgery to after delivery? Simple. We can if the surgery is elective. In this context, what an elective surgery would mean is that if there is little or no untoward consequence for the mother, if that is possible, let's defer it to 6 weeks postpartum. If not, the surgery must be conducted. It should not be denied just because the mother is pregnant or there is a fetal risk. The best timing remains the second trimester, and a question often to be considered in pre-op period is a laparoscopic surgery safe? Laparoscopic surgery will continue to offer the same advantages as in a non-pregnant patient, which means you are looking probably at lesser pain, shorter length of stays in the hospital, faster ambulation. The fears which arise are there is a potential of a direct uterine and fetal trauma. Can there be fetal acidosis because of all the absorbed carbon dioxide? Will the decrease in cardiac output, maternal cardiac output, result in a decrease in neutroplasmic perfusion because of associated increased IAP and the positioning? On top of that, there was earlier evidence to show that an open appendicectomy was better than a laparoscopic approach because it resulted in lesser fetal mortality and longer period of gestation. Subsequently, more evidence, almost 2 million pregnancies, there was no difference in fetal outcomes. So as of today, yes, we can do a laparoscopic surgery. Let's maintain a left uterine tilt, use the smallest IAP possible, definitely less than 15 mmHg, and especially in third trimester, try and use an open technique for instrumentation insertion. So having decided this, in pre-anesthetic considerations, what becomes important is that not only we need to counsel, of course, reassure also, and take a consent for associated fetal asphyxia, preterm loss, preterm delivery or fetal loss, but also take a consent for emergency cesarean section. And that has to be taken for a viable fetus in the pre-anesthesia checkup itself. Because if and when the need is going to arise, cannot be ascertained. And if you are taking a consent for an emergency cesarean during the surgery, we need a neonatal consultation as well. Anesthetic goals will remain the same like in a cesarean section, which means maternal well-being and fetal well-being. A multidisciplinary approach because we will have to consult the obstetrician as well as the neonatologist. What are the maternal considerations we need to consider? They are a result of the physiological changes, and for that reason, they have been discussed, I think, since morning in a couple of sessions. So I'll just stick to those which become important in this patient who is pregnant, but it may not be for fetal delivery. It is not for fetal delivery. And the period of gestation can be anything from first trimester to the third. So remember that airway changes, the progressive mucosal friability and edema starts very early in the first trimester itself. So it may be prudent to not use a nasal airway, not use nasal intubation. And remember that they continue to pose a difficult intubation and mask ventilation. Respiratory consequences will mean that when you're offering them general anesthesia, yes, it's going to be a rapid desaturation. Remember to pre-oxygenate them. Remember, it's going to be a rapid inhalational induction and emergence. The most important cardiovascular effect for these patients is going to be a supine hypotension syndrome because it can result in fetal asphyxia. Are these patients at increased risk of aspiration pneumonitis? Now, typically, we have believed that these patients do have a heightened risk of regurgitation and aspiration. So the current recommendations are, if in any trimester your patient is symptomatic with nausea, vomiting, pain, infection, there are symptoms of GERD, hiatus hernia, or if the patient is full stomach, we treat them as full stomach, take all due precautions. Otherwise, asymptomatic patient more than 16 weeks period of gestation, yes, we treat them as such, and we for general anesthesia, we use rapid sequence induction. Does evidence support this risk? Now, if you look at the face of present new evidence, there is a SCORE project. It says that out of 96,000 cesareans, these are cesareans, mind you, which means third trimester, hopefully. And out of which 5,000 were given general anesthesia, no cases of aspiration. Deep sedation with propofol used in pregnant patients, 51,000 in first trimester, 11,000 in second trimester, no aspiration cases. And the most recent closed claim analysis showed that out of the 115 aspiration events reported, 4 were in pregnant patients. So a very small percentage of them. Now, although this seems like aspiration is not a risk, let's remember that these data are when current clinical practices to decrease this risk are being undertaken, because that is the conventional wisdom we have all been using. So the recommendation is that let's continue to apply these standard fasting guidelines. Let's give prophylaxis as we just discussed, and we will use RSI, even though controversial, in patients who are pregnant, either from 16 weeks onwards or even earlier if they are symptomatic for a full stomach. Do we need to position these patients also in a left uterine tilt? Yes, 15 to 30 degrees, because we know that IVC compression starts as early as 13 to 16 weeks. And maybe earlier if it is with multiple gestation or obesity. We need to remember that the MAC for volatile agents is reduced. Plasma cholinesterase also falls, but clinically there's not much effect on the duration of succinylcholine. NDMRs may pose a prolonged duration of action, and the local anesthetic environment does go down. When we talk about the fetal considerations, so this was maternal well-being, of course, a result of the salient physiological changes, which will have to be considered. We need to do some fetal monitoring. Now, a pre-viable pregnancy, which means less than 24 weeks period of gestation, it suffices if you have a pre and post-procedure fetal heart rate monitoring by Doppler only. If it's a viable fetus, more than 24 weeks. We must do a continuous electronic fetal monitoring, again before and after, and this is going to include uterine contractions as well. If you have the advancements and the facilities, should we do a continuous intraoperative fetal heart rate monitoring? Yes, this can be done for both viable and pre-viable fetuses, because not just that it will tell you about the fetus. By the FHR changes, it also helps us to maintain or intervene with the mother to optimize maternal hemodynamics. For example, it may be positioning, it may be change in the FiO2, it may be a change in the ventilation. And all this why? To increase the oxygen delivery to the fetus. But the problem is that this has to be physically possible during the surgery. You need a qualified individual to interpret it. Intraoperative cesarean must be possible. If the monitoring so indicates that we need to deliver the fetus now, then that facility has to be available. Otherwise, this monitoring doesn't serve a purpose eventually. But at the same time, let's remember there's no evidence that it is improving the fetal outcome per se. So should we be using fetal heart rate monitoring at all period of gestations? As I just said, it'll depend whether it's a pre-viable or a viable fetus. You change the nature of your monitoring. And let's remember that fetal heart rate can only be monitored beyond the 18. The important caveat here is that the anesthetic agents reduce the heart rate variability and baseline fetal heart rate itself. So the interpretation is difficult, but one thing which definitely indicates fetal hypoxia would be a persistent fetal bradycardia, because this is not caused by anesthetic agents. If there is fetal asphyxia, we must try and make maneuvers to correct it, and we should prevent it also, which means we will avoid maternal hypoxia, hypocarbia, hypercarbia. And remember that uterine placental circulation has no autoregulation. So we have already discussed this, that in the fetal considerations, in the first, second, and third trimester, it is the second trimester which remains the safest. In the first trimester, there was a huge debate much earlier on that do preoperative opioids and benzodiazepines cause cleft palate or cleft lip? It is no longer substantiated. Should we choose regional anesthesia or GA? Whenever possible, if the surgery and patient factors allow, yes, regional anesthesia is better because it is going to decrease the fetal drug exposure. It's going to avoid maternal airway manipulations. It's going to provide post-op analgesia. The disadvantages which remain include an increased risk of systemic toxicity because there's a free fraction of local anesthetic, which is higher in pregnant patients. Drug uptake is higher because of the venous engorgement, and cardiac irritability is more because of the altered progesterone and estrogen balance. Irrespective of the technique, maternal hypotension has to be prevented and treated. What is currently recommended is that let's try and maintain the systolic blood pressure as close to maternal baseline as possible, definitely within 80% of the baseline, irrespective of the technique. And general anesthesia, let's remember, does result in lower birth weight babies even when the period of gestation is completed in these patients. When it comes to general anesthesia, I already talked about this, that the difficult airway and failed intubation apprehension remains. There is a rapid desaturation. You need to pre-oxygenate. Some evidence also says that an EtCO2 more than 80% itself may be enough for pregnant patients rather than more than 90%. And as I already said, rapid sequence intubation remains controversial, but yes, we continue to recommend it for more than 15 to 18 weeks. Since we are so fond of using newer things, can you use sugammadex in pregnant patients? Even though you would love to, I assume, the latest guidelines, the SOAP guidelines 2019 consensus statement recommends against its use. Why? Because there is a concern that this will result in a progesterone binding which might disrupt the integrity of pregnancy. Can we use neostigmine instead? Yes, it is safe. Even though there was some reports earlier on of a non-consequential fetal bradycardia. So for the same reason, you might find clinicians who prefer using atropine rather than glycopyrrolate along with neostigmine because atropine crosses the placenta more readily. What will be the post-operative goals in these patients? Post-operative analgesia gets a heightened importance for these patients because it decreases the incidence of preterm labor by decreasing the circulating catecholamines. If we had offered a regional anesthesia, we could continue using that for post-op analgesia. If it was GA, we resort to multimodal. When we talk about multimodal analgesia, the question arises, is it safe to use post-op opioids in these patients? Because it is going to decrease the FHR variability. Can it cause respiratory compromise? Yes, that will be relevant if the fetus ends up being delivered prematurely, might need respiratory support. But otherwise, for acute post-op pain, short-term period, yes, opioids can be used. NSAIDs, we have to avoid their long-term use because they can cause a fetal miscarriage or malformation in early pregnancy and a premature ductus arteriosus closure and oligohydramnios after 30 weeks. But for in a limited dose for acute post-op pain, they can be used in the second or the third trimester. And we also need to remember that while we are going to be offering post-op analgesia and ensuring it, it may mask signs of early preterm labor. Besides post-op analgesia and the post-op period, you will continue to monitor the fetal heart rate and the uterine activity. And we will need to remember that the risk of thromboembolism remains in these patients. So early mobilization, maintaining hydration, maintaining any kind of calf compression devices or stockings, and considering pharmacological prophylaxis with low molecular weight heparins will have to be thought of on an individualized basis. And if the pregnancy continues beyond the first post-operative week, the chances are that the risk of preterm labor is no higher than the non-surgical patients. So to recapitulate, we have understood that postponing elective surgeries may be wise if it is truly elective in nature. Otherwise, second trimester is the best period. Let's try and use regional anesthesia over general whenever possible. You consider aspiration prophylaxis in any POG where patient is symptomatic or more than 16 to 18 weeks. Otherwise, continue to use left uterine tilt after 18 to 20 weeks of gestation. Use intraoperative fetal monitoring if you have the means. Otherwise, pre and post-operatively definitely. Post-op analgesia is to be maintained. Prefer regional to GA if you are using GA. Remember that certain modifications, just like in a cesarean, will have to be implemented. And with that, I thank you and I wish you the best.
Thank you, Dr. Asha, for your talk. And I'm sure our postgraduate students have definitely added to their knowledge based on this talk, and they will follow the principles as outlined by you.
Thank you. Thank you so much.
Are there any questions for Dr. Asha? I don't think there are
none.
Yeah, I can't see. So over to you, Dr. Neha.
Okay, thank you so much, ma'am. Thank you, Asha, ma'am, for such a wonderful lecture. I think all the points have been included. Thank you so much, ma'am. Thank you, Nisha, ma'am, for all your inputs. Thank you so much.
Okay, thank you.
So with that, we move on to the next lecture. It's a long case discussion of a 32-year-old G4P3L2A1 presenting with moderate anemia. The case would be moderated by Dr. Medha Mohta. We welcome you, ma'am. A very good evening.
Hello, thank you. Good evening.
Ma'am is a director professor and head at the Department of Anesthesiology and Critical Care at University College of Medical Sciences and GTB Hospital. Ma'am is a member of the editorial board of Journal of Indian College of Anesthesiologists. She's a reviewer for many national and international journals. Ma'am has many publications and journals and about 140 and book chapters as well. Ma'am has a fellowship in Commonwealth Academics in Trauma Management. She's an instructor for ATLS courses. Area of interest, ma'am's area of interest are obstetric anesthesia and trauma management. Welcome, ma'am. The case would be presented by Dr. Annapurna Mehta, the postgraduate, and later be summarized by Dr. Abhinav, senior resident. Over to you, ma'am.
Thank you. So first of all, I'll request Dr. Annapurna to start with the case presentation.
Good afternoon, ma'am.
Good afternoon.
Ma'am, today I'll be presenting a case of anemia with pregnancy. So my patient, she's a 32-year-old female, gravida 4, para 3, life 2, and abortion 1 at 31 weeks of and 1 day period of gestation, and she's an unbooked case. She presented with the chief complaint of amenorrhea for 8 months, breathlessness on exertion for 1 month, and easy fatigability for 1 month. The history of presenting illness, patient was apparently well when she started experiencing amenorrhea 8 months back. The pregnancy was confirmed on urinary pregnancy test. After 1 month of missed period, she started experiencing breathlessness on climbing 1 flight of stairs 1 month ago, which was insidious in onset, relieved on taking rest, aggravated on physical activity. It was associated with easy fatigability, not associated with chest pain or palpitations, shortness of breath on lying down, awakening in the night, sudden loss of consciousness. No history of cough with expectoration, blood and cough, fever with chills, weight loss, evening rise of temperature. There is no history of burning.
Could you please tell us, why have you elicited these histories? Why have you asked about this chest pain or palpitations or blood and cough? How are these relevant to this patient?
Ma'am, I wanted to rule out if the cause for shortness of breath was cardiac or respiratory in nature.
Okay, all right. Go ahead.
There is no history of poor weight gain, indigestion, or loss of appetite. No history of passage of worms in stool or mouth, bleeding from any site, blood in stools, easy bruising, or yellowish discoloration of skin or eyes. Trimesteric history, first trimester. It was a spontaneous conception confirmed on urinary pregnancy test after 1 month of missed period. There was no history of fever with rashes, radiation or drug exposure, excessive vomiting, bleeding per vaginal, or discharge per vaginal. The second trimester, quickening was experienced at 20 weeks. First ultrasound was done at 16 weeks, confirming a singleton pregnancy. First TT dose was taken at 16 weeks. Second dose was not taken, and she did not take iron folic acid supplementation. There is no history of headache, epigastric pain, blurring of vision, increased frequency of urination, excessive thirst, bleeding, or discharge per vaginal. Third trimester, adequate fetal movements were felt. No history of headache, epigastric pain, blurring of vision, increased frequency of urination, excessive thirst, bleeding, or discharge per vaginal. Her menstrual history, her last menstrual period was on 5th December 2024. Her menarche was attained at 12 years of age with regular menstrual cycles of 30 days with normal flow lasting 4 to 5 days. Obstetric history, first pregnancy was 5 years ago, which was a full-term normal vaginal delivery, a male child, during which she received 1 blood transfusion, and there is no history of reaction to the blood transfusion. Second pregnancy was 3 years ago, full-term normal vaginal delivery, male child, and was uneventful. Third pregnancy was 1 year ago, followed by a missed abortion at 2 months of amenorrhea, for which she got a dilatation and evacuation done. Present pregnancy is her 4th one. Past history, no history of diabetes, hypertension, tuberculosis, asthma, seizure disorder, or any surgical intervention performed. Family history, no history of tuberculosis, cardiac disease, infectious disease.
Just tell us the significant points. Okay. We are running short of time. So yeah. Any significant point in family history or personal history?
No, ma'am.
Okay. Move ahead. Go to the next slide.
Ma'am, examination. It was performed after taking consent. She was conscious, oriented to time, place, person, sitting comfortably in bed. Her weight was 52 kgs and her height was 158 centimeter. Her blood pressure was 104/68 mmHg in right arm in sitting position. Pulse rate 92 beats per minute in right radial artery, regular, normal in rhythm, volume, character, with no radioradial or radiofemoral delay, and all peripheral pulses were felt. Her respiratory rate was 16 per minute and was abdominothoracic. Temperature was 97.6 degree Fahrenheit. Saturation was 99% on room air. Pallor was present. There was no icterus, cyanosis, clubbing, lymphadenopathy, or edema, and her JVP was not raised. Her skin was pale, brittle nail and hair were present, but no angular stomatitis or glossitis was found. Systemic
Any
examination.
significant points in respiratory system examination?
No, ma'am.
Cardiovascular? In respiratory
No, ma'am.
system, how was the chest? Just tell us about that. Any crabs or any other findings?
No, ma'am. Bilateral air entry was present. It was clear and no added sounds were present.
All right. So chest is clear. Yes, go ahead. Next.
Ma'am, cardiovascular examination was also in normal limits.
Any murmurs?
No, ma'am.
No murmur. Okay. Next, yeah.
Ma'am, per abdomen examination was next, which was also within normal limits. And so was central nervous examination and breast examination.
All right. Okay, so can you summarize your findings? Can you give us a summary? Yeah, airway is also okay? Yeah.
Yes, airway and spine were also within normal limits.
All right.
Ma'am, my patient is a 32-year-old female, gravida 4, para 3, live 2, and abortion 1. She presented with the chief complaint of breathlessness on exertion for 1 month and easy fatigability for 1 month. And she had in her history, there was no folic acid supplementation taken, according to her. And on examination, pallor was present along with the brittle nails and hair.
Okay, so on the basis of this history and examination, what is your provisional diagnosis?
Ma'am, based on my history and examination, she most likely has anemia, which not in failure, and she's currently not in labor.
Okay, pregnancy with anemia. So can you just tell us what is anemia? Just to begin with, we must understand how do we define it?
Ma'am, anemia is a quantitative or a qualitative reduction in red cell mass or hemoglobin, which is below for the same age and gender.
Okay. All right. So can it be classified?
Yes, ma'am. Ma'am, different organizations give different classifications. ICMR gives one classification based on severity, wherein they have classified it as mild, moderate, severe, and very severe. So mild is 10 to 10.9 gram% of hemoglobin. Moderate is 7 to 9.9. Severe is less than 7, and very severe is less than 4.
So that means hemoglobin less than 11 is defined as anemia, isn't it?
Yes.
And is it same throughout pregnancy in all trimesters?
Yeah, ma'am, in first and third trimester, it is taken as less than 11 gram%, while in second trimester, it is taken as less than 10.5 gram%.
Why? Why this difference is there? Why a lower cutoff is allowed in second trimester? See, this is to adjust the increased circulatory volume, increased plasma volume during second trimester. That is why it is compensated by 0.5 gram%. All right. So, and it has been seen that these pregnant women, that the incidence of anemia, in these patients is very, very high. So what do you think, why these patients are so prone to develop anemia?
Ma'am, firstly, they, as a result of compensatory changes, they all develop physiological anemia of pregnancy.
Okay.
Other than that, the iron demand increases during pregnancy in order to accommodate for the growing fetus and the placenta.
Yeah, even mother needs more iron. She's
Yes, ma'am.
forming new tissues, she's forming new RBCs, new hemoglobin. So fetal as well as maternal requirements increase. So during second half of pregnancy, the iron demand of pregnancy increases. In fact, it is a state of physiological iron deficiency during pregnancy. And on an average, the iron demand increases to 4 milligrams per day. Whereas we know that with average diet, the maximum iron absorption is around 1.5 milligram per day. So if you don't supplement, these patients will develop anemia.
Yes, ma'am.
Okay, so now you made a provisional diagnosis of anemia.
Yes.
Pregnancy with anemia. So what were the points in favor of this diagnosis? How did you arrive at this provisional diagnosis?
Ma'am, firstly, her presenting complaints were breathlessness and easy fatigability, commonly seen. Secondly, she did not take iron folic acid supplementation, which she should have. Then on examination, we found pallor.
Okay. Okay. So, all right. So, on the basis of these points, you have made a provisional diagnosis of anemia. Now, how can we finalize this or confirm this diagnosis?
Ma'am, we can investigate her further. We can start with a complete count. Other than that, a peripheral smear will give us the morphology of the red blood cells. Iron studies can help us diagnose any iron deficiency anemia and confirm it.
Iron studies will include what?
Ma'am, total iron, serum ferritin, total iron binding capacity, and transferrin saturation.
Okay. What else can be done? See, there is a whole list of investigations for screening of these patients, although these are done by the obstetricians. But because by the time the patient comes to us, the definitive diagnosis has already been made in most of the cases, but still we should know about it. What all investigations can be done to confirm this diagnosis? One, you said, okay, complete blood count, so hemoglobin, hematocrit, that will be reduced. Then iron studies you talked about. Then the RBC indices, MCV, MCH, MCHC, all these need to be seen. Then peripheral smear that you have said. In other investigations, there can be other causes of anemia as well, especially B12, folate. Deficiency anemias can be because of B12 and folate deficiency also, in addition to iron. So those levels need to be found out, need to be measured. Then other investigations, what can be the other causes?
Ma'am, liver function test can be seen.
In
Kidney
hemolytic, for hemolytic anemia?
Yes, ma'am.
Especially bilirubin will be altered. Then renal function, that is also done routinely for all these patients because chronic renal disease may be one of the causes.
Yes, ma'am.
Even sometimes thyroid function is also conducted because hypothyroidism may also be associated with anemia. Then for other type of hemoglobinopathies, HbA2 or, all those investigations are also conducted as a part of routine screening of these patients. So what will be the findings that we expect in a case of iron deficiency anemia?
Ma'am, we will have a hypocytic, hypochromic type of anemia.
Okay, on peripheral smear. Okay. Microcytic, hypochromic,
type of
and anisocytosis, poikilocytosis. What is anisocytosis? Variation in
the
variation
size
in
of
size.
the
And poikilocytosis is?
duration in the variation in the morphology.
Yes, variation in shape basically. And hemoglobin hematocrit will be reduced. Then RBC indices, all these will be reduced. MCH, MCH, MCV, MCHC, all these will be reduced. Ferritin levels will be reduced. Serum iron will be reduced below 30 microgram %. TIBC, total iron binding capacity, that will be increased more than 400 microgram %. And the ratio, serum iron to TIBC ratio, that is again a very important, ratio. So that is less than or equal to 10%. So you will get all these findings in a case of iron deficiency anemia. Okay, so you said that anemia is reduction in hemoglobin. So why is this hemoglobin important? Why do we need hemoglobin? What is the importance?
Ma'am, for oxygen transport in our body.
Yeah, mainly required for oxygen delivery to the tissues. If hemoglobin is low, then oxygen delivery is also affected, which is not good for the patient. So can you tell us how oxygen is transported in the blood?
Ma'am, oxygen is mostly transported in two forms in the blood. One is the bound form to hemoglobin and the other is the dissolved form in plasma. Ma'am, hemoglobin contains heme and out in the globin, so in the most common form that we have, which is HbA, there are two alpha and two beta chains, to which one molecule of oxygen binds to each of these.
Yes,
so every molecule of hemoglobin can carry 4 molecules. Yes, ma'am.
Yes, so 1 gram of oxygenated, fully oxygenated hemoglobin can carry 1.34 ml of oxygen. So that is attached to the hemoglobin. Then dissolved form, 0.003 ml is usually dissolved in 100 ml of blood per millimeter mercury of PO2. All right. See, all these things are important to understand the compensatory mechanisms. Then only you will be able to understand if you know all these basics. All right. So it is being transported in two ways by two mechanisms. So what is oxygen content? Arterial oxygen content?
Ma'am, here we calculate the amount of oxygen present per ml of blood, wherein we add the dissolved form and the bound form. So, ma'am, there is an equation for it. So, the bound form is 1.34, which, like you mentioned, is the oxygen carried by every gram of hemoglobin, multiplied by the hemoglobin of the patient and multiplied by the saturation.
Yes. So
And
this is and what is the
add the dissolved form, which is 0.003 multiplied by the partial pressure of oxygen.
Okay, so this is oxygen content. Now, what is oxygen flux?
Ma'am, it is the amount of oxygen which is being delivered by the ventricle per minute. So in that equation, we multiply it by cardiac output.
Okay, so basically oxygen content multiplied by cardiac output, it will give you oxygen flux. And here for the calculation purposes, because this dissolved form, the volume of this dissolved oxygen is very small, so this is not taken into consideration. But basically it is oxygen content multiplied by cardiac output. That will give you oxygen flux. Okay. So how much is the normal oxygen flux? Normally in most of the cases, it is around 1 liter per minute. And out of this, around 250 ml of oxygen is consumed by the body. So oxygen consumption is around 250 ml per minute. 1000 ml or 1 liter is being delivered, 25% of this is being used. So what is oxygen extraction ratio? Oxygen consumption divided by oxygen flux or oxygen delivery. So that is around 25%. All right. Is that clear? Okay. So now can you tell me the various compensatory mechanisms in a case of chronic anemia?
Ma'am, firstly, there is sympathetic activation, wherein there is vasoconstriction and tachycardia, which increases the cardiac output. Then
Cardiac output increases. Because just now we discussed oxygen flux is basically oxygen content into cardiac output.
Yes,
And because of hemoglobin, we know oxygen content is decreasing. So body tries to compensate for that by increasing cardiac output. All right. So that is how this is the main compensatory mechanism, the increase in cardiac output. What else?
Ma'am, there is a decrease in blood viscosity because of water and electrolyte retention.
Otherwise, also hemoglobin is reducing, RBCs are reducing. So, yes.
Ma'am, there is
the viscosity. So, what will happen? The tissue blood flow will improve.
Yes.
Third compensation.
Ma'am, there is increase in 2,3 DPG levels, which is where there is a rightward shift of the oxygen dissociation curve, so that there is more oxygen delivery to the tissues.
Okay, very good. 3.
There is increase in the erythropoietin production, so that there is stimulation of erythrocyte production.
Okay, anything else?
Ma'am, there is redistribution of blood flow to the vital organs.
Anything else that we discussed just now? What about oxygen extraction ratio? Have we discussed? Oxygen extraction ratio also improves, it increases. All right, so by all these mechanisms, the body tries to compensate for the decrease in hemoglobin. Now, suppose you have to anesthetize an anemic patient for cesarean section. So what will be your anesthetic considerations? Just think about all this that we have discussed and give the answer.
Ma'am, they can be, one will be pregnancy related and the other will be anemia related.
Pregnancy related because so many physiological changes have occurred in the mother. So we need to consider all those physiological changes. They will be our concern, first concern related to pregnancy, and then related to anemia.
Yes, ma'am. Ma'am, there we have to ensure that the oxygen demand is not increased. Any factor that increases the demand, we have to avoid those.
Okay.
Such as fever, tachycardia, shivering, or pain, or in case of an anesthetized agent, a patient, inadequate depth.
Okay, so prevent any factor which will increase the oxygen consumption.
Yes.
What else?
Ma'am, we have to avoid any dip in the sudden dips in cardiac output.
Yes, because that is our main compensatory mechanism. So avoid any factors which can decrease cardiac output. And also, this is one factor which will impair the oxygen delivery. Another thing, what else? We have minimized any factors which will interfere with the oxygen delivery. So one of them is maintenance of cardiac output. Another one, there should not be any shift of ODC to left. Otherwise, the oxygen delivery will reduce.
Okay, ma'am.
So what are those factors? Can you enumerate one or two factors?
Ma'am, yes, ma'am. There is
Left shift किससे होता है? Right shift, you talked about 2-3 TPG. Left shift, that is not in our control, but we can control some other factors like avoid hyperventilation.
Yes, ma'am.
Isn't it? Hyperventilation will lead to hypocarbia. That will shift the ODC to left and will reduce the oxygen delivery. What else? Hypothermia. Avoid hypothermia. That will also shift your ODC to left. So avoid all these factors and maintain adequate PO2, adequate oxygen levels in the blood. So give high FiO2, avoid any, airway complications, maintain a patent airway so as to maintain a good PaO2 in the blood. So these are the main anesthetic concerns. Okay, now coming back to our patient, she's 31 weeks pregnant. And suppose she has hemoglobin of 8 gram%. So how should she be treated? 31 weeks pregnancy with 8 grams hemoglobin.
Ma'am, I would like to start iron therapy, preferably oral iron therapy.
All right. So what type of iron is given? Just in one or two sentences, we should know a little bit about these things.
Yes, ma'am.
How much iron?
Ma'am, in oral iron, it is best absorbed in the ferrous form. So ferrous sulfate, which is given in 325 mg, which has 60 mg of elemental iron, that is prescribed. But ma'am, they are associated with common GI disturbances, such as nausea, vomiting, diarrhea, constipation. So they lead to a lot of intolerance.
Yeah, but that is the most commonly used form of iron therapy. So most of the patients are started with oral iron. And as you said, iron, elemental iron, 60 milligrams. In the form of ferrous sulfate, it may be around 200 milligrams or so, depending on the preparation. But remember, iron, elemental iron, 60 milligrams along with folic acid, 250 mics. That is given thrice a day for treatment and once a day for prophylaxis.
Yes,
So once adequate hemoglobin levels are achieved, then from thrice to, you can switch over to once a day regime. But this is the most commonly used form of iron therapy. And so what are the indications of parenteral iron?
Ma'am, when there is intolerance to oral iron, there is non-compliance to oral iron.
Intolerance, non-compliance, or sometimes there may be gut issues. The patient is not able to absorb iron because of some gut problems. So in those cases, parenteral is given. And what are can you tell us something about parenteral iron therapy?
Yes, ma'am. Ma'am, it can be given as intravenous or as intramuscular. Ma'am, in intravenous, there is iron sucrose, iron carboxymaltose, dextran, and they are usually preferred. They're mostly painless. They're associated with less pain, so they are preferred. As opposed to intramuscular, wherein we can either give it as a total dose infusion or as repeated doses.
Infusion for IV therapy, but it is okay. Iron dextran, that is associated with the number of, very frequent incidents of anaphylaxis. So nowadays, safer preparations are there. Iron sucrose complex, or as you said, FCM, ferric carboxymaltose. So all these can be used, and you should know how to calculate the iron demand. Okay, now what about blood transfusion? What is the indication of giving blood to these patients?
Ma'am, usually it is given in advanced pregnancy with severe anemia, or when we need to compensate for acute blood losses, or in cases of refractory anemias.
Okay, so yes, all severely anemic patients receive blood transfusion, irrespective of gestation age, and or if the it is closer to the delivery. So more than 36 weeks, then you can't treat anemia using oral iron or parenteral iron, because that takes a long time to
Yes.
rectify the iron, the hemoglobin levels. So at that time, we need to give blood, or severely anemic. So less than 6, they say all patients should receive blood transfusion, and more than 10, it is not indicated. In between, you have to see the patient's clinical condition and any coexisting problems, or the chances of blood loss. According to that, you have to decide. But in our institution, like, we give blood to all patients who have HB less than 7 gram%. So basically severe anemia. Less than 7 is severe anemia. So all severely anemic patients receive blood transfusion. Okay, tell me, if a patient is posted for an elective surgery, so what is the optimal timing of giving blood? How much time should be there in ideal situations when there is no urgency, no emergency, between blood transfusion and the surgery?
24 to 48 hours.
Why? See, when you give blood, you are giving blood, you are increasing the blood volume, and viscosity is also increasing. So time should be allowed for circulatory adjustments to occur. Another, that in stored blood 2-3 DPG levels, they are reduced markedly. So when this blood is transfused in the patient, then the body tries to replenish the levels of 2-3 DPG. It provides substrates, and within few hours or maybe 24 hours or so, the 2-3 DPG levels are also replenished. Okay, so that is why it is preferable, it is ideal to wait for 24 to 48 hours, like to give blood 24 to 48 hours before surgery. All right. So your patient, she came with 8 grams, she was started on oral iron, and near term, her hemoglobin is now 10 gram%. All right. But now she's diagnosed with CPD, cephalopelvic disproportion, and is posted for an elective cesarean section. You are the anesthetist. What will be your anesthetic technique of choice and why?
Ma'am, I would like to proceed with spinal anesthesia.
Why?
Ma'am, I would like to, ma'am, spinal anesthesia has multiple benefits over general. Like we avoid the complications which are associated with general anesthesia. Like a pregnant female is a patient with difficult airway. So airway instrumentation is avoided. Any of the drug transfer from the mother to the fetus is avoided, as well as the mother. A psychological benefit is that the mother is awake for the childbirth. And in case an epidural is also used, then we can also extend the analgesia to the post-op period, which is beneficial to the patient.
So with neuraxial, risk of aspiration is also minimized or is avoided. So all the problems associated with GA can be avoided. And then blood loss is also said to be less with regional techniques as compared to GA. So these are the advantages. That is why routinely we prefer to give neuraxial anesthesia, regional anesthesia to pregnant patients. This is considered to be the safest, unless there are some other considerations, some other contraindications. All right. So how will you conduct now the spinal anesthesia for this patient? You said you will give spinal. How will you conduct?
Ma'am, first there would be patient preparation. First, I will explain the procedure to the patient and take written informed consent. And I will first provide her with the anti-aspiration prophylaxis.
Okay, why? Why anti-aspiration prophylaxis?
Ma'am, all pregnant females are at a high risk of regurgitation. And even though I'm planning for neuraxial anesthesia, there can be any reason to convert to general anesthesia. So I would want to prevent any aspiration pneumonitis.
But why they are at higher risk of aspiration?
Ma'am, the lower is as a result of the progesterone, the relaxing effect of progesterone, the lower esophageal sphincter gets relaxed, and that's why they have a higher risk of esophageal regurgitation.
The hormonal effect is definitely there, but along with that, anatomical changes also occur. Because of gravid uterus, it is pushing the stomach upwards and to the left. So the intra-abdominal portion of esophagus, it is pushed to the thorax above the diaphragm. So there is anatomical change also. So a change in anatomy along with hormonal changes. These cause decrease in tone of lower esophageal sphincter. And that is why they are at a very high risk of aspiration, regurgitation and aspiration. So how do you prevent it? What aspiration prophylaxis will you give?
Ma'am, there are 3 classes of drugs that can be used. The first one is a histamine blocker, an H2 blocker, which typically that we use is ranitidine. So tablet ranitidine 150 mg can be given both on the night before the surgery, planned surgery, as well as in the morning before the surgery. An IV of 50 to 100 mg can also be given about half an hour to 1 hour before surgery. The other
milligrams, not 100. Oral is 150 ranitidine and IV is 50 milligrams. If you want to give IV, then 50 milligrams, and that should be given at least half an hour before induction. And oral should be given around 2 hours prior to surgery, in the night and 2 hours prior to surgery. Yes. Other drug?
Ma'am, the second class of drugs is metoclopramide, which is a prokinetic, so it will increase the gastric emptying. So for that, we give 10 mg metoclopramide around 20 to 30 minutes before the surgery. IV.
Yeah, besides that is fine. That is prokinetic. Then it also has an antiemetic effect, and it also increases the tone of lower esophageal sphincter. So metoclopramide has multiple effects, so it is a good drug. This can also be given either orally or IV. The dose remains same.
Yes.
Okay.
And third class of drugs is a non-particulate antacids, such as 0.3 molar sodium citrate, which around 15 to 30 ml has to be given around half an hour before surgery.
Yeah, it should be there inside the stomach when you are inducing anesthesia. So it is given after shifting the patient to the OT, whereas other drugs should be given around 2 hours before, or if you are giving IV, then at least 30 to 45 minutes prior to surgery. All right. So you have asked your patient to keep fasting and then given anti-aspiration prophylaxis. What else?
Ma'am, oxygen supplementation should be given since she's anemic.
Okay.
And left lateral position.
When?
Or
left lateral in the OT or?
Ma'am, both while shifting the patient and inside the OT.
Okay. While shifting, it is okay, but inside the OT, like during surgery, you cannot keep her in lateral position. But first, tell me why. Why do you want to keep her in lateral position even during shifting?
Ma'am, in the second and third trimester, when a pregnant lady lies supine, there is aortocaval compression because of the pressure from the gravid uterus. So that to a decrease in the venous return and can lead to supine hypotension syndrome.
Okay.
So, ma'am, it can be predicted by either manual displacement of the uterus to the left, or by asking the patient to lie in left lateral, or using a pelvic wedge, which is kept under the right hip of the patient.
Right. So see, it is aortocaval. So caval compression will lead to decrease in venous return and cardiac output. And in like in body, there are compensatory mechanisms for everything. So here also, body tries to compensate by increasing systemic vascular resistance and heart rate. Tries to compensate it to certain extents. Therefore, all the patients will not develop bradycardia and hypotension on lying supine. But in about 6 to 10% patients, the compensation is not adequate. So there is revealed caval occlusion. Otherwise, it is concealed. So revealed caval occlusion, the patient will develop bradycardia and hypotension, and she may experience dizziness, nausea, anxiety, restlessness. So this is supine hypotensive syndrome. All right. And there is also aortic compression occurring simultaneously. So for aortic compression, there are no compensatory mechanisms. And the patient may not have any sign symptoms because of that, but it will lead to decrease in blood flow to the femoral artery and then to the uteroplacental circulation. So fetus is going to suffer if this aortocaval compression is not prevented. So that is why it is very, very important to take precautions to avoid uteroplacental compression in all pregnant females after 20 weeks of gestation. Right?
Okay.
What next?
Ma'am, next would be my OT preparation. Ma'am, for my OT preparation, I will first check my machine, ensure that it is working and functional. I will prepare my difficult airway cart, which will have the appropriately sized.
Why do you want to keep a difficult airway cart? Here you said all the airway parameters were okay.
Ma'am, but all pregnant females are at a risk of failed intubation. Like they are probably difficult airway.
Why?
Ma'am, because of the physiological changes, like when the mucosa, there is edema as well as the mucosa becomes friable. So they're very because of the edema, the vision can get occluded, as well as because of the increased vascularity, the friable mucosa, we can find even slightest amount of traumas can cause bleeding, which can further occlude our
Okay, so there is a lot of oral, nasal, and laryngeal edema. It may be there, huh? Not necessary to be there in all patients, but yes, there is capillary engorgement. So some patients may be having a lot of laryngopharyngeal edema, which may make the airway management very difficult. And the Mallampati class also increases by 1 during pregnancy. So it is very important to reevaluate. If you have evaluated during early pregnancy, it is very important to reevaluate near term again before giving anesthesia. What are the other points like which may add to difficulty with?
They desaturate very rapidly because of decreased functional residual capacity.
Okay.
So they are at a higher risk for hypoxemia during attempts at securing the airway.
Okay. Yeah, okay, that is fine because their FRC becomes low. It decreases by around 20%. Because the gravid uterus is pushing the diaphragm up. So FRC, and what is FRC? It is the reserve of oxygen in the body, which is being used during apnea period. So FRC definitely decreases, whereas oxygen consumption is increasing. Why oxygen consumption is increasing? Again, the fetus is also requires oxygen. The entire uterus with the products of conception, maternal cardiovascular performance is also increasing. Maternal metabolism is increasing. So oxygen consumption increases by 20%, whereas the reserve, that is FRC, decreases by 20%. So they tend to desaturate very rapidly. That is why, okay, that also adds to the problems in airway management. Then there may be difficulties because of weight gain, because of enlarged breasts, short neck. So enlarged breast, because of this also sometimes you will find the insertion of laryngoscope blade very difficult. Right? Because of all these reasons, you always consider pregnant patients as difficult airway patients. So keep everything ready. Next.
Ma'am, I will check for my oxygen supply, both pipeline and cylinder, my suction apparatus at the appropriate pressures, my machine, my monitors, and my drugs preloaded according to the weight of the patient, and my emergency drugs as well. After that, ma'am, I will take the patient
And
inside.
you should have a skilled assistant available in the OT. Then baby trolley, baby resuscitation trolley should also be checked, and availability of pediatrician. All these things are important. Okay. Okay. You have checked your OT, prepared your patient. Now the patient has been wheeled in. She's on OT table. What next?
Ma'am, I will first attach the monitors, and I will take 2 wide bore IVs, cannulas.
And take baseline readings, heart rate, baseline, blood pressure, everything. You will take the baseline readings. Or then insert IV cannula. Okay. What next?
Ma'am, I will start giving fluid to the patient. In order to preload or co-load the patient.
Preloading.
Ma'am, here I'll be co-loading the patient.
No, what is preloading? I'm just asking you, what is preloading and what is co-loading? You should be clear about it.
Ma'am, I'm sorry, I couldn't hear. Can you repeat?
What is preloading and what is co-loading?
Ma'am, preloading would be before we start our procedure. We start the administration of IV fluids.
Not only start, you give IV fluid, 10 to 15 ml per kg of most commonly ringal acid before starting the spinal injection before before initiation of spinal. All right. But that also has its own advantages and disadvantages. But nowadays we tend to use co-load more often. What is co-loading? Here you push fluid at the time when the spinal administration is being done, and when the block is ascending, at that time you are pushing fluid. Because with preloading, initially you have given fluid 15 or 20 minutes before spinal. So it will be effective for initial few minutes, but then the fluid will be redistributed outside the intravascular compartment. So later on, the effect will not be there. In co-loading, you're pushing fluid when you have started the procedure. But
Yes,
again, you have to keep in mind, if the patient is severely anemic, then she may go into overload. That we will discuss later on. But yes, okay. So you will start loading your patient. She has 10 grams of hemoglobin, so it is okay.
Yeah.
Yeah.
Ma'am, after painting and draping, I will give spinal anesthesia at the.
But how will you give spinal after painting and draping? Just you are okay preparing the back. Okay, all right, all right. I thought you are talking about the uterine preparation. Okay, fine. Yeah, you will give spinal. How
Yes.
much?
Ma'am, using 25 gauge Quincke's needle. Ma'am, in this patient, I'd like to give 2 ml of 0.5% heavy bupivacaine along 10 mics of fentanyl as an additive.
Okay. How much level do you need in a pregnant patient?
Ma'am, T4 to T6.
So do you think this 2 ml will achieve that level?
Ma'am, yes, ma'am. In a pregnant patient, this can.
Okay, this can. So that means their requirements are low.
Yes,
They
ma'am.
need lower amount of this local anesthetic.
Yes.
So why is so? Why the local anesthetic requirement is less?
Ma'am, the gravite uterus puts pressure on the epidural space, and further that will compress the subarachnoid. So when
Puts
we
pressure on the epidural space, or is it something else? Direct pressure, will it cause this thing?
Ma'am,
Happens because of aortocaval compression. What are the, or you can say, what are the other implications of aortocaval compression? One, we discussed, it will reduce uteroplacental perfusion, will cause bradycardia and the hypotension in the mother. What are the other implications? So,
ma'am, the epidural venous plexus.
yes, and compensation also, we talked about that the body tries to compensate by increasing peripheral vascular resistance and heart rate. Also, the venous return is maintained through collateral venous channels. So that is another mechanism by which the body is trying to compensate. So what will happen to the epidural venous plexus? These veins will be engorged. So because of engorged epidural veins, the space available reduces. Even the spinal CSF volume reduces. So the same amount of drug will travel to a higher level. So that is one reason for reduction in dose of local anesthetics that is required. Any other reason why lower dose is needed? One is this. Then their neural tissues are more sensitive to local anesthetics. That is also the reason for lower requirement. Then the pelvis becomes wider. So if you are giving spinal in lateral position, the drug will travel to a higher level because of wider pelvis. The angle will be like this. And then in supine position, the apex of the thoracic kyphosis, that is at a higher level. So again, the drug can travel to a higher level. Then what happens because of increased intra-abdominal pressure? It will push the intervertebral foraminal soft tissue inside. So again, this volume further reduces. And their CSF also, some people say that it has higher pH, which facilitates diffusion of local anesthetic through membrane. So their requirements are very less. That is why you can manage with this 2 ml with 10 mics fentanyl. And what are the other differences in neuraxial anesthesia and analgesia management in pregnant and non-pregnant patients?
Ma'am, the bony landmarks are harder to appreciate in pregnant females.
Okay, because exaggerated lordosis.
Yes, ma'am.
Because of that, it becomes difficult to feel the interspinal spaces. And then there may be edema at the back.
Yes, ma'am.
So it is technically more difficult. Any other difference while giving epidural? Any point?
Ma'am, more prone to a bloody epidural.
Okay. But see, epidural pressure is not negative. It is towards positive side, isn't it? Because of pressure, the epidural pressure is positive. So the techniques used for epidural space, identification, there you have to use loss of resistance technique. You cannot use negative pressure techniques. Like fluid, the drop that we put at the tip. So that is a negative pressure technique. That is not reliable. So you have to use loss of resistance technique. All right. Okay. So you have given spinal. All right. The effect has come. The surgery has started. But within, say, 4 or 5 minutes, earlier the BP was 120 by 70. Now it has dropped down to 70 millimeter mercury systolic. What has happened?
Ma'am, spinal hypotension.
Yes. So patient has developed post-spinal hypotension. How do you define it? What is the definition of post-spinal hypotension?
Ma'am, reduction in the systolic blood pressure less than 20%.
Yeah, 20% or more below the baseline values. That is why it is very important to take baseline values of heart rate and blood pressure. Okay, or less than 100 millimeter. Absolute value less than 100, or a reduction in systolic blood pressure, baseline systolic blood pressure by 20%. All right. And see, you will see very commonly the spinal hypertension occurring. Why do these patients develop spinal hypertension so frequently? Any idea? See, because they are dependent on sympathetic nervous system for maintenance of their hemodynamic stability. So by giving your axial blockade, you are blocking the sympathetics. So that is why the incidence of, and plus this aortocaval compression, that also contributes to a certain extent, but mainly they are very much dependent on sympathetics. So that is how the incidence of postspinal hypotension is very high in them. And how do we treat? Because time is short. So I will just tell you that, see, you have to, ideally, you should prevent postspinal hypotension. According to the latest guidelines and consensus statements, we must prevent hypotension by giving prophylactic vasopressors. And these should be given as prophylactic vasopressor infusions, which should be titrated according to blood pressure response. So according to the current state, literature, till today, the vasopressor of choice is phenylephrine. So they say give phenylephrine 25 to 50 mics, start it at this rate, 25 to 50 mics per minute, and then titrate it according to the blood pressure. And the aim should be to maintain systolic blood pressure above 90% of the baseline values and avoid any decrease below 80%. So avoid hypotension at every cost, but try to maintain BP above 90% of the baseline values. So, but yes, there is one problem with phenylephrine. With high doses, it can lead to reflex bradycardia. So nowadays, alpha agonist along with some beta agonist activity, they are thought to have the best profile. So that is why norepinephrine has emerged as an alternative to phenylephrine. But our mefentermine, that also has alpha along with some beta activity. So that can also be, that is also a good agent. It's not bad. And most of us are using mefentermine, so we can use it. So according to guidelines, we must prevent it. And if you feel that it is not possible to give prophylactic infusions to all patients, then you can give prophylactic boluses also. But you must try to prevent hypotension. But if it develops, then treat it at the earliest, because we know it is bad for the mother as well as for the fetus. The uteroplacental perfusion is being hampered, right? So that is about the management of spinal hypotension. Now, okay, so we still have 7 minutes more with us. So I would like to change the scenario.
Yes, ma'am.
Suppose our patient has 7 grams % of hemoglobin. And she has presented for an emergency cesarean for some fetal indication. Now, what will be your technique of anesthetic technique of choice?
Ma'am, I'd like to give general anesthesia.
Can we give regional to this patient, because we know it is safer and all those problems of GA will be there otherwise? So if someone says that, oh, I can give spinal within 5 minutes or 10 minutes maximum. So is it advisable to give spinal at this hemoglobin, 7 grams? Yes or no?
No, ma'am, there is a risk of decompensation in this patient.
What will happen?
The patient can decompensate, ma'am. She can go into failure.
Because, see, you have to give fluid loading during your axial anesthesia. That will further exacerbate anemia and the patient can decompensate. Her heart is already being overworked, so she can go into cardiac failure. And these patients, see, all the major mechanisms of compensation, they are through sympathetic overactivity. So once sympathetics are blocked, there can be sudden hypotension. So it is not advisable at this hemoglobin. Less than 8 grams, we should avoid giving regional. So, okay, so we have decided we will give GA. How will you conduct GA in this patient?
Ma'am, just like we discussed first, my patient preparation and my OT preparation will remain the same.
Yes.
Ma'am, my plan of anesthesia will be balanced GA with the
all right,
modified rapid sequence induction with the endotracheal intubation and multimodal analgesia.
So what will you do? The patient is there on the table. You have attached the monitors. You have taken the baseline values. What will be the next step?
Ma'am,
and you talked about modified RSI.
yes, ma'am.
What will
first I'll start with pre-oxygenation with a tight-fitting mask with 100% oxygen for at least 3 to 5 minutes. Ma'am, after that, I'll start giving my induction agent.
Okay, you will ask the surgeons to clean and drape in the meantime, and you will pre-oxygenate. Now, why pre-oxygenation is important? We have discussed in part because why?
They are prone to rapid desaturation.
Yes, because oxygen consumption is more, FRC is low, so you want to fill up the FRC with oxygen. And how will you know that the pre-oxygenation is adequate? What are we trying to do by pre-oxygenating? We are trying to denitrogenate.
Increase the yes, ma'am.
Okay. Denitrogenation kar rahe na?
Yes,
So how will we know whether this is adequate or not?
Ma'am, the end tidal O2 should be
Yes.
more than 90 to 95%.
Yes, so it at least 0.9 or more.
Yes, ma'am.
End tidal oxygen fraction 0.9 or more indicates that the denitrogenation is adequate. All right.
Yes, ma'am.
What next?
Ma'am, I'll start giving my induction agent. Ma'am, injection propofol 2 mg per kg titrated to the blood pressure of the patient. And as there is loss of consciousness,
Titrated to blood
we'll start
pressure.
with.
You have to give full dose, huh? You can't
Yes.
titrate it according to blood pressure in rapid sequence induction. Okay.
Yes, ma'am.
You give your calculated dose. What else then?
Ma'am, cricoid pressure. We'll start with cricoid pressure at 10 newtons.
Even before starting induction, before starting injection of propofol, है ना? Your assistant should be ready with the hand on the cricoid, fingers in the proper position. Start with the low pressure and then increase it to
30 newtons.
Okay. क्या करोगे? बोलते जाओ, कैसे मैनेज करोगे?
Ma'am, then I'll give my muscle relaxant. Preferably injection rocuronium.
Rocuronium, okay.
And
have Sugama Dex available in your hospital? Do you have Sugama Dex? Because if you are planning to use rocuronium
no, ma'am.
for RSI, then you need to have Sugama Dex with it.
No, ma'am, not here.
So?
Ma'am,
Which is
choline.
Succinylcholine, 1 to 1.5 mg per kg. All right.
And ma'am,
Say.
Ma'am, after the cricoid pressure is only removed after the end tidal confirmation of the correct placement of the tube.
Okay, see, if you have read the DAS guidelines or maybe IDA guidelines also, all of them mention that you can optimize the patient position as the initial step. If you make the position slightly head up by 20 or 30 degrees, then how is it going to help? See, it will improve the FRC, slight head up tilt. And then it will also make it easier to insert the laryngoscope. The problem that we face with enlarged breasts, that is minimized to a certain extent. So they recommend to keep the patient in slight head up position. That is the optimal position. Okay, then you start with your pre-oxygenation that you said correctly, and how to denitrogenate, that is fine. At the same time, nowadays, they say that you can consider nasal oxygenation. You just put a small catheter, nasal catheter with a flow of 5 liters per minute. According to DAS guidelines, it is 5 liters per minute. According to IDA guidelines, it is 15 liters per minute. But it is a good idea to keep a oxygen, this nasal catheter with oxygen flowing continuously. So even during period of apnea, the oxygen will continue to be delivered by diffusion. So this will increase the time to desaturation. All right. And then you have given your assistant is giving cricoid pressure, and you have given your induction agent and muscle relaxant. After that, they say consider face mask ventilation. That is what modified RSI is. In traditional RSI, we used to say we will not ventilate after giving this before intubation. In modified, they say you can consider gentle positive pressure ventilation, gentle face mask ventilation. The pressure should not be more than 20 centimeter of water. Now, how this is going to help? This will again increase the time to desaturation, and you get some idea whether you can ventilate this patient in case it is needed for a long time, in case of failure of intubation. So you can consider it if there is not a very high risk of aspiration or something, then you can, with proper cricoid pressure, you can consider gentle, very gentle positive pressure ventilation. Now you will intubate the trachea, confirm the tube position, and then only ask your assistant to remove the cricoid pressure. All right. Now, I'll just take 2-3 minutes more just to complete this scenario. So if you fail to intubate, what next? The tube is not going.
Ma'am, we can use an LMA as a rescue device.
Okay. See, first attempt has failed. You can take 2 attempts. You call an experienced person with you. You can take different types of laryngoscope. You can use some other type of laryngoscope, or modify your head and neck position, modify cricoid pressure. You can consider reducing, or even removing cricoid pressure if required. So you can take second attempt. If that also fails, then you should declare it as failed intubation. Third attempt should be taken only by a very experienced person, if available. Otherwise, this is a case of failed intubation. And now you move on to the second step. Now your focus should be on maintaining oxygenation. So use LMA. You can use any second generation supraglottic device. But here the thing that you must remember is that you should remove cricoid pressure at the time of insertion of the LMA. Because this cricoid pressure will interfere with the positioning of the LMA, the tip of the LMA in the hypopharynx. So at the time of putting LMA, just remove this cricoid pressure and then reapply it after insertion of LMA. If that is also not possible, for LMA also they say maximum 2 attempts should be taken. If that is also not successful, just try to maintain oxygenation using face mask ventilation, 2-person face mask ventilation. If that is also not successful, then you move on to the next step. They cannot intubate, cannot oxygenate scenario, where what will you do?
Front of neck access.
Yes, front of neck access. So all this you should be very clear about when you are giving GA to your patient. And just in one sentence, can you tell me about the analgesia that you are going to provide to this patient?
Ma'am, multimodal analgesia, in which for intravenous we can give NSAIDs, we can give paracetamol. After the delivery of the fetus, we can also give her opioids. Like
we are given opioid, and towards the end of surgery and in the postoperative period, you can continue with paracetamol and NSAIDs. Any block that can be used to provide?
Yes, transverse abdominis plain block can be given. Also, ilioinguinal, iliohypogastric block can also be given.
Okay. Now, what about the postoperative management? Just the important points that you should keep in mind.
Ma'am, the same intra-op concerns wherein we want to avoid anything that which increases the oxygen demand. We want to avoid those, and so we'll continue with the oxygen supplementation. We will use a pelvic wedge, and we'll ensure that
Now pelvic wedge is not required. The baby is out. Aortocable compression, that thing is not that important now at this stage. But you have to give enough oxygen to the patient, continue with the oxygen supplementation, proper monitoring, and avoid then the same things, hypothermia, even hyperthermia. If patient develops fever, her oxygen consumption will increase.
Yes, ma'am.
Because of pain, she hyperventilates. Again, oxygen consumption will increase. So try to, prevent factors which will increase oxygen consumption or which will impair the oxygen delivery or shift to the left. So again, take care of all those things. Thank you. So now we can hand over to Dr. Abhinav because our time is over. There are many more questions that you should know, but yes, here we can discuss up to a limited extent only. So thank you.
Thank you so much.
Thank you, ma'am. Can we have the presentation of Dr. Abhinav, please?
Yes, please.
Is it audible? I don't think.
Oh no, can't hear.
Wait, the presentation is not audible.
Please unmute yourself, Dr. Abhinav.
Ma'am, that's a recording, ma'am. I'll just see to this.
Okay.
Good afternoon, everyone. Myself, Dr. Abhinav Srivastav, Senior Resident in RML Hospital. And today I'll be presenting topic of pregnancy with anemia under guidance of Dr. Medha Mota ma'am. So let's begin by looking at maternal mortality rate, which is in India at 204 per 1 lakh live births. In US, it is approximately 7 per 1 lakh live births. Hence, it's critical for us to understand physiological changes in pregnancy and how anemia alters anesthetic considerations. So coming to physiological changes in pregnancy, these changes can be due to hormonal alteration, mechanical effect of gravid uterus, increased oxygen and metabolic requirement, and hemodynamical alteration. Two patients are cared for simultaneously during pregnancy. Failure to take care can be disastrous for one or both of them. These are some of the changes which occur during pregnancy. So blood volume changes approximately 30% from the normal levels, of course. Plasma volume from 45% change. Cardiac output is increased up to 30 to 50% and so on. So coming to the volume homeostasis, the total plasma volume is increased during pregnancy approximately 45%. The factors which result in contribution are increased sodium retention, the RAS mechanism, decrease in thirst threshold, and decrease in plasma oncotic pressure. So in normal delivery, basically 400-500 of ml of blood loss occur, while in cesarean section, approximately 800 to 1000 ml of blood loss occur. So coming to the cardiovascular system effects, basically cardiac output effects. Cardiac output increases to meet the accelerated maternal and fetal metabolic demands. It increases approximately 40% by 12 weeks and 50% for rest of pregnancy. And it is highest right after delivery due to uterine contraction. Diastolic blood pressure increases more compared to the systolic blood pressure, the percentage change. And we have got this aortocable compressions, which is of utmost importance during if we study normal physiological changes which occur during pregnancy. There is compression of lower aorta and compression of inferior vena cava. So because of this supine hypotension syndrome, which is hypotension associated with pallor, sweating or nausea and vomiting can occur. And it occurs in 20% of women at term. Women with 20-week or longer gestation should not be placed supine without left uterine displacement. And it can be done by tilting the table left side down or rigid wedge, which is greater than 15 degrees under the right hip. One of the utmost important point to be noted here is that fluid preloading should be done before neuroaxial anesthesia is administered. It helps in preserving uteroplacental blood flow. Coming to the respiratory changes, there is changes in the upper airway, minute ventilation, lung volume, and oxygen consumption. These are some of the changes which occur during pregnancy pertaining to the respiratory parameters. Due to increased metabolic demands, oxygen consumption and minute ventilation progressively increase during pregnancy, and pregnant women thus takes larger tidal volume to eliminate carbon dioxide. One of the utmost important things during the respiratory change which occur in normal physiology of pregnancy is that there is decrease in the functional residual capacity, which along with increase in O2 consumption leads to decrease in mother's ability to tolerate apnea. So there is increased risk of hypoxemia in anesthesia. That is why pre-oxygenation is important before induction. Along with that, there is capillary engorgement of respiratory tract mucosa. So we should use smaller size endotracheal tube, approximately 6 to 7 mm during general anesthesia, and repeated attempts at laryngoscopy should be minimized. Coming to the CNS changes and its anesthetic importance, there is decrease in the minimum alveolar concentration of inhalational agents. Local anesthesia requirements for subarachnoid or epidural anesthesia reduced in pregnancy. There is diffusion of local anesthesia to the receptor side along with increased sensitivity of nerve fibers to local anesthesia. There is engorged epidural venous plexus and raised CSF progesterone level. So the amount of drug which we give during pregnancy for the LSCS is less compared to the other normal surgeries which we normally do. IVC obstruction by enlarging uterus results in engorged epidural venous plexus. There is decrease in CSF volume and decrease in volume of epidural space. This enhances the Keflet spread of local anesthesia during regional blocks. Coming to the GIT changes, as we all know, the pregnant women are prone for higher risk for aspiration, basically. So this is because the upward and anterior displacement of the stomach by uterus, which result in incompetence of gastroesophageal sphincter, and gastroesophageal reflex and aspiration can occur. Apart from this, increased progesterone is there, which can lead to decreased tone of gastroesophageal sphincter. So narcotics and anticholinergic reduce lower esophageal sphincter pressure and should be used with caution. Renal changes, renal vasodilatation increases renal blood flow early during pregnancy. There is increase in GFR and increased renal plasma flow by 50%. Coming to the hepatic effects, there is 25 to 30% decrease in serum pseudocholinesterase activity, which is present in tub, and thus if we are giving succinylcholine, the action can be a bit prolonged. Coming to metabolic changes, there is increase in thyroid binding globulin with increase in T3 and T4. Free T3, T4, and TSH remains in normal range. Now, some points about the placental transfer of an anesthetic agents. Highly ionized substance have poor lipid solubility, as we all know, and molecular weight less than 500 Daltons cross easily. So, to summarize, pertaining to this physiological changes in pregnancy, careful attention to the assessment of airway and any necessary preparation should be done for difficult airway in preoperative period. And when positioning the patient on table, remember to use either a left tilt of between 15-30 degrees or a wedge under the right buttock to minimize retrocaval compression. Once airway is secured, ventilation should be aimed to keep the PCO2 in normal range for pregnancy, and MAC of volatile anesthetic is slightly reduced. Coming to our main topic now, pregnancy with anemia. So anemia is a qualitative or quantitative deficiency of hemoglobin or red blood cells in circulation, resulting in reduced oxygen carrying capacity of blood to organs and tissues. So basically, WHO classifies anemia into mild anemia as hemoglobin of 10 to 10.9 gram per deciliter, moderate in range of 7 to 9.9 gram per deciliter, and severe less than 7 gram per deciliter. We have got an ICMR classification also. Anemia causes can be classified as nutritional, which can be due to iron deficiency, folate deficiency, and so on. Infections such as malaria, hookworm infestation, bone marrow suppression, aplastic anemia, renal disease. So iron deficiency anemia is one of the commonest type of anemia in pregnancy. And blood volume expansion in second and third trimester resulting in iron deficiency anemia is one of the major causes. Apart from it, we can have infections and macrocytic anemia due to deficiency of folic acid or vitamin B12 also. So maternal plasma volume begins to increase early at 6 weeks and continues to rise by 45 to 50% till 34 weeks of gestation, and it returns to normal by 10 to 14 days postpartum. Increase in plasma volume exceeds the rise in RBC volume, resulting in hemodilution and consequent physiological anemia of pregnancy. As we all know, oxygen is carried in the blood in two forms, as a physical solution in plasma and reversible chemical combination with hemoglobin, that is oxyhemoglobin. Arterial blood contains only 0.3 ml of O2, and the O2 content of blood can be calculated from a formula which is HB into 1.37 into saturation of O2 plus 0.0034 into PaO2. The relationship between the saturation of hemoglobin with O2 and the partial pressure of O2 in blood is best described by oxygen dissociation curve. This is a table which is showing specific concerns of different type of anemia. So if a case of iron deficiency anemia comes, it can have various stages basically. So tests such as serum ferritin, serum iron, and transferrin saturation along with MCV, MCH, MCHC can be undertaken to determine the cause of iron deficiency anemia. Now coming to management of iron deficiency anemia. Responses to iron therapy can be documented by an increase in reticulocytes 5 to 10 days after initiation of therapy. Oral iron, as we all know, is safe, inexpensive, and effective way to administer iron. Ferrous sulfate is least expensive oral iron and allows more elemental iron absorbed per gram administered. Parenteral iron therapy is indicated for patients suffering from inflammatory bowel disease or is non-compliant patient and unable to tolerate oral iron. Different preparations include iron dextran, iron sucrose, iron sorbitol citric acid complex. Now, total dose of the iron which we are administrating can be calculated by a formula which is 15 minus patient's hemoglobin percent into body weight in kilogram into 3. Now, what is the minimal acceptable level of hemoglobin which can be needed for preoperative transfusion? Transfusion is rarely indicated in stable patient with hemoglobin is greater than 10 gram per deciliter and is almost always indicated when less than 6 gram per deciliter. There's compensatory mechanisms in pregnant anemic patient, which is increase in cardiac output, rightward shift of oxygen hemoglobin dissociation curve, and increase in 2,3 DPG concentration in RBC. Now coming to anesthetic considerations. So as we discuss, iron deficiency anemia is one of the most common causes of anemia which occurs in pregnant females. History suggestive of poor tissue perfusion can manifest as tiredness, easy fatigability in mild anemia to breathlessness and palpitations in moderate to severe anemia. Tachycardia, wide pulse pressure, and systolic ejection murmur can be signs of anemia in pregnancy. So we should undertake investigations like CBC, reticulocyte count, blood grouping. Other investigations include serum creat, bilirubin, serum iron, total iron binding capacity. Main anesthetic considerations in chronic anemia are due to minimize factors interfering with O2 delivery, prevent any increase in O2 consumption, and avoidance of hypoxia. Careful positioning of patient is required to minimize position-associated volume shifts. Mild tachycardia and mild pressure may be physiological and should not be confused with light anesthesia. Monitoring should be aimed at assessing the adequacy of perfusion and oxygenation of vital organ, and central neuraxial blocks can be judiciously employed using either a low-dose spinal anesthesia along with adjuvants or an intermittent dosing continuous epidural. Now, choice of anesthesia will depend on severity and type of anemia, along with the concomitant medical conditions and anticipated blood loss. Regional anesthesia is relatively safer in patients with moderate anemia with no cardiac decompensation, but should be avoided in patients with severe anemia with decompensation. Analgesia can be extended in the post-operative period, and risk involved with general anesthesia are avoided in regional anesthesia. The major disadvantage is that the sympathetic blockade extending above T4 can lead to sudden hypotension and increase further load on heart and impairment of respiration and oxygenation. General anesthesia is the choice in severely anemic or moderate anemic patient with cardiac decompensation. Major advantages include better cardiovascular stability, control of airway and ventilation. Disadvantage, of course, includes aspiration, hypoxemia during induction, failed intubation, and neonatal effects if induction delivery time is more than 8 minutes. So after all this knowledge, I think anesthetic management we can discuss, which is pre-anesthetic checkup includes history of tiredness, easy fatigability, breathlessness, history of increased or acute blood loss from GIT, conditions such as COPD, restrictive lung disease should be taken care of. Investigation-wise, complete blood count, RBC count including hemoglobin and hematocrit, and platelet count are of utmost importance. Coming to monitoring, non-invasive monitoring include ECG, NIBP, that's non-invasive blood pressure, temperature monitoring, pulse oximetry, and additional monitoring can be undertaken if anticipated major blood loss includes central venous pressure monitoring, invasive arterial blood pressure monitoring. Goals during surgical intervention include avoidance of hypoxemia and avoidance of hypothermia, along with avoidance of hyperventilation. Coming to post-operative management. So if a patient is having pre-existing anemia or perioperative blood loss, it should be looked upon, and immediate post-operative management includes supplemental oxygen to maintain hemoglobin saturation. Postpartum management of iron deficiency anemia. If we have mild to moderate postpartum anemia, oral iron therapy for 3 months in hemodynamically stable, asymptomatic or symptomatic patients. Switch to parenteral iron if inadequate response to oral therapy. Ferric carboxymaltose up to 1000 mg in a single dose provide faster and more effective correction of hemoglobin. Special conditions such as sickle cell and thalassemia, triggers like hypoxia and acidosis must be strictly avoided. In thalassemia, iron overload and cardiac dysfunction are major concerns due to frequent transfusion. Thank you.
Thank you, Dr. Abhinav. Over to you, Medha ma'am. You want to add on something else?
Yeah, just a small comment that during the presentation, I think it was said that succinylcholine levels are low. So the action of the plasma pseudocholinesterase levels are low. So succinylcholine's action may be prolonged. But in pregnancy, this decrease in cholinesterase levels is not that significant. So the duration and dose of succinylcholine remains the same. Rest, everything has been covered. If there are any questions, then I would be very happy to answer them.
Ma'am, I don't think so. There are no questions in the chat box.
Okay.
I think there's not much scope for any queries. So everything has been very excellently covered. Thank you so much, ma'am.
Thank you so much. Thank you. Thank you.
Thank you. Thank you, ma'am. Thank you, Annapurna and Abhinav, for an excellent case discussion. Thank you so much.
Thank you.
So with this, moving on to the next part of the session. For the next session, let me reintroduce our chairperson, Dr. Nisha Kachru. We have met ma'am today morning itself. So we have already introduced ma'am. Over to you, Nisha ma'am.
So the next section will be a lecture delivered by Dr. Garg on biostatistics. Biostatistics is very important. All of you have done your thesis and you know that we needed to analyze the results and then the implications of that in clinical practice further have to be understood. So Dr. Rakesh Garg is going to take you through it today. He is a professor in the Department of Onco-Anesthesia and Palliative Medicine at Dr. BRAIRCH, All India Institute of Medical Sciences. He has over 350 publications, 25 chapters. He has written 2 textbooks. Dr. Rakesh Garg's name should be familiar to you all because he is the editor-in-chief of the Indian Journal of Anesthesia and Journal of Onco-Anesthesiology and Perioperative Medicine. His areas of interest are onco-anesthesia, airway, research, cancer pain, and palliative medicine. So over to Dr. Garg.
Thank you so much, ma'am, and thank you all the Appec team for the kind invite. So we'll take you through the basics of biostatistics, which is one of the important components when we talk about the research, when we talk about the interpretation, when we talk about critical appraisal. We need to understand these basic concepts so that we can go ahead and do it. May I ask if my audio and video is clear?
Yes, sir.
Yes, I think it is quite clear, Dr. Garg.
Thank you so much, ma'am. Thank you. Thank you, Sudhir. So what we'll be talking about in next around 25 minutes or so, we'll be talking about the variables and what all statistical tools needs to apply to summarize the data that we have collected and how to analyze them effectively to make some concluding statement. Now, this is important to understand what variable mean. It is anything that has a quantity or a quality attached to your observational value, and it needs to be defined appropriately at the start of study. Whether you are talking about age of the patient, you are talking about the patient satisfaction using a Likert scale or a scoring system, whatever you are looking for calculating or recording a parameter, it needs to be defined. And the definition should be very clear. And then you need to understand whether it's a continuous or a discrete variable that will come a little later. But you need to define them appropriately so that there is no dichotomy when you collect these patients. As simple as when we say age at last birthday. So somebody who is crossing 6 months, he may put his age at the last one or the next coming one, depending upon what type of collection of data is being done. And hence you should be clear when you're collecting them. Second is when we talk about variables in study, there are 2 types of variables. Usually broadly we say independent variable or a dependent variable. Now independent variable means the characteristics that when changed or modified will influence the outcome. And dependent means the influence or the change, if you change something, will be dependent on some other variable, which become a dependent variable. So this needs to understand because a third variable that we usually talk in the study remains the confounder variables. And these confounder variables also needs to be assessed because if certain variables are affecting your outcome parameters, it will be difficult to interpret the data. For example, if you are looking for, say, caffeine causing cancers, and you do not consider patients with smoker versus non-smoker, then some of the patients in a group will have more smokers as compared to the other, and this becomes a confounder variable. And this is important to understand and identify because the same outcome is being influenced by a third variable, and here it is called confounder variable. So this is 3 terms that we have used up. And you need to be very clear when you choose your outcome parameter that what are dependent and independent. To summarize again, independence means one thing you change, limit to only one in an experiment. Dependent means the change that happens because of the independent variable. So they have some influence on the other variable. And control means it remains the same. Now, the other quality or other parameter attached to variables are the qualitative versus quantitative. So these are two components. If they have some categories to it or some, they are not numerical values, they are labeled as qualitative and categorical variables. If they have some numerical numbers or quantity, they are called quantitative or numerical variables. They are further divided as nominal ordinal or discrete continuous. Sometimes it may be asked as a short note in your theory exams, but they are important when your thesis is being evaluated. You need to understand these variables. Remember, for the analysis purpose, sometimes we try to change from one category to the other. We can always categorize the quantitative variables. For example, if a BP is 140, 150, 160, 110, 90, these are the quantitative variables. But sometimes, for the purpose of analysis, we can divide them into hypotensive, normotensive, hypertensive. So this means we are changing them from quantity to quality or categories. So this is the conversion can happen from quantitative variables to qualitative variables, but vice versa is not possible. Now, when we have collected the data by doing a study, we need to interpret them. And the analysis will be understood at variables level. So when you are doing design or protocol writing of your study, you need to understand here itself your statistical tool starts coming up. So don't think that when you are analysis and publish your paper, then only the analysis or the statistical tools comes up. They would depend upon the study design that we have looked for. It will require sample size. This randomization has different analysis as compared to a non-randomized study, and hence you need to understand at the beginning itself. Now, why do statistics? Because when you see your data sheet after data collection, there'll be a huge number of numerical numbers or figures, and you will not be able to make any concluding statement out of it. So we have to summarize the data so that we can meaningfully understand it. And second, we need to compare sometime that the difference between the different groups that we have assigned as a part of our study, 2-group design study, 3-group design study. Accordingly, we need to compare them, that which is better with respect to some of the objective that you have looked for. So these are the two basic purposes of the statistical analysis. So when we say statistical analysis, there are two types, descriptive versus inferential statistics. Now, descriptive means that probably we are just summarizing them. See, for example, if you have 100 patients, you have seen for their age or numerical rating scale, or you're looking for length of the hospital stay, you are 50 patients, you'll not be able to understand that what these numbers are. If you can summarize them in the form of a mean or a median, say your mean age is 54 years, this means you are summarizing them. Then you understand that approximately all patients were somewhere around in 50s. This is called descriptive. Inferential means that one group has 54 mean age, the other group has a 64 mean age. Now you want to see whether this is statistically different or not. So I'm using a word statistically different. I will come a little later. What does it mean by clinical difference? Clinical is between the two groups that we are analyzing. So this inferential statistics means you will apply certain tests and to see whether this difference has a statistical significance or not. Now, when we start analyzing, it depends upon the type of study you have. It could be a one variable. When you compare two variables, becomes bivariate. Sometimes more than two variables, it becomes multivariate. We have already talked about variables. So univariate means qualitative or quantitative. If there are two variables, they can be three combinations, as you can. So if there are categories, say for example, gender, we usually say percentages. 30% were male, 70% were females, or frequency. Talk about the quantitative aspect. We need to summarize them in the form of mean and median. And when we say mean and median, usually with mean, we mention standard deviation. With median, we usually mention about range and interquartile range. Now, remember that when to use mean and median, there are different aspects. When your data is normally distributed, that is a Gaussian distribution. I'll show you the graph little later. You need to report your data as mean. If your data is not normally distributed, that is non-Gaussian distribution, you need to apply median into it. So remember that when to use median, it is normally distributed data. When to use median, it's a non-Gaussian distributing data. The other aspect is we get a mean value or a median value, but the data will be dispersed around it. And this is called measures of central tendency or measures of dispersion. Now this measure is across a central number that is usually described. We don't use mode usually, we usually describe mean, median, and I've already mentioned when to use mean and when to use median. Now, when we start looking for this data, the middle line will be your mean or a median, and the data will start distributing across this line on both the ends. Now, if you try draw a curve around these all values, if it shapes bell-shaped, this is called symmetrical data or a Gaussian distribution or a normally distributed data. Such data must be reported as mean along with standard deviation. But in case if you think the data is not like a bell shape but skewed on the left or the right side, these are called non-Gaussian or non-symmetrical data. And here you need to report your data in descriptive statistics as median along with range and interquartile range. So very, very clear, you cannot quote both because data cannot be normal and not normal in the same collection. So that's why you need to choose them accordingly. So this is what we mentioned. Gaussian distribution, mean, non-Gaussian distribution, median. Now, statistically, the Gaussian distribution, and we apply robust statistical tool, which are called parametric tests. Non-parametric tests are less effective and they're applied for non-Gaussian distribution. So statistically, we can look for the distribution using tests like Kolmogorov-Smirnov or Shapiro-Wilk. And also sometimes if you compare mean and median, and if they're less than 5%, probably it appears to be a Gaussian distribution. If they're more, then it's not Gaussian. But in case if you have collected data, it's non-Gaussian, it becomes not a good statistical data for parametric analysis. Sometimes statistically we try to convert into logarithmic transformation to make them Gaussian distributed and try then apply parametric test as for normal distribution. But sometimes this still remains non-Gaussian. We have to apply non-parametric test, and then we will not be able to conclude whatever the results comes out from them. So this is for you to summarize once again. Normally data or a Gaussian distribution use mean, non-Gaussian use median, range, IQ. Now coming to the inferential statistics. Inferential statistics, we use two terms, p-values and confidence interval. Nowadays, all the journals, including IZ2, wants to use both the values because p-values is not. It's just a measure of effect which happens by chance, and this is being shown by the p-value. It does not say anything about the comparison between that which is better, which is worst, and take some confusion from it. This is just says that the difference has happened because of by chance, which is as depicted by the p-values. So this means the observed value may not be equivalent to true value, and hence we need to add something different. This is what different is the confidence interval. Confidence interval is basically a range that, if I speak it very grossly, that if you do the study 100 times, what would be the mean value 95% of time? So this means statistically, we are repeating study 100 times to see the value. Every time mean will be a little different, and whatever this range comes is called 95% confidence interval. So it gives more robustness to your data, and hence you will be able to maintain some meaningful value. That's why 95% CA must be reported. Now coming to the bivariate analysis, where we are using two variables, and this is most commonly when we do a randomized controlled trial, a two-group study design. This is usually what analysis that we use. Now, since we have two types of variables, categorical and quantitative, so these three combinations can happen. So when we want to analyze the data that we have collected, we require 4 informations, and that's I said, it needs to be described in which variables you want to compare, whether the data you have collected is normal or not normal, how many groups you have, and the data you collect is related or non-related. Related means that you have done something pre and post. Separate groups. In one group, you have used drug A or equipment A. In other, you have used drug B or equipment B. Hence, you need to be clear about those 4 parameters to look for which statistical tool will be appropriate for them. So combination of 2 variables, you can easily know normal, not normal. We have already discussed. You can use test, ask your statistician to tell you. They will do it. Groups, you already know your study design. You know it's 2-group study or more than 2-group study. And related again depends upon your study design. So you are aware of it. So you already have the idea of the various variables that you have collected. Now we need to apply a statistical test. Now each statistical test will depend upon these combinations. So I will take you through about those variables. So now if you're comparing categories versus category, means 2 groups, for example, you need to compare gender. Now if there are 2 groups, they are unrelated. This means 2 separate groups. You will apply chi-square and Fisher-Exer test. Even for related, you will apply for McNeman test. Now when you're comparing category versus category, if there are more than 2 groups, you will use the similar test, chi-square or Fisher-Exer for unrelated, McNeman for related. Now, in the unrelated, chi-square and Fisher-Exer test, if the event rates are less than 5, you apply Fisher. If there are more, you apply chi-square. This is how you choose the test. Now, most of the time, we are using statistical software tools. You have to choose this test to give you the correct values. Even if you get from statistics, ask which test is applied and check they applied the correct test, because system does not know anything. So if they apply a wrong test, McNeman test, it still give you p-values, but that will not be correct. Hence, you should be aware that which test is appropriate for your data. Now, coming to the categorical versus quantitative. For example, you want to compare numerical rating scale, length of hospital stay, the mean blood pressures, and so on and so forth in 2 groups. Now, since there is a quantitative, so quantitative will have to be analyzed for normality. If they are normally distributed, you will apply parametric test, as I mentioned earlier. If there are 2 groups, unrelated, you will apply student t-test. If they are related, you apply pair t-test. More than 2 groups, if they are unrelated, one-way ANOVA. If they are related, repeated measures ANOVA. For example, when you measure blood pressure after laryngoscopy at 0, 1, 3, 5, 10 minutes, they are related, apply either the repeated measures ANOVA, and in case if they are unrelated in 2, say 3 groups or 4 groups, you will apply one-way ANOVA. Now, in case if your quantity variable was non-Gaussian distribution, you will apply non-parametric test. For 2 groups, unrelated, Wilcoxon rank sum or Mann-Whitney, they are same. For related, you will apply Wilcoxon sign rank. If there are more than 2 groups in your study, if they are unrelated, you will apply Kruskal-Wallis. If related, Friedman's test. So be very clear. Ask your statistician person. It is mandatory to report into your thesis as well as your research paper that what was your data, what were the variables, outcome variables, whether they were normally distributed or not, and which tests were applied. So these are the mandatory requirement. Now, if they are combination is both are the quantitative, right? Say for example, you want to compare the age versus length of hospital stay. So both are numbers. So you want to have some relation. More the age, more the hospital stay after a major surgery. So something like this. So here you want something correlation between them. If both the data are normally distributed, you need to apply Pearson's correlation. If they are not normal, Spearman's rank correlation. So this is what in summary for the selection of test. So be very clear, you need to understand that. Check that your statistics person has applied the right test. and also report into your study. Right. Now, having said that, when you want to analyze these values, you also need to understand the clinical interpretation. So I'll take you some of them. There are many. I'll take you some of the important ones. The most important one is the statistical significance does not guarantee clinical significance. Even if the p-value comes out to be 0.001, do not say always that group A is better than B, group B is much, much better than group A or something like this. You need to look for the clinical significance also. For example, if we take an example, we have compared tracheal intubation time using two types of video laryngoscopes, and they found that p-value was 0.01, and the time taken by two laryngoscopes were 14 versus 18 seconds. Now we know that 14 versus 18 seconds, though p was 0.01, it is statistically significant, but it does not have any clinical significance because the difference of 4 seconds, and when both are within the clinical limits, patient will not become hypoxic in a normal airway. This means this is of no clinical significance. So please interpret your data not just based on statistical significance, but do consider whether it has some clinical value or not. So this is what you need to be clear, and that's why sometimes we have started using nowadays mandatorily the confidence interval, the effect size. So if you see here, even the difference was same, 14 versus 8, p-value 0.01. But if we report confidence interval, even statistically, they are overlapping. If you see 12 to 18 seconds, 14 to 20 seconds, both these values are overlapping. So this means even the statistical, there is no difference here, and obviously no clinical difference, even though the p-value was significant. So this p-value depends on multiple parameters, and hence you need to make appropriate interpretation based on the values that come up. Second point, sometimes we do a lot of subgroup analysis, also called as data dredging or multiple testing. Now, if you see this interesting study, which was reported to explain this phenomena, in 1980s, around 1,073 heart patients were divided into two groups, but no intervention was done. They received the same treatment. All patients received the same treatment. And obviously, when they receive the same treatment inside two groups, obviously they will be comparable. Now, what they did is they divided them into 18 subgroups based on age, gender, and so many other values. And they found that one group was significantly different from the other. Now, how can this happen? They have not done anything. They were just randomized in two groups. Everything was same. So why this difference? Because there are certain assumptions in the analysis that we do. And if you try to do a multiple analysis, something like if you beat somebody and say you're a thief, he will say, okay, I'm a thief. So that is what is called torturing of the data. You need to remember it's not correct because we assume that 5% of error is acceptable. You usually put your alpha 0.05. This means when you apply a single test, we accept that 5% error can happen, we accept it. But if you run multiple tests, this is exponentially increased. And this error increases for the 20%. Higher than the expected norm of 5%, and hence multiple testing will not conclude anything else. Also remember, when you try to interpret, look for the role of bias, confounders, chance, and associations. So when you interpret it, the bias can affect your outcome, the confounder variables can affect. You need to look for into your method section that these does not happen, and then only you can say that the real association or the difference between two groups exists. Hence, you should be interpreting your data just not on p-values, but try to understand all the things that we have discussed. They need to be included when you're looking for. So to summarize, we need to understand the statistics for multiple reasons. It's not statistics. Statistics do assume that you have done blinding, randomization, concealment, appropriate exclusion of biases, confounders. Then only those tests are applicable. So that's a basic assumption of these tests. Hence, ensure that these all tests, all those things have appropriately been covered in your protocol at the planning stage itself. And then you can try to interpret the data as we have just discussed. So understand your statistics at the study planning itself, involve the person who knows it, but also cross-check that the right test has been applied to your data appropriately or not, and interpret the data just not on p-values, but consider everything that we have discussed about biases, confounders, by chance association, real association, statistical significance versus clinical significance, or clinical differences between the two groups. Based on this, you need to assess your parameter. So thank you so much, and we are open for questions now. Any questions you can look for? Actually, this is a very big session, maybe around for 3 to 4 hours, but I have tried to summarize it with the specific time given to me. So any comments or question, most welcome.
So there are no questions in the chat box, actually. Nisha ma'am.
So since there are no questions, then I would thank Dr. Garg for his
Yes,
wonderful talk, and thank you. And I hope it will not only help the students in writing answers or notes on biostatistics in the exam, but also practically how to apply this knowledge when they are doing research and other studies.
Thank you, ma'am.
Thank you so much. Thank you.
Thank you.
Thanks.
Thank you. So our next talk is by Dr. Neha Gupta herself. And Dr. Neha is a professor at ABVIMS and Dr. RML Hospital. Her areas of interest lie in giving and discussing ultrasound guided regional anesthesia, BCS and CCLS, as well as hyperbaric medicine. So Dr. Neha will be giving a lecture on neuromuscular monitoring. So over to you, Dr. Neha.
Thank you for that introduction, ma'am. So, just share my slide. Okay, so a very good evening to everyone. So in this session, we'll be talking about neuromuscular monitoring. So to begin with, why do we need neuromuscular monitoring at all? So the first and foremost indication for neuromuscular monitoring remains detection of any residual neuromuscular block. So you need to remember this is the main indication for NMT monitoring, and all other indications are basically the corollaries of this one. So NMT is also used as a guide to optimize dosing of neuromuscular blocking agents, to find the optimized time of administration of reversal agents, and also to assess the time pattern of recovery. Now, what do we actually mean by a residual neuromuscular block? It can be defined by the presence of signs or symptoms of muscular weakness after administration of neuromuscular blocking agents, even after reversal of neuromuscular blockade. As you all know, it is associated with serious complications like pharyngeal dysfunction, increased risk of aspiration and pneumonia, hypoxemia, airway obstruction, and increased length of stay in PACU. It is signified by a TOF ratio of less than 0.9. TOF ratio we'll be subsequently talking about. The incidence is as high as 20 to 40%. And the solution lies in doing a neuromuscular monitoring, and that too preferably a quantitative one. Now, what are the various methods of NMT that are used? They can be divided as clinical tests, qualitative evaluation, and quantitative monitoring. The clinical tests are the ones that we all routinely do in our OTs on a daily basis. They involve an evaluation of respiratory parameters and muscle function, that is sustained head lift, leg lift, and hand grip for 5 seconds, a maximum inspiratory pressure of 40 to 50 centimeters of water. Now, these tests are pretty unreliable because the sensitivity is less than 0.35 and positive predictive value is less than 0.52. They also require a high degree of cooperation and wakefulness on the part of the patient, which we know is a challenge when the patient is actually coming out of general anesthesia. So a slightly better method is the qualitative evaluation. It, as we all know, employs peripheral nerve stimulators that we all routinely use. It involves visual and tactile assessment of response to stimulated muscle. There are various patterns of nerve stimulation that can be used, like train of 4, double burst stimulation, post-technique count, which further lead to parameters like TOF count and degree of fade. As we said, these tests are more reliable than clinical tests, However, they also do not eliminate the risk of residual paralysis. So lastly, the quantitative monitoring, this is the best monitoring which is available. It uses neuromuscular devices which stimulate the peripheral nerve while simultaneously recording, quantifying, and displaying numerically the evoked responses. Many methodologies are available for quantitative analysis, which involves mechanomyography, electromyography, acceleromyography, which is most widely used and considered as the standard of clinical care. Then kinomyography, phonomyography, and compressomyography. Now coming on to the most commonly used method of neuromuscular monitoring, that is the peripheral nerve stimulators. They are used to evaluate the effect of neuromuscular blocking agents. They are used whenever precise information regarding neuromuscular function is desired. Or they are used when there's prolonged neuromuscular blockage, such as during vascular and neurosurgeries, and also in case of neuromuscular disorders like myasthenia gravis or Lambert-Eaton syndrome. Now, which are the normal common nerve muscle units that we use for peripheral nerve stimulators? The most superficial and easily available muscle is the ulnar nerve and the adductor pollicis responds to it. Other nerves which can be used are facial nerve, median nerve, posterior tibial nerve, and peroneum. Now, the various muscles, their sensitivities to non-depolarizing muscle relaxants vary. The most sensitive being the extraocular muscles, followed by the pharyngeals, masseters, the adductor and abductor pollicis. And lastly, the least sensitive are the diaphragm and the vocal cords. So this is basically a nature's way of protection. And this is the order, the reverse order is when the patient comes out, the vocal cords and the diaphragm is the first one to come back. Now, certain summary about the equipment and the basic setup of a peripheral nerve stimulator. It involves electrodes, as we all know. Electrodes can be either surface electrodes or needle electrodes. These are the surface electrodes that we commonly use. They are disposable and pre-gelled. They are placed in the medial aspect of the forearm around 2 centimeter proximal to the proximal wrist crease. The surface should be cleaned with alcohol-based solution before applying these electrodes. The waveform, it should be rectangular and monophasic. The duration of current is around 300 milliseconds or even less. And the current which is most commonly used is 30 milliampere whenever ulnar nerve is stimulated. Now coming on to the patterns of stimulation, this is the most important part, especially for the postgraduates. The various patterns are single twitch response, train of 4, double burst stimulation, technique stimulation, and post-technique count. Starting with single twitch stimulation, it was the earliest pattern which was used. It involves a repetitive supramaximal stimuli for a period of around 0.2 milliseconds at regular intervals. So whenever around 70 to 75% postsynaptic receptors are occupied, the twitch response is depressed. This type of pattern is useful during onset of blockade. However, it is a poor indicator of profound paralysis. However, single twitch stimulation is no more used in clinical practice. This is how a single twitch stimulation looks like. So coming on to train of 4, this is you all are already familiar with. It is the most commonly used pattern of stimulation, and it consists of 4 supramaximal stimuli given at a frequency of around 2 Hz every 0.5 seconds. What is TOF count? It is the total number of responses being produced. What is TOF ratio? It is the ratio of the fourth response to the first response. And the normal value in an awake patient would be obviously 1. There's something called fade pattern, which we'll eventually see. It is characteristic of non-depolarizing muscle relaxants, and it's not present when succinyl is used. However, if after succinylcholine injection a fade is observed, it signifies a phase 2 block. So this is what we were talking about. In case of non-depolarizing block, the T4 response is the first one to disappear, followed by T3, T2, and T1, thus giving a characteristic fade appearance. This is what is known as fade, and it is a characteristic of NDMRs. However, in depolarizing block, the magnitude of all the 4 responses decreases equally, so there's no fade present. This is the similar thing being repeated. The fade is seen in a non-depolarizing block. In phase 1 block, that is a normal succinylcholine block, no fade is seen. However, if a fade is seen after succinylcholine, that shows it's a phase 2 block. So what are the common TOF guidelines? If the TOF ratio is between 0.15 to 0.25, that indicates an adequate surgical relaxation. A TOF of more than 0.9 is needed for safe extubation and recovery after surgery. We can correlate the TOF ratio and the TOF count to the receptor occupancy as well. For example, when TOF ratio is 1, that the patient is almost awake, then the 75% of the receptors are occupied. A TOF ratio of at least 0.9 is needed for the patient to be ready to extubate. Benefits, advantages of train of 4. It is the most frequently used pattern. The degree of block can be identified directly. It allows reliable assessment of the onset of neuromuscular block. Clinically relevant information about the onset, relaxation, and neuromuscular recovery can be obtained, and it is not very painful, so not a very deep level of anesthesia is required for it. Limitations of train of 4. It needs objective monitoring. It cannot distinguish between intense and deep levels of block, that is when the TOF count is 0. It does not allow monitoring of phase 1 of depolarizing muscle block. Coming on to the next pattern, the technique stimulation. It consists of high frequency delivery of stimuli in the range of 50 to 200 Hertz. Most commonly 50 Hertz stimulation is used for 5 seconds. It is a very painful pattern of stimulation and can be used only in deeply anesthetized patients. This is how a technique stimulation response looks like. A more practical approach is the post-technique count. It was designed to assess the magnitude of deep neuromuscular blockade. It can only be used when the TOF count is 0. That is, the neuromuscular blockade is profound. It involves a technique stimulus of 50 Hertz followed by 10 to 20 single twitches of 1 Hertz, starting 3 seconds after the end of technique stimulation. It is based on the concept of post-technique potentiation, where there is a temporary increase in response to stimulation following a technique stimulus due to an exaggerated rise in acetylcholine. It is also useful to define the exact moment of Sugama-Dex administration. Coming on to double burst stimulation, it consists of 2 short bursts of 50 Hertz technique stimulation separated by 750 milliseconds. It is mainly useful to detect small residual neuromuscular paralysis. So just a basic summary of the different patterns of stimulation. What as postgraduate students you all need to know. In train of 4, it can be used mostly in all situations. A TOF ratio, as we have discussed previously, should be more than 0.9 before extubation. Post-technique count is the pattern of choice for profound neuromuscular block. It can only be used when the TOF count is 0. Double burst stimulation is useful for recovery. Single twitch stimulation, as we said, is no more clinically used. And technique stimulation, being very painful, should never be used in awake patients. Even technique stimulation has no real indication in routine clinical practices. Now there are many patterns of quantitative neuromuscular monitoring, but the main one that you all need to know is acceleromyography. It is the most popular quantitative technique and being defined as the standard of clinical care. It's based on Newton's second law, which says force is equal to mass into acceleration. There's use of a piezoelectric transducer, which generates a voltage proportional to the acceleration of the muscle. How it is used, the transducer is fixed to the thumb which is being tested. The thumb should be freely moving. The rest of the hand is immobilized and the machine calibration should be ensured before you give relaxant. Advantages, it's a very simple method, widely available and inexpensive, and there's a better detection of residual neuromuscular block than our usual visual and tactile methods. Now coming on to reversal of neuromuscular blockade, it should never be attempted before at least all 4 responses of TOF stimulation are present. Extubation is recommended at TOF ratio of more than 0.9. It's important to know that even when TOF ratio is more than 0.9, around 70% of acetylcholine receptors may still be occupied, and which leads to patients suffering from residual neuromuscular block. So what are the different definitions which are involved? What is meant by a profound block? It's the period of time when there is no response to TOF stimulation. That is, both TOF count and post-technique count are 0. A deep block is when TOF count is 0, per PTC is 1. In moderate block, it is the period between recurrence of TOF count between 1 to 3. A superficial block is a TOF count of 4, and a minimal block is when TOF ratio is more than 0.4. What are the current recommendations for reversal of neuromuscular blockade? In case of a profound block, one has to avoid acetylcholine esterase inhibitors and use Sugama Dex in that place in a dose of 4 to 16 milligrams per kg. In case the patient is in a moderate block, both acetylcholine esterase inhibitors, that is neostigmine, and Sugama Dex can be used. In case of superficial block, a minimal dosage of neostigmine in a dose of 0.02 to 0.03 milligram per kg is sufficient. What are the limitations of neuromuscular monitoring? Neuromuscular response may appear normal despite persistent of receptor occupancy by the relaxants. There can be an individual variability, even that some patients may exhibit weakness even at a TOF ratio of 0.8 to 0.9. The established cutoff values sometimes do not guarantee adequate recovery. And in cases of perioperative hypothermia, increased skin impedance may affect appropriate interpretation of the results. So what are the current guidelines on NMT? As per the 2023 ASA practice guidelines on management of perioperative neuromuscular blockade, they strongly recommend use of quantitative monitoring of neuromuscular block to prevent any residual paralysis, especially using the ulnar nerve and the adductor pollicis muscle unit. These guidelines also advocate for Sugama Dex for reversal of deep, moderate, and shallow aminosteroid relaxants, and also suggest initiating neostigmine reversal only when TOF ratio is above 0.2. Thank you so much.
Thank you, Dr. Neha, for your talk. Are there any questions?
No, ma'am. No.
No, there seem to be no questions. So then thank you very much, and let's move on now. Okay.
Thank you. Thank you so much, ma'am. Thank you, Rakesh, sir. Thank you so much. So moving on to our next, that is the last session of day 5 today. It is the table viva, the drug viva based on neuromuscular blocker drugs, and it will be moderated by Dr. Nidhi Pathak. And the PGs are Dr. Prajit and Dr. Mohit. Can we have the presentation, please?
Good evening, everyone. Today in this session, we are going to talk about the viva voce questions for neuromuscular blocking agents. This topic is very popular among examiners and is asked very often during drug viva. I'm Dr. Nidhi Pathak, Assistant Professor in the Department of Anesthesia, Dr. RML Hospital, and I have 2 second-year postgraduate students with me, Dr. Mohit and Dr. Prajit. So we'll start our session now. I hope this session will be a very good simulation for all the exam-going students. So we'll start with Dr. Mohit. Dr. Mohit, our first drug is succinylcholine, and we'll start now. Can you please pick up the drug and describe it?
Yes, ma'am. The given vial is of succinylcholine chloride, and the concentration of the drug is 50 milligram per ml. Expiry date is March 2026.
Okay. And what class of drug is this?
This is depolarizing muscle relaxant.
Okay. Can you please classify muscle relaxants?
There are 2 classes, non-depolarizing muscle relaxants and depolarizing muscle relaxants. In depolarizing, succinylcholine is there, and non-depolarizing muscle relaxant, there are 2 groups, benzyl isoquinolines and aminosteroid group. In aminosteroid group, the example are pancuronium, rocuronium, and vicuronium. Benzyl isoquinolines are atracurium, cis-atracurium, and mevacurium.
Okay. And can you please classify according to duration of action?
Yes, ma'am. There are 3 classes, short acting, intermediate acting, and long acting. In short acting, like mevacurium, intermediate acting like atracurium, cis-atracurium, vacuronium, rocuronium, and in long acting, pancuronium is there.
Okay, so that was about classification of muscle relaxants. Now we'll come back to succinylcholine. Mohit, can you please comment on the structure of succinylcholine?
Yes, ma'am. The succinylcholine is made up of two molecules of acetylcholine, which linked by methyl acetate group.
Okay, so it is a dicholine ester. And what is the mechanism of action of succinylcholine?
Yes, ma'am. Succinylcholine mimics acetylcholine and acts on nicotinic receptor at postsynaptic membrane, bind with nicotinic acetylcholine receptor, and there are some conformational changes there by which sodium channel open, sodium influx, and potassium efflux is there. So there is sustained depolarization of motor end plate. Initially, muscle fasciculations are there, but the persistent depolarization inactivates sodium channel and muscle can't repolarize.
Okay. And what is the onset of action of succinylcholine?
30 to 90 seconds.
And duration of action?
2 to 8 minutes.
Okay. And what is the ED95 dose of succinylcholine?
0.3 mg per kg body weight.
And intubating dose?
0.5 to 1.5 mg per kg body weight.
Okay. And can you please comment on metabolism of succinylcholine?
Yes, ma'am. It metabolized by pseudocholinesterase enzyme, and the metabolites are succinyl monocholine and choline.
Okay. And have you heard about suxamethonium apnea?
Yes, ma'am. Suxamethonium apnea, it is a prolonged apnea after administration of succinylcholine. Normally, the apnea is 5 to 10 minutes, but in suxamethonium apnea condition, it may be more than 30 minutes.
Okay.
Because of deficiency of normal pseudocholinesterase enzyme.
Okay, so this deficiency can be because of what? Can you please tell what are the causes of suxamethonium apnea?
It may be acquired or maybe genetic. Acquired like pregnancy, old age group, liver disease, and malnutrition. And in genetic, there may be genetic deficiency of the enzyme or atypical variant of pseudocholinesterase enzyme.
So can you please comment on Dupuytren number?
Yes, ma'am. Dupuytren number is the test to identify the abnormal pseudocholinesterase enzyme activity. Dupuytren is local anesthetic, which inhibits normal pseudocholinesterase, and there is no inhibition of abnormal pseudocholinesterase enzyme. If the Dupuytren number is more than 80, it means the enzyme is normal, and the recovery time is 5 to 10 minutes. But if there is the Dupuytren number is 40 to 60, it means the enzyme is atypical heterozygous, and the recovery time becomes 1 to 1.5 times. If the Dupuytren number is less than 20, the enzyme is abnormal. It is atypical homozygous, and the recovery time in hours, approximately 4 or 5 hours.
Yes, maybe even more than that. Okay, so now we'll come to phase 1 and phase 2 block of succinylcholine. So Dr. Mohit, please comment on phase 1 and phase 2 block.
And phase 1 block, because of the normal dose of succinylcholine, it is the desired effect for intubation. But phase 2 block is a complication of overdose or repeated dose of succinylcholine. Phase 1 is depolarization block, and phase 2 is desensitization block. The onset of action is rapid in phase 1 and delayed in phase 2. Fasciculations are present in phase 1 and absent in phase 2. Of response, all twitches equally decrease in phase 1 block. There is no fade, but in phase 2, fade is seen. Post-tetanic potentiations is absent in phase 1 and present in phase 2.
So we can say that in phase 2 block, succinylcholine is acting like a competitive antagonist, like non-depolarizing muscle relaxant.
Non-depolarizing muscle relaxant. Yes, ma'am.
Very good, Mohit. And now we'll come to side effects of succinylcholine. Now, please enumerate what are the side effects of succinylcholine.
Ma'am, the side effect like fasciculations, sinus bradycardia, cardiac arrhythmias, hyperkalemia, increased intraocular pressure, increased intracranial pressure, increased intragastric pressure, masseter spasm, myalgia, malignant hyperthermia, etc.
So we all know that some of the complication like increase intraocular pressure is because of fasciculation. So there are a few methods by which we can decrease fasciculation. Can you please comment on what those methods are?
There are two methods, ma'am: self-teaming and pre-colorization. In self-teaming, we give small dose of succinyl choline before the intubating dose. And in pre-colorization, we give 1/10 of 1/10 dose of the non-depolarizing muscle relaxant 2 to 3 minutes before the intubating dose of succinyl choline.
Okay, very good. And you also said that one of the side effects is hyperkalemia. So in a few conditions, that hyperkalemia gets exaggerated or it may be lethal also. So can you please tell what those conditions are?
Ma'am, hyperkalemia, it may be because of upregulation of the acetylcholine receptors. There are increase in number of the acetylcholine receptor at neuromuscular junction as well as extrajunctionally. When normal nerve signal to a muscle are reduced, muscle increase in number and spread of the acetylcholine receptor. It is a compensatory response.
Okay, so can you please tell some of the conditions in which upregulation of receptors is happening?
Like spinal cord injury, burns, stroke, neuromuscular disease like muscular atrophy, prolonged immobilization like ventilator patient or ICU myopathy, poliomyelitis, etc.
So in burns, do we avoid succinyl choline at all times, or is there a particular duration after burns in which we should avoid?
We avoid succinyl choline from 2 days to 2 years.
Okay, very good. So that was all about depolarizing muscle relaxants. So now we'll come to Dr. Prajeet. Dr. Prajeet, Dr. Mohit has already classified muscle relaxant into two groups, depolarizing and non-depolarizing. So non-depolarizing were further classified into aminosteroidal and benzyl isoquinoline. Can you please tell some of the major differences between aminosteroidal and benzyl isoquinoline group?
Benzyl isoquinoline compounds are more prone to histamine release and they have an organ-independent elimination such as Hoffman elimination and Hester hydrolysis, while aminosteroids are not seen to have histamine release and they have an organ-dependent elimination, ma'am.
So now we'll proceed to individual drugs, but before proceeding, I would like you to comment something about history of muscle relaxants. Can you please tell something about history?
Muscle relax. Yes, ma'am. It was first seen used by South American natives for hunting. They used cuirass in their arrows for muscle relaxation of the animals, ma'am. And the first human experiment was done by Harold Griffith in 1942 for a patient with appendectomy, ma'am.
Yes, very good. So that is when usage of muscle relaxant in anesthesia came into limelight. But before that, some scientists like Benjamin Brody and Claude Bernard used curare in animal studies. So, but the first one is Harold Griffith only, as you said, in 1942. So now we'll proceed to individual drugs. Our first non-depolarizing muscle relaxant is vecuronium. So Dr. Prajeet, can you please pick up the drug and describe it?
Vecuronium comes as vecuronium bromide in a lyophilized vial, ma'am. Each vial contains 4 milligrams in them, and we have to substitute and make it as a solution. The expiry date of it is 10/2027, ma'am.
Okay. And which class of drug is this?
This is a non-depolarizing muscle relaxant of intermediate action, ma'am.
Okay.
And
how
it
much
belongs to aminosteroid group, ma'am.
Okay, very good. And what is the onset of action?
Onset of action is 3 to 4 minutes, ma'am.
And duration of action?
30 to 40 minutes.
Okay, and what is the ED95 dose of vecuronium?
0.04 mg per kg, ma'am.
What is the intubating dose?
0.1 to 0.2 mg per kg, ma'am.
Okay, and how does this drugs get metabolized?
It is 40 to 50% is mainly metabolized by the liver and around 10% is through renal, ma'am.
Okay. And what is the most important side effect of vecuronium for which we should be cautious?
Vecuronium can cause vagolytic actions, ma'am. It can cause bradycardia and hypotension associated with it.
Okay, very good. So now we'll come to our next drug, that is rocuronium. So can you please can you please pick up the vial and describe it?
Yes, ma'am. Rocuronium also comes as rocuronium bromide in a vial with 10 mg per ml constitution. The expiry date is August 2028. ma'am.
Okay. And what is the intubating dose of rocuronium?
Rocuronium has two different intubating doses, ma'am. 0.6 to 1 mg is the usual intubating dose, and it can also be used in rapid sequence intubation with the dose of 1.2 mg per kg.
Okay. And how does onset of action differs when we use these two doses?
Ma'am, using normal intubation such as 0.6 to 1 mg, the intubating time during onset of action comes around 3 to 4 minutes. While using an increased dose of 1.2 mg per kg, it can be reduced to 60 to 90 seconds now.
Okay, so this is self-explanatory why we are using rocuronium in rapid sequence induction and intubation, because its onset is decreasing. Okay, so how does this drug gets metabolized?
It all 70% is metabolized by liver, ma'am, and the active metabolite is 17-desacetyl rocuronium, and the rest around 10% is metabolized through renal.
Okay, and what is the side effect of rocuronium?
Rocuronium is more prone to have anaphylaxis, ma'am, and it also has seen that pain on injection is there.
Okay, very good. So we talked about vecuronium and rocuronium, and you said that both are getting metabolized by liver and kidney. So can you please tell what drugs can be used in patients with liver and kidney dysfunction, which are not getting metabolized by those organs?
Yes, ma'am. Benzyl isoquinolones like atracurium and cisatracurium can be used in patients with liver and renal failure, ma'am. Because they have an organ-independent elimination through Hoffman elimination and ester hydrolysis, ma'am.
Okay, very good. So we'll come to our next drug, that is atracurium. So can you please tell what is the intubating dose of atracurium
0.5 mg per kg, ma'am.
and maintenance dose?
0.1 mg per kg.
Okay, and onset of action?
Onset also 3 to 5 minutes, ma'am.
Yes, similar to vecuronium and vecuronium. And what is the
Yes.
duration of action?
40 to 50 minutes, ma'am.
Okay, and what are the major side effects caused by atracurium?
Atracurium can cause histamine release, ma'am, due to which tachycardia, hypotension, bronchospasm can also occur, ma'am.
Okay, so and what is one another side effect of atracurium? Can you please tell the major one?
Yes, ma'am. It can cause, active metabolite is laudanestine, which can reduce the seizure threshold in humans.
Yes, very good. So can you please name any drug which lacks these side effects caused by atracurium?
Yes, ma'am. Cisatracurium can cause less histamine release due to its higher potency, and the active metabolite is formed also is very less with cisatracurium, ma'am.
Yes, it is 5 times more potent and it causes no histamine release and there's no laudanum production. So that is why it is the preferred drug for infusion in ICU patients also. Okay, so what is the intubating dose of atracurium?
Atracurium is 0.5 to
Atra
ma'am,
you said
0.15 to
Hmm.
yes, ma'am, 0.15 to 0.2 mg, ma'am.
Okay. And
mg per
what
kg.
is the onset of action?
Same as atracurium, ma'am, 3 to 5 minutes.
Okay. And the metabolism you've already talked about for both atra and etc.
Yes.
Okay, so
Yes,
we'll come to our next drug, that is mivacurium. So what are the special characteristics for which we study mivacurium mostly?
Mivacurium is a short-acting benzyl isoquinolone, ma'am. It is metabolized by pseudocholinesterase in the body.
Okay, very good. So that was all about our individual drugs. Can you please enumerate what are the factors which can potentiate the effect of neuromuscular blocking agents?
Ma'am, things like inhalational agents.
जाएगा यही लाएगा लाइक
Good afternoon, ma'am.
Yeah, good afternoon,
Are
Dr.
we audible, ma'am?
Yes, I'm audible. Yes, you're
Ma'am.
audible, Dr. Khile.
Yes, ma'am.
So, good afternoon, sir. So, on behalf of Department of Anesthesia, I would like to extend a warm welcome to you for this Appec course. Sir is a visionary and is a constant source of encouragement to us. Please welcome Dr. Ashok Kumar, Director of ABVMS and Dr. RML Hospital. Sir, I would like you to share a few words of wisdom and encouragement to our delegates. They are postgraduates from all over India. So request you to kindly share your wisdom and knowledge with them.
Yeah, good evening, everyone, and thank you, Dr. Nija, for giving me the opportunity to interact with your student. This program 2025 is the 5th program by your department, and it is very popular among the student. Now, has taken advantage of learning and students for their exam. And again, as I understand, this is the program which simulates the exam environment and all the things which are happening in the exam, like practical, viva voce, and probably case also.
Yes,
in this platform, and students will get real experience how the situation they will face in the exam. Our student also, and it is a popular program and it is a need of the hour for the students, because also the fact that the teaching programs by the departments or by the medical colleges are not uniform at all places. There are some centers of national boards, some centers of universities where the uniformity is not there. So by having these programs from a like our medical college or some other institutions, it gives a student also a uniformity, and they also uh, learn that what is expected in the exam, and how they should prepare or answer in the exam, and what all is expected from them. That is another thing which is important. So I wish you all the best for your exam, and I hope that these programs will give you a more vision about your subject, and you will be able to understand the subject better. And I congratulate Dr. Nirja Banerjee as well as her team, and Dr. Akhilesh is also with me, to him also, that the department is organizing such a wonderful program for the benefit of students. So thank you very much and best of luck.
Thank you, sir, for taking out time from your busy schedule at this hour. And we are really thankful that you appreciate our efforts and are encouraging us at all times. Thank you very much, sir.
Thank you.
thank you.
Yes,
Hello?
madam. Yes, madam.
आप प्लीज जो बाकी बचा हुआ लेक्चर था वो स्टार्ट कर सकते हैं.
Yes,
सर
ma'am.
ने ऑफ हो. हाँ.
Local anesthetic, metabolic acidosis,
बोलो.
hypothermia, hypokalemia,
Hello.
hypocalcemia can all cause from prolongation of action of neuromuscular blocking agents.
So very good, Prajit. So we've discussed about depolarizing and non-depolarizing muscle relaxants. Now we'll come to our next class of drug, that is relaxants. So the first relaxant that we'll discuss is neostigmine. So Dr. Mohit, can you please pick up the vial and describe it?
2-3 साल पहले था ये टॉपिक.
हाँ ये तो मैंने पढ़ा
Yes,
देखा
ma'am.
पर बनाया
The given vial is of neostigmine methyl sulfate. Concentration of the drug is 0.5 milligram per ml. Expiry date is May 2026.
Okay. And what class of drug is this?
It is cholinergic agent, ma'am.
Okay. And can you please tell some other drugs of this class?
Yes, ma'am. Other than neostigmine, there are physiostigmine, hydrophonium, pyridostigmine.
Okay. So what class did you say cholinergic? What is the mechanism of action? Which enzyme does it inhibit?
It inhibits acetylcholine esterase enzyme, ma'am. It competes with the residual molecule of neuromuscular blocking drugs for unoccupied acetylcholine receptor at neuromuscular junction.
Okay. And you must have seen that we always combine one another class of drug with while giving neostigmine. What class of drug is that?
Yes, ma'am. We giving anticholinergic drugs when we give neostigmine, because when neostigmine acts on acetylcholine esterase enzyme, the concentration of acetylcholine enzyme increase at neuromuscular junction, which acts on nicotinic receptor as well as muscarinic receptors. So the unwanted muscarinic effects like bradycardia, salivation, bronchospasm caused by neostigmine counteract by the anticholinergic drug like glycopyrrolate or atropine.
Okay. But why do we generally use glycopyrrolate more often than atropine?
Because, ma'am, the onset of action and the duration of neostigmine and glycopyrrolate is similar. That's why we are use glycopyrrolate.
Okay. And what is the dose of neostigmine?
From 30 to 75 microgram per kg body weight.
Okay. And can you please tell what ceiling effect is?
Ma'am, ceiling effect is increasing the drug dose beyond a certain point. Does not change or increase the desired effect. It is the ceiling effect.
So that was all about anticholinesterase class of drug. Now we'll come to our next reversal agent, that is Sugama-dex. So Dr. Pradeep will come back to you. Can you please tell what Sugama-dex is? What is the structure of Sugama-dex?
Yes, ma'am. Sugama-dex is a gamma cyclodextrin, ma'am. The gamma cyclodextrin forms a 8-membered ring such that there is a central lipophilic cavity, ma'am. This lipophilic cavity can bind to aminosteroidal compounds and cause reversal of neuromuscular blocking agents.
Okay. And
Sugama-dex is a Sugama-dex is a biologically inactive compound, ma'am, which binds to rocuronium, vecuronium, and pancuronium. More affinity towards rocuronium than to vecuronium, then least to pancuronium in a 1:1 ratio, ma'am, and it is excreted as it is, ma'am.
Okay, so it is excreted as it is without any further metabolism. And what is the dose of Sugama-dex?
Ma'am, Sugama-dex can be given in different doses, ma'am. For moderate blockades, we can give it as 2 mg per kg. For deeper blockades, we can use 4 mg per kg. And for immediate reversal after just administering rocuronium, we can use Sugama-dex in 16 mg per kg dose, ma'am.
Okay, so we can say for intense blockade, we can use dose of 16 milligram per kg. Okay, and what is the one major side effect of Sugama-dex?
It has been major anaphylaxis as reported with Sugama-dex, ma'am.
Okay, so anaphylaxis. So that is why while giving Sugama-dex, we should always be prepared for anaphylaxis. Okay, so
Yes,
I must say Dr. Mohit and Dr. Pradeep, both of you have answered very well. And this was for everyone to understand how your Viva may proceed during examination. So this is how we'll conclude our session. All the best to both of you.
Thank you, ma'am.
Thank you.
Thank you so much, Dr. Nidhi Pathak. So that's it for day 5 of Appec. Before winding up, just for the delegates, Google link has been activated in your groups. One is the feedback form and other is the quiz. 10 MCQs are there, and the first 2 winners to reply all the answers correctly will be awarded. And that's it for today. Thank you and have a very nice day. Good day. Bye-bye.